for epilepsy following following stroke for the past 2 years. Though he has been seizure-free, currently he has developed intermittent dysarthria, dysphagia, along with bilateral nystagmus, intentional tremor, and central ataxia. CT scan of her head showed no change from the previous scan. So the treating physician suspected of phenytoin toxicity and reported for serum phenytoin concentration, but found the suspect reported phenytoin concentration. Hello?
Yes, ma'am.
Yes, ma'am.
Yes, ma'am, we can see that.
Ma'am, just make it full screen.
Omita, kindly follow.
Sure. Yes, yes. Slides are moving.
Am I audible?
Yes, ma'am, you are audible.
Yeah, okay, sure. Thank you.
Good morning, all the respected delegates, faculties who were present today in the second annual conference of Association of Clinical Pharmacologists in India. So from Kolkata, we are really privileged to host you all. Welcome all the online delegates, and we'll start today's session with a very interesting workshop on therapeutic drug monitoring. And we are really privileged to have Professor Smita Pattanaik Madam with us. She is the course director for this particular workshop. And may I request Professor Shantanu Kumar Tripathi to felicitate Madam, and we'll start the workshop straight away. Madam, please.
It's a great privilege to welcome Professor Smita Pattanaik, who needs no introduction, and she will be the course director of this particular symposium on therapeutic drug monitoring. And she is a professor at PGI MER Chandigarh. And welcome, Dr. Pattanaik. So now the stage is yours.
So I welcome you all to this symposium. At the outset, I would like to thank the organizing team, especially Dr. Shambo, to invite and keep this as an introductory thing. I wish there would have been more participants, but I am really thankful to my online participants who are present to hear this. And I also sincerely thank Dr. Sandhya and Dr. Sumit Matthew from CMC Velo, Dr. Sandhya from JIPMER, who kindly accepted my proposal and also have consented to present in this symposium. And the purpose of this symposium is nothing but to hear from the experts, those people who are doing the TDM in the respective therapeutic areas. And this is definitely a very basic and preliminary kind of a work that preliminary kind of information that would be provided to the participants in terms of the level of complicatedness we would try to avoid, or we would try to avoid the other issues. We'll try to do the basics mostly. And people will share their experience, and you're welcome to ask questions. Please ask questions. That's my request to you, so that we want to make it as an interactive thing. And this is the so I had the PDF document.
Can you please, Klarnet, please let us enable to share the screen first from this conference room. Yeah. Sir.
Basically, we will I hope everyone is able to see this. So this is the schedule of presentation. First, Dr. Sandhya will take on the anti-epileptic drug, and we are all set. We have welcomed her already, and she's here to join from JIPMER. Then I would give a brief overview. Good morning, Dr. Sandhya.
Good morning, madam.
Ma'am, hello.
Yes, yes.
Yeah, ma'am, please try to increase the volume. Actually, it's too low.
From my side.
Yes.
Okay.
Sound is coming properly, but it's too slow. So just need to increase the volume.
Okay. Is it better?
Yes, ma'am. Absolutely.
Okay, wonderful.
Thank you.
Okay, so next we will be having the TDM of immunosuppressant drugs, and though CMC Vellore has the maximum sort of, I can say that experience, but Dr. Sumit Matthew would be presenting the TDM of antimicrobials, and we will be taking on the TDM of immunosuppressant drugs. Now, in the end,
Professor Tripathi will sort of give us a overview that why TDM has not picked up the way it should have picked up in this era, in the sense that India is no more considered a developing country. You might all know that, because there is a lot of development in other areas of science, but somehow TDM has lagged behind. So Dr. Tripathi will take us through the reasons or the constraints that TDM is currently facing in this country. And in the end, we will have a short panel discussion, kind of a thing, where we would take up your questions and also try to understand what all we can do to make the status of TDM better in our country. So without much delay, let me invite Dr. Sandhya. Dr. Sandhya is an additional professor in the Department of Clinical Pharmacology at Jawaharlal Nehru Postgraduate Institute of Medical Education and Research, JIPMER, we fondly call it as JIPMER Puducherry, and she will take us through her journey of anti-epileptic drug TDM. She has many other accolades to share. She heads a lot of committees in JIPMER. She is into the administrative committees. She is into the ethics committee, and she runs a very active clinical pharmacology program at JIPMER. So Dr. Sandhya, over to you. We are eager to listen to your presentation. Thank you.
Thank you, madam. Thanks for the introduction. Just a few seconds. I'll share my screen once again.
Yeah. Unshare, right? Yeah. That she can share. Yes. Wonderful. I think she can share now, right?
Is my screen visible?
Yes, Dr. Sandhya. Yeah.
Okay. Yeah.
Yes, ma'am.
So at the outset, I would like to thank the organizing committee, Dr. Shantanu Tripathi, Dr. Shambo, and the director of this symposium on TDM, Dr. Smita, for giving me this opportunity to be one of the resource persons and give a lecture on therapeutic drug monitoring of anti-epileptic drugs. So for the need of better internet connectivity, I will just switch off my video while I start my presentation, and I will join back at the end of my presentation. So moving on to my topic, in the next 40 to 50 minutes, I'll be giving you an introduction to TDM, the various indications and the drugs requiring TDM, the clinical application of TDM, especially with respect to my topic, that is anti-epileptic drugs, and how do we do TDM in special population when they take anti-epileptic drugs, the use of pharmacogenomic knowledge to decide the dose, and the recent advances in TDM. So moving on to the first slide of my talk, let me start with a case scenario. A 87-year-old man came with a 1-week history of feeling uneasy with unsteady gait and episodic confusion. He was on phenytoin for epilepsy for the last 2 years, which occurred after stroke. However, he has been seizure-free for the last 2 years. But currently, he has developed intermittent dysarthria and dysphagia along with bilateral nystagmus, intentional tremor, and ataxia. When a repeat CT scan was taken, it did not show any change from the previous CT scan of the head. So the treating physician suspected phenytoin toxicity and asked for phenytoin concentration. But however, the TDM showed the phenytoin concentration is within the normal range of 10 to 20 microgram per ml. It was within range. The concentration was 18 microgram per ml. So now there's a confusion. When the plasma concentration of phenytoin is within the normal range, why is showing features of phenytoin toxicity? What could be the cause leading to this presentation, and how the patient should be treated? So the answer to this scenario is available somewhere down the slides while I present my topic. So with this, let us move on to what is TDM and what are the uses of TDM. Okay, what is TDM? In simple definition, it is nothing but measurement of drug level to decide the dose of a drug for an individual patient. So when we give drug to an individual patient, after some time collect the blood sample and see the concentration of the drug in the plasma or serum, and then see whether it is within the therapeutic range and should we change the dose or keep the same dose to the patient while we decide the next dose. So this is the basis of therapeutic drug monitoring. So why we have to do this and for what kind of drugs we will do TDM? We will do TDM only for those drugs which have got a definite relationship between dose of the drug, the plasma concentration of the drug and pharmacodynamic effects. If all three factors have some association between them, then only we can do TDM. A drug should have association between its dose and the pharmacodynamic effects. So assuming when we give a drug, after it reaches a particular concentration in the plasma, that is known as the therapeutic range. If it produces therapeutic response within that range, then we just want to check whether the plasma concentration is within this range or above the range, which can cause toxicity, or below the range, which is not effective. With this knowledge, we can adjust the dose to maintain the plasma concentration of the drug to be within this targeted therapeutic range, so the patient does not experience either toxicity or treatment failure. So the very basis of TDM is based on the assumption that there is an association between the dose given, the plasma concentration of the drug achieved, and the pharmacodynamic effect it produces. So can we do TDM for all the drugs? Can we measure the plasma concentration and adjust the dose for all the drugs? No, that's not possible. Only for few drugs we can do TDM. So what are those drugs? What are the indications? Those drugs which have got narrow therapeutic index, zero order kinetics, which show wide variation in the metabolism of the drug, drugs which undergo lots of interaction when multiple drugs are given, in patients with hepatic or renal impairment, if the particular impairment is known to affect the metabolism of the drug or elimination of the drug, in the presence of poorly defined clinical endpoint, or if there is treatment failure. In these if there are these indications, then we can do TDM for such a drug. Sometimes we also do TDM to find out the adherence of the patient to the treatment. Okay, so usually if you look at the drugs requiring TDM, anti-epileptic drugs, immunosuppressants, mood stabilizer like lithium, antiarrhythmics like amiodarone, digoxin, aminoglycosides, and some of the antibiotics are the drugs which require TDM, which will be covered by subsequent speakers. So let me focus on my topic, anti-epileptic drugs. So most of the time TDM is done for the commonly used anti-epileptic drugs in our setup like phenytoin, phenobarbital, carbamazepine, valproate, etc. So why do we do TDM for these anti-epileptic drugs? Now coming back to the indications for TDM. So drug like phenytoin has a narrow therapeutic index. It follows saturation kinetics. After a particular level, it starts, initially it follows for first order kinetics, but after a particular concentration, it starts following zero order kinetics. So we don't know how much will be cleared, how much will be eliminated. And drugs like phenobarbital, carbamazepine, and valproate, they can show wide variation in their metabolism. And these drugs have drug-inducing and drug-inhibiting properties, so there can be lots of drug interactions when they are taken with other drugs. And if the patient happens to have hepatic impairment, again, most of these drugs which are metabolized in the liver may have a different effect. And epilepsy, as we all know, has a poorly defined clinical endpoint. We don't know when do we say the patient is treated. Like, for example, how seizure-free period for how long can be considered as the patient has come out of seizures, or if a seizure occurs, if it is due to the disease or if it is due to treatment failure. It is very difficult to decide. when seizure occurs in a patient after a long time, after a long seizure-free period. So the anti-epileptic drugs fits into all the criteria for doing therapeutic drug monitoring. That's why we do therapeutic drug monitoring for anti-epileptic drugs. Also to ensure adherence to the treatment, because most of these patients, since this is a chronic treatment, if there is seizure-free period for a long time, these patients tend to stop taking the drugs by themselves, which is not good for them. So to check adherence also, sometimes TDM is done in these patients. Okay, now how do we do? We have let us say we have patients who are taking anti-epileptic drugs, but then how do we do TDM? So the most important thing for TDM is doing a sample collection. We need to collect the blood sample for doing TDM. So when do we take blood sample? Can we take blood sample immediately after taking the first dose or second dose or third dose? We have to wait till the patient reaches the steady state. Not only for anti-epileptic drugs, for any drug for that matter, TDM can be done only after the steady state level is reached. So depending on the off-life of the drug, we need to wait for 4 to 5 off-lives for the patient to reach steady state, so that we can collect blood sample for doing TDM. If the loading dose is given to achieve the steady state, then we can do TDM immediately also. So which level to be taken, trough level or the peak level? So for knowing the treatment efficacy as well as adherence, trough levels are preferred over the peak levels. What is trough level? Trough level is nothing but taking the blood sample just before the next dose. So this will help us to know whether the patient's drug concentration is within the therapeutic range. So let me show this with the help of this graph. So once the patient has reached the steady state concentration after the drugs are given for 4 to 5 off-life, then there is a particular therapeutic range within which the plasma concentration will be maintained. So before the next dose, just before taking the next dose, if we take the sample, then we will be able to know whether this is within the effective concentration. So when do we take peak level? So if we suspect toxicity, then we can take peak level. But if the patient is already in so much of toxic symptoms, he has come with toxic features, we can take sample at any time. So generally, we do trough level plasma concentration measurement for assessing adherence or treatment failure. Okay, after collecting the samples, what do? We go for analytical methods. We can analyze the plasma concentration of the drug using any of the equipments like HPLC, ultra performance liquid chromatography, UPLC, or LCMS-MS, or even using spectrophotometry or fluorimetry. We also have got multi-drug analyzers like tabletop multi-drug analyzers, where using kits we can analyze few samples. So depending upon the availability of the equipment in a particular institute, we can choose any of these methods for analyzing the plasma concentration of the drug. So while doing this analytical analysis, what are the issues which can arise? We have to be very sure the accuracy, precision, reproducibility, repeatability, and robustness of the method which we follow is good, so that we can ensure the quality of the results. Though most of our labs don't go for laboratory accreditation, it's always better to have accreditation, though it's an ideal requirement. Having a laboratory accreditation is always good to ensure that whatever results we are giving is accurate and dependable. Okay, now after analysis, what do we find? We find out concentration of the drug. So this table shows the therapeutic range for drugs like phenytoin, carbamazepine, phenobarbital, and valproate. So if the plasma concentration of the drug in the patient is within this range, then we consider the patient is having normal range, is less likely to develop toxicity or treatment failure. So that is the conclusion from the therapeutic concentration. So in our lab, we have HPLC, LCMS, as well as UPLC. Initially, maybe around 10 years before, we were using HPLC for measuring all the anti-epileptic drugs. Right now, we are using LCMS for measuring valproate and immunosuppressants, and UPLC for measuring phenytoin, phenobarbital, and carbamazepine. So as I already said, depending on our feasibility and the availability of the equipment, we can choose any of the equipments. Or if we can't spend so much money, we also have small multi-drug analyzers, where we can do samples, for a few samples using kits for saving time as well as money. Okay, so this is our requisition form. So the physician who asks for TDM has to fill this form. They have to mention, I don't know whether you are able to see this properly. So the patient's name, diagnosis, which drug they are taking, what's the drug history, when the treatment started, when was the last dose given, what do they need this test for, when the sample, is it for toxicity or treatment failure or adherence, when the sample should be collected, should it be at trough or peak level. So all these queries will be there in the requisition form. Though most of the time this will not be filled completely, but generally at least 90% will be filled properly. So this is the report form. Once the results are ready, the report will be given in this report form with the standard normal range. And here the values what I find from the analysis will be given. And this is also mentioned at the end. The therapeutic ranges are given in parentheses. However, it varies depending upon the diagnosis and clinical condition of the patient. So the clinician has to correlate the concentration with the clinical condition of the patient. Okay, so if we look at the monthly reporting of TDM on anti-epileptic drugs in 2022 in JIPMER, we had a total of approximately around 150, including phenytoin, phenobarbital, carbamazepine, valproate, with more TDM for valproate. Actually, this is less as compared to the previous year, 2021 and before 2020, as compared to the values before 2020, this was less. Probably the 2023 values, when we check, we might have got the values which we used to get before 2020. Okay, now having said this, so what are the applications of TDM? As I already mentioned, this is mainly for individualizing the therapy before initiating the therapy, or after initiating the therapy. If you want to change the dose, again, we need to do TDM to see whether the plasma concentration is maintained within the therapeutic range, to avoid toxicity, to monitor adherence, and whenever seizure occurs, to see whether it is due to treatment failure or is it because of the disease. Also to monitor drug interactions if the patient is on multiple drugs, especially if they are on ATP or some other drugs which are known to interact with anti-epileptic drugs. Okay, having said all these things, apart from whatever factors I have mentioned, the plasma concentration of the drug may also be influenced by other factors, like one is drug interaction, the other one is if you look at the pharmacodynamic variability, it could be due to variations at the drug receptor level, genetic factors, or development of tolerance to the drug. So in these conditions, how do we use the TDM value? How do we proceed about with deciding the dose? So there is also a concept called a priori TDM. What is this a priori TDM? So here we identify the subpopulations of patients with different dosage requirements from their from the demographic data and other pharmacogenetic characteristics which are available in the literature or from our previous study. For example, if what should be the initial dose for patients with hepatic impairment, or what should be the initial dose in children below 6 years or 5 years. So identify subpopulations and try to find out the dosage requirement using population PKPD models. So we can determine the initial dose based on the available data using population PKPD models, and then start the initial dose. That's the a priori TDM. So we do some sort of analysis even before giving the first dose, and then give the dose and see whether this is within the therapeutic range. Okay, so what are these special populations? One is children. As I already mentioned, the clearance of anti-epileptic drugs is different in children as compared to the adults. The clearance is very high, resulting in less elimination of life, especially in children between 6 months to 6 years of age. As a result, they require a higher dose as compared to the older children, adolescents, and adults. In this condition, TDM plays a major role in maintaining the therapeutic range, and a priori TDM plays a major role in predicting the optimal therapeutic doses for this group. Similarly, for patients with hepatic impairment, most of these anti-epileptic drugs are highly bound to serum albumin, and this hepatic impairment can lead to reduced serum albumin, resulting in elevated free concentration of the anti-epileptic drugs, which could lead to toxicity. Though we do the plasma concentration of the drug, it may be within the therapeutic range because this is the total concentration. But if we measure the free level may be high in these kind of patients. This is like this partially answers the scenario which I had shown in the first slide of my talk. So there also the old man had presented with the features of phenytoin toxicity, but the TDM showed phenytoin concentration within the normal range, that is 18. It was well within 10 to 20 microgram per ml. It was 18 microgram per ml. So they were not able to decide whether it is due to toxicity or some other reason. But if the history of that the person was looked back, he was he was not feeling well. He was having dysphagia for the last few days. So this could have resulted in his this undernourishment could have resulted in low albumin level. So if the albumin level was checked, the albumin level was found to be low. So again, the free level of phenytoin was done, and it was found to be high, which described why he was showing phenytoin toxicity. It was because of low albumin level, free phenytoin concentration was high, and this resulted in phenytoin toxicity. So sometimes even if the therapeutic concentration, if the concentration is within the therapeutic range, we need to be we need to be looking for other factors which could be responsible for causing the toxicity. Similarly, one more thing which we should keep in mind is use of alternate system of medicine. One of the systematic reviews has found out that South Asians use alternate system of medicine more than any other population. So one of the interesting studies from KEM long back in 1992 has found that 2 cases of generalized tonic-clonic seizures with well-controlled serum phenytoin levels suddenly showed seizures after seizure-free interval. So upon taking history, they found that both these patients were taking an alternative Ayurvedic preparation called Shankapushpi, which is also known to have anti-epileptic effect. Subsequently, they have done animal studies in rat and found that with one dose of Shankapushpi, nothing happens. But when multiple doses of Shankapushpi is taken, it reduces the phenytoin concentration, leading to treatment failure of phenytoin. So it also has an anti-epileptic effect. It has got some sort of drug interaction with phenytoin, and hence clinical combination of this drug SRC is Shankapushpi has to be avoided. And the patient should be advised not to take alternative medicine when they are taking these anti-epileptic drugs, because this could lead to drug interaction, unknown drug interactions which are not documented in the literature. So we also need to look at these factors. So what are the practical issues which we come across while doing TDM? So whenever the sample is sent for TDM, the physicians expect the value to be given at least within 24 hours of giving the sample, because it plays a major role in clinical decision making. However, there are few difficulties like feasibility issues in giving the results immediately. For example, even in our setup, it will take around 2 to 3 days depending on the availability of the sample. If more samples are there, then the results will be available on the same day. But if only 2-3 samples are there, then they will wait at least for some 7 to 8 samples to be collected. This is mainly to avoid wasting the machine run and consumables. So it depends. If we get more samples, the results will be given immediately. If the samples are less, then they have to wait. So this is some of the practical issues which we face in our setup. Apart from that, we also should keep in mind the reason for variation in therapeutic range could also be due to the genetic polymorphisms involved. Even though the patient is taking the drug properly, even though the dose given to him was appropriate, if there are few genetic polymorphisms, they may have an effect on this plasma concentration. So some of the studies, let me show some of the studies done from our own center. So this study, which was done to see the effect of CYP2C9 genetic polymorphism and undernourishment on free phenytoin concentration in epileptic patients, found out both undernourishment as well as CYP2C9 allele variant elevate the free phenytoin concentrations individually as well as in combination. And this additive effect of increasing free phenytoin level has can cause phenytoin toxicity with an odds ratio of 37.3. It's quite high. When both undernourishment and CYP2C9 allelic variant were combined, the odds ratio for developing phenytoin toxicity was found to be very high. Similarly, one more interesting finding was like the effect of NAD2 gene polymorphism on phenytoin toxicity. This study found out when these anti-epileptic drugs are given with anti-tubercular drugs, INH, which causes minimum inhibition of CYP2C9 enzyme, the CYP2C9 enzyme is one of the primary metabolizing enzyme of phenytoin. But however, in some of the patients, they found out this INH-induced phenytoin toxicity was not due to the involvement of CYP2C9 enzyme, which is involved in metabolizing phenytoin, but it was due to inhibition of CYP2C19 enzymes, which is in the alternative pathway of metabolizing phenytoin when the phenytoin level exceeds 10 microgram per ml. So this study found out that NAD2 gene polymorphism results in increased phenytoin level. As a result, phenytoin follows saturation kinetics, leading to phenytoin toxicity. So this study found the plasma phenytoin level was more than 15 microgram per ml in all patients with phenytoin toxicity, suggesting saturation kinetics of phenytoin due to the indirect effect of NAD2 polymorphic gene polymorphism. So when we don't find any reason for toxicity, even if the drug level is within the normal range, normal therapeutic range, then these polymorphisms also could be looked for. Though in our research over setup, it's not always possible to see the genetic polymorphisms and their effect on therapeutic range. But if we have the facility, it is always good to look for the genetic polymorphisms also. Okay, so now moving on to the recent advances in TDM. What are all the recent advances? How do we assess the plasma concentration of the drug, especially phenytoin? There is an interesting concept from your PhD thesis called microdialysis. In microdialysis, what did they do? They use the principle of dialysis for measuring drug concentration from brain tissues. So the concept is any substance present in high concentration in the brain's interstitial tissue diffuse into the dialysis perfusion fluid, and this perfusate known as microdialysis can be collected to assess the concentration of phenytoin in the brain. So how do they do it? They use a microdialysis catheter. So it can be inserted into the, it can be inserted to collect the perfusate from the brain interstitial tissue, and this can be done as a bedside therapeutic drug monitoring to measure the phenytoin level. So the advantages of this is the drug concentration in this compartment does not vary. We can do continuous sampling and any number of samples can be collected, and unlike our blood samples, sampling is very fast, and we can do the analysis within a short time and dose can be adjusted. Usually here the collection time is between 10 to 12 minutes for 20 to 25 microliter sample value. So we can decide the concentration of the drug in the brain and decide on the dose accordingly. But the disadvantages are it is a very intensive process, time consuming. A skilled person has to be dedicatedly present in the scenario to measure the drug level at frequent intervals. Other methods of collecting blood other than collecting the usual blood sample is like dried matrix microsampling, where we can take either dried blood spot, dried plasma spot, dried serum spot, or volumetric absorptive microsampling. The advantages of this dried matrix microsampling is less volume is sufficient. With finger prick blood, we can go for dried blood spot, and this can be even done by the patient themselves in their house, and they can give the dried blood spot for analysis to the lab. And another easy method of collecting the blood sample is capillary microsampling. So the advantages are they are easy to do. No need for any technical person to draw the blood from the patients. The patient themselves can pick the blood from the fingertip, and the samples can be transported to the lab. But it also has its own disadvantages. Like we cannot repeat the test because the quantity of blood sample available is very less. And sometimes there is difference between the capillary blood concentration and the venous blood concentration. So how much we should go for is it to be answered properly through studies. And one more recent advances is biosensor based TDM. So here we use the principle of biosensor. So the difference in the physical and chemical properties due to interaction between the drug analyte and biological element, that is a blood sample, is used to get a signal which can be amplified to find out the concentration of the analyte to be analyzed. However, again, this biosensor is yet in the development stage. Though few studies say that biosensor prove itself to be more effective in the integration of TDM clinic because they give values within few minutes. So in the coming days, we may be seeing lots of advances in the technology to collect blood samples as well as to process the blood samples and to get the results. Okay, so far I have been telling so much about indications for TDM. What are the applications of TDM? So what are the contraindications for TDM? It's just the opposite of the indications for TDM. So if we have a measurable clinical endpoint, then we don't have to do TDM. For example, antihypertensive drugs or anti-diabetic drugs, where we can give the drug and measure its effect by recording the blood pressure or by measuring the blood glucose level, there we don't have to do TDM. Similarly, drugs with wide therapeutic range, which can be used, for example, amlodipine, which can be used from 2.5 milligram to 10 milligram. So like for these kind of drugs, we don't have to go for TDM. Hit and run drugs like omeprazole, like where drugs produce the effect even after they leave the body by inhibiting some enzymes permanently or irreversibly, and where the enzymes take time to get synthesized newly. So in these conditions, even if we look at even if there is no serum concentration of the particular drug, it will be having its effect. So no need to do TDM for such drugs. Then prodrugs which produce active metabolites, and the active metabolite also has got some action, and the off-life of prodrug and the active metabolite is different. In these conditions, doing TDM will not give you a fruitful outcome. So in these conditions, we can avoid TDM. So who all should be involved in doing TDM? So TDM cannot be done by a single person. It has to be a team. If TDM should be really useful in patient care for taking a decision on changing the dose to the appropriate required dose, then it needs to be a multidisciplinary approach between the clinicians, clinical pharmacologists, as well as the technicians and nurses who are all involved in collecting blood samples, processing the blood sample, reporting to the patients. So all of them should work as a team and discuss all the queries related to the value and take an appropriate decision, then only TDM will be a successful thing. So what is the role of clinicians in TDM? They have a major role. They are the one who suspect it could be treatment failure or toxicity and send the samples. But they have to keep in mind when they send the samples, they also should know what are they looking for and what sample needs to be taken and what instructions needs to be given to the patient. So that when they come to the lab, the proper sample is taken and appropriate results are given to the clinicians. And after getting the results, the clinicians should also interpret it accordingly. Even if the plasma concentration is within the normal therapeutic range, if the patient is showing some toxic features, then they should look for other things. For example, like measuring albumin level, asking for free drug level. So those things are very essential for the clinicians to ask for, and they should also be knowing about these factors and counsel the patient properly with respect to adherence. And when they send the patients to the lab to give sample, they should fill the form with all the relevant history of the patient. So what is the future scope for TDM? As we all know, TDM has not taken up much in many of the institutes. Wherever it is, even wherever it is happening, it is not at a full-fledged level. This is due to many issues like financial issues, like getting consumables, equipments, and if the equipment gets repaired, like how do we repair it, how much time it takes. So all those things has its implication on doing TDM. So if we really want to introduce TDM in our institutes, we need to conduct awareness programs through conferences or lectures or by distributing newsletters to produce awareness among the administration as well as the clinicians to bring about the significance of doing TDM. And we should always go and interact with the clinicians and tell them the importance of doing TDM in certain drugs. And our lab should be providing accurate results so that the clinicians depend upon our value and trust our value. And in future, we this is an era of artificial intelligence, and there are so much scope for coming out with lots of software which can maybe deciding the next dose for the patient depending on the present therapeutic range. So to summarize, TDM is a very simple thing of measuring the blood concentration of the drug after giving the drug and then seeing whether it is in the therapeutic range to decide whether this drug will produce efficacy. Also, this is done to avoid toxicity or in the presence of toxic features to find out if it is above the therapeutic range, as well as to determine if the patient is taking the drug properly, if the patient is adhering to the treatment. These are the three major indications for which TDM is done. And we have got various procedures depending upon the institute's facility. And as far as our institute is concerned, it's regularly done in pharmacology department for anti-epileptic drugs as well as immunosuppressants like tacrolimus and cyclosporine. So I would take the opportunity to thank Dr. Manikandan, the professor and head department of pharmacology, for helping me to get the details from the lab, and Mr. Rajan and Mr. Tamirsi, the senior lab, who compiling the data and shared it with me, and Dr. Shravan and Dr. Ilan, senior residents from my department, for helping me for getting the information for this topic. So with this, I will stop and ask for queries. I'll be happy to take queries if you have any.
Yeah, thank you, Dr. Sandhya. That was really an extensive and elaborate talk on the TDM of anti-epileptics. Any questions from the audience? Online or offline? Okay, so Dr. Sandhya, if you can go back and show the slide on the example, that's what Dr. Tripathi has requested.
I'll show. Just a minute.
And in the meantime, Dhaneria sir, if you have anything to add, we will be happy to listen to you. So Dr. S.P. Dhaneria is here with us from with Dr. Qurashi from J&K. So we really welcome you, and if you have anything to add, please feel free to add in this session. Every experience is important and every experience is worth learning from. In the meantime, let me take the opportunity to introduce Dr. Sumit. Dr. Sumit Matthew is from CMC Vellore. I requested him to join and contribute to the discussion if possible.
Thank you for inviting me, Dr. Smita. Thank you.
Pleasure, Dr. Sumit. Your session is next to mine. I just
Yeah.
thought that let me introduce your and acknowledge your presence. Thank you so much.
Thanks.
Madam, which example slide, madam?
Which example, sir?
First slide.
First slide.
First few.
Okay. The case scenario, sir. Okay. Yes, sir.
Yes, this 18 microgram per ml phenytoin.
Yes, sir.
So how did you actually finally got the answer to this? That was the
Yeah. I had not given that one value, that albumin. Then subsequent to this, its albumin level was measured, and it was found to be 24. And then I asked for the free phenytoin concentration, but we were not able to do free phenytoin concentration at that time. But then still, because the albumin level was low, it was suspected free phenytoin must have been high. That could have been the reason for phenytoin toxicity, and the dose was reduced. Subsequently, the patient became alright.
So, but here the phenytoin range was well within the normal.
Well within the normal range, but the albumin level was lesser. He was not feeling well for the last 1 week, and he was having dysphagia. So probably he was not taking food properly. Some sort of undernourishment must have led to this low albumin level. All other parameters were normal. Complete hemogram and other routine biochemistry parameters. Only albumin level was low. But however, free phenytoin concentration could not be measured for this patient. But then based on low albumin level, it was suspected it could have been phenytoin toxicity, and the dose was reduced for. Subsequently, he became all right.
Madam, this phenytoin level, 80 microgram per ml,
Yes.
That is not corrected with the serum albumin. You mean to say?
Pardon?
No, this the phenytoin concentration was 18 microgram per ml.
Yes.
That was not corrected with the serum albumin level. That's why it is low, but the free level you say it's 24 microgram per ml. Is it so? We have to correct this with the serum albumin.
Madam, can you just, I was not able to hear. Madam,
Yeah,
can you please
so-
repeat the question?
So, sir wants to add that this 18 microgram per ml, the 18 microgram per ml, which is been written here, this
Yes.
is not the corrected phenytoin level.
Yes, this is not the correct. This is the total phenytoin
Right.
level. This is not the free phenytoin level. That's what I am trying to say. We were not able to do free phenytoin level.
Right.
After getting this 18 microgram per ml, the physician suspected, then they checked for albumin level, and when the albumin level was low, they asked for free phenytoin level. But we were not able to measure free phenytoin level at that time. This was some 10 years before, when we were not able to measure free phenytoin level, so could not be measured. But however, they thought this could be due to reduced albumin. Free phenytoin level may be high. So empirically, they reduced the phenytoin dose, and subsequently he became all right.
So I would like to reframe it for the residents, whoever is listening to this. So the phenytoin therapeutic concentration is between 10 to 20 microgram per ml. Now, we know very well that phenytoin is 90% plasma protein bound. So the free drug that is available to us is 1 to 2 microgram per ml. Now, from the basic pharmacological concept, we know that the pre-drug is the fraction which is important and responsible for the therapeutic action. The bound form actually behaves as a reservoir. And as and when the drug dissociates and becomes a pre-drug, it is available for action, right? So in this case, since it is 18, you would presume that there would be around 1.8 to 2 point something, 2.6 or 3.6 should be the concentration. But here the catch here is, if the phenytoin is more than 90% bound and you have less than 2.5 milligrams per deciliter of albumin, there would be much more phenytoin available as preform. And this preform is responsible for all this CNS effect this patient was demonstrating, right? And therefore, like Madam said, in the form, there are several details. Sometimes the forms are not adequately filled. If you see a level of 18 and the patient is showing you signs of toxicity, you will be confused. It's all good. But you have to ask proactively, what is the serum albumin concentration in this patient?
So I think here lies the importance of interpretation and the comment from the clinical problem.
Absolutely.
In this particular case, okay, although the phenytoin estimation system was not available at that point of time, but if it comes from a clinical pharmacologist desk that this is the possible reason, clinical reasoning, then that can assure the clinical.
Absolutely, sir. So pre-phenytoin estimation is a very tedious process. You need to do the microdialysis. You have to keep the sample incubated overnight, and then you need a very sensitive method to go back and detect that 0.01 to 0.4 microgram per ml. Our systems, the HPLCs, are good at 1 microgram to, let's say, 50-60 micrograms. So therefore, we don't perform the pre-phenytoin concentration unless the albumin is low. We assume that it is the total drug concentration which will guide us to decide the therapeutic range.
I think we need to appreciate that why this particular case was sent for review. Okay, the problem was it was in that apparently normal range.
So the clinical signs and
clinical
symptom of toxicity.
Absolutely. The clinical was seeing toxicity of phenytoin, while the apparently was a normal range. So that is the reason they had sent.
Correct.
So when it was done, the phenytoin estimation was done, it was found to be 18. Then the interpretation, clinical pharmacological approximation and execution, that should go. Okay, that's why it is again and again say it's not just measuring, but also the monitoring. The monitoring is actually and proper report, okay, from the clinical
Okay. So we'll move on, sir. There's one question in the chat box. How do you do TDM on biologics? Dr. Satyavrata Sahu.
Yeah. So as such, right now we are not doing the TDM of biologics. As I already mentioned, we are doing TDM of anti-epileptic drugs and immunosuppressants, namely tacrolimus and cyclosporine. We have restricted to this thing only, and this itself takes most of the time of the lab. Weekly twice it is for tacrolimus and cyclosporine, and once for anti-epileptics. Tacrolimus will be done on the same day because these are renal transplant patients, and the dose has to be modified accordingly within a day because the patient comes from different places for just doing this TDM. So this will be done on the same day, whereas for anti-epileptic drugs, they will wait for the samples to collect some 10 samples to run one HPLC or UPLC. So it takes some time. We have not entered into the TDM of biologics as of now.
Right.
As such, I don't have experience on commenting.
Nor do we have experience, but being a part of this International Association of Therapeutic Drug Monitoring and Toxicology, I get to hear from my colleagues there about the etanercept and other drugs. Apparently, some of the inflammatory bowel disease patients, they have found that this is really determining the response. But to the best of my knowledge, I haven't seen any of, I haven't come across any department doing it in India, but anybody can correct me if it is being done in India.
Thank you for the question. Basically, I would like to comment on this and the
Sure,
previous
please.
question regarding the phenytoin. So one is the availability of TDM for biologics. It is available in India. It is available. Whether people are using it is a different question, but it's available in India. So there are two ways of doing biologics TDM. One is the easiest way is by using ELISA methods. So for example, immunoassay methods. So immunoassay kits are available in India, which we can actually use it for TDM of biologics. The second option is LCMS, but LCMS is a more tedious procedure where you have to digest the big biological molecule, and only a small part, which is the key for that. So basically a small part of it, peptide chain, will be analyzed. But that is a tedious procedure in MS. So the easiest way to do monitoring of biologics is by doing immunoassay kit method. Now, the previous question about the phenytoin, I would like to address here the important reason why we pharmacologists are supposed to play a role in doing TDM. So here we have a procedure room in CMC Vellore where we actually do procedures related to TDM. We have to collect a lot of information before you actually take a sample. So in the example of phenytoin or rifampicin, one important information that you need to collect even before doing the analysis is you have to see the albumin. Okay, so if you actually see the albumin, and if it is low, then you have to account for it when you actually give a result. So now for phenytoin, as you all know, there is an equation called Srinathosar equation, which is used for correcting. If there is hypoalbuminemia, you have to use that equation to correct the phenytoin that you're measuring. And then only you report it. So otherwise, you have to go and do the free phenytoin level. Free phenytoin is the best way actually to do phenytoin estimation. Okay, so the important role of pharmacologists here in TDM is we have to collect information before a sample is taken from the patient. And that's an extensive process. And that is why the TDM is very different from a simple biochemistry test. A biochemistry test, you can just send a sample to a lab and the sample can be analyzed there. But when we are doing TDM, you have to collect a lot of clinical information before. It's like doing pathology specimen test or doing a pathology slide examination. You have to know a lot of history before you actually do the TDM. So I hope I am clear with that for phenytoin. So obviously, just going by range always will not help. Make sure that you are getting the information correct before you do the collection of sample. Thank you.
Thank you so much, Dr. Sumit, for those two important points. And I would like to ask, which platform does the biologic TDM? Or is it an open-ended kit?
There is a company which provides kits for biologics, Nova Diagnostics. So yeah, there
Those
are
simple ELISA plates.
Kit-based method, immunoassays,
Okay,
immunoassay kit-based method.
If you have, let's say, 4 samples today, would you be able to perform that in those? Is the 96 well plate?
I assume so. I have not used it, but those people actually came to us and they said it's available. You can start the test. I mean, so that's how I came to know all that.
Wonderful. Thank you for that information. We have been struggling with the small molecules. We haven't ventured into the biologics so far.
Okay, ma'am.
Right.
Okay, ma'am. Thank you.
Yes, sir. It's a ELISA-based technique. I'll show you some of the things. So, Dr. Sandhya, thank you so much. Thank you so much for that presentation. You may stop share so that I will be able to share my screen.
Yeah. Thank you, madam. Once again, I thank organizing team.
Thank you so
giving me
much
this
for
opportunity.
accepting that invite in such a short notice. We would have loved your presentation in person though.
Yeah, I also was thinking of coming. Due to some other reason, I could not come. Yeah, thank you, madam.
Thank you. Okay, so I'll quickly start with mine, though I had some of the anti-epileptic data from our center to share, but in the interest of time, I'm just refraining from that. If we have time in the end, maybe during the discussion, I can project those slides. We just concluded about, we did an audit of 950 patients over a period of 5 years at our center for the older anti-epileptic drugs. And I would have loved to show that data, but nevertheless, let's move on to the next topic. For the sake of, I would say, to keep it basic and simple, basically this presentation is mostly meant for an MD student who has no knowledge about the TDM of immunosuppressant drugs. Unfortunately, very few centers in India are performing this. So let's
just ask you are interested in history. So I suppose the PDF service in India, actually, KM had a lot of role because I think 1988 they started.
They started in
What
88.
about PDF? When did
We started in 1991
So for all
or
practical-
90, maybe
90.
90.
For all practical purposes in India, 88 is the
Yes.
when PDF
That's
started.
what is my information. Sir.
As per the literature code.
Yes.
It is 1988. Okay. And then 90 is the year.
91, I think the CMC Vellore started, if I'm not wrong. So Dr. Sumit, you may correct me if I'm giving some misinformation.
No, we started very late. We started very recently compared to that. So we started in 2004. 2004. Yes,
But
yes. We
to
had
the
a
best
clinical
of-
pharmacology lab even
Hmm.
before that, but TDM was started in 2004. Yes.
So these are also interesting because basic history of India in India.
Right. And sir, I must acknowledge this, that we started in 91. We did not make much progress in those. After a decade, we did not make much progress the way we should have progressed in our center. I say we because I grew up in that place. So it's been.
It's not 90, it has to be 91. But I remember when we were there were a lot of talk about very soon it started. I left in 91.
So 91.
Maybe right there, Dr. Gar.
With Dr. Garg.
Right. So,
So I would presume that we should have been we could have made better progress, but nevertheless we tried catching up about a decade back with the world and with everyone else. So now we really are making fast progress, but there's a long way to go, I must say. So, to the best of my knowledge, CMC Vellore does a very wonderful job. I mean, I am really I'm very proud of saying that the kind of work they have done so far, and the kind of work they are doing. They also run a fellowship program for everyone else's information. Those who are interested in taking it post MD, this program is even open for the non-MD graduates. Dr. Sumit, is it so?
No, it is only for MD pharmacologists.
MD,
Yes,
okay.
yes.
Right. And this is a 1-year program, if I'm not wrong.
Yeah, it is. They started as a one-year program. Yes.
1-year program. So anyone who is interested and wants to pursue this area is CMC is the place to go, definitely.
Yes.
Okay, let's move forward. So where are these immunosuppressant drugs used? Mostly we know that it's organ transplantations. It is the solid organ transplantation, hematopoietic stem cell transplantation. And the other major area is autoimmune diseases, where we know that we have to lower the, I mean, this is the basic two broad areas where we see that these drugs are being used. So these are the non-transplant settings are glomerular diseases, several you would have seen the vasculitis, SLE, inflammatory bowel disease, autoimmune hemolytic anemia, etc. Now, so these are the drugs which we use. We use mostly the calcineurin inhibitors, cyclosporin A, tacrolimus, and the proliferatives, that is the mTOR inhibitor, which is sirolimus and everolimus. And to your information, mostly a TDM run, which is run by the LCMSMS method, we try to club cyclosporin, tacrolimus, sirolimus, and everolimus in one run because of the basic nature of these compounds being similar. Now we have antiproliferative, that is mycophenolate, which is a IMPDH2 inhibitor. Now, the other four, you may notice that I have grouped them separately. That's azathioprine, steroids, antithymocyte, globulin, and belatacept. So these are drugs which are being used, but TDM has not been the standard of care for them or not been practiced. So like Dr. Sandhya said, you have to understand when TDM is not useful. For, let's say, antithymocyte globulin, we have got something like a rabbit monoclonal antibody which has to be used against the CD3 to kill the T cells before the transplantation is being done. So in this case, the better biomarker we have, that is the CD3 cell count, which is easily doable. Why take the pain of measuring a biologic? Now, next, coming to the azathioprine, we really don't do the TDM, but we do some of the 6-guanine compound estimations. But these are mostly in connection with the TPMT and the NUDT polymorphism in which we need. So mostly the TPMT and the NUDT polymorphisms are being done in the tertiary care hospitals. And some of the 6-guanine compounds are also being done to give an indicator that you might have a polymorphism that is affecting the metabolism of this drug. So at our center, we don't do routine monitoring of the drug. However, whenever the patient actually lands up in a neutropenia or a pancytopenia, we get activated and we go and frantically get the genotype done. So the clinicians believe that very few patients land up with this adverse event, and then most of the time it is salvageable. So we routinely don't perform it. And the other thing is steroids. Steroids are kind of the ubiquitous the immunosuppressant that's being used. So in which we generally don't monitor their thing. We only monitor the dose and the clinical response. Now, the other drug is belatacept. Belatacept is a co-stimulation inhibitor. Again, a biologic, has to be administered by injection, subcutaneous injection once a month. Again, a biologic, the TDM. There are papers about belatacept TDM, but the processes are not the established, and the TDM in clinical practice is not well established. So why we immunosuppressant drugs? Why do we really need TDM? As Dr. Sandhya very rightly pointed out some of the points that if your kinetics is very well correlating with the clinical response, and you can titrate those responses, you can prevent toxicities when your drug is of low therapeutic index, etc., etc. So in the context of immunosuppressant drug, When we're using them in clinical practice, it's like walking on a tightrope. Like this person, you can see, you just imagine you're using an immunosuppressant drug and you are a doctor and you're like this. So are the TDM professionals. So you end up facing consequences of insufficient immunosuppression or over immunosuppressed patients. So this is typically from a renal transplant perspective, that this slide, but this is nevertheless is the universal truth that you may have therapeutic failures, your immunosuppression is not adequate, or you end up having a lot of infection, nephrotoxicity or end organ toxicity, I should say, and all the metabolic side effects like hypertension and diabetes, or I should say deranged glucose metabolism. Okay, so now the immunosuppressant drug typically fit into these four groups, with two things that I'm adding here is high interpatient variability and high intrapatient variability. These are very well-known observations about the immunosuppressant drugs, and therefore, if we see the number of requests that any center who does a myriad of drugs and delivers a service for or TDM service for a myriad of drugs, immunosuppressants will dominate the list. So, and out of these immunosuppressants, let me be very honest, tacrolimus is more than 90% of the requests. Okay, so for the residents, it is interpatient is between patients and intrapatient is within the same patient. So you may have different levels for the same dose in a patient with different absorption profiles. Let's say one day patient took food, the other day he is maybe having some underlying infection. The other the GI motility was not appropriate like the previous day. So these are the reasons for intrapatient variability, and sometimes the causes are really unknown. And for interpatient variability, the pharmacogenomics of the patient is the one which plays a lot of role, especially in the context of tacrolimus, which is the CYP3A5. We'll see some of them. So cyclosporine, those are that's the first immunosuppressant as such for which TDM was introduced. You know, the first transplantation was actually done with azathioprine and corticosteroids. So after the introduction of cyclosporine, actually the scenario for organ transplantation changed. The rejection rates were reduced by more than 50%. When earlier days we used to have rejections 80%, now it reduced to somewhere around 30%. So this drug got approval in 1983, and the first formulation actually was in 1983, which is the Sandhya from Sandhya, which is a formulation of cyclosporine which had a bit of absorption issues. So the initial absorption was not very good for cyclosporine when it was launched. Then the neural formulation or the microemulsion formulation came in 1994, launched by Novartis. And so this is practically one of the first drugs for which the immunosuppressant drugs for which TDM was done. So the next drug, I'll be just giving an overview. That's 1994. The same year, the cyclosporine new formulation was launched. The first indication was actually in liver transplant, and then kidney and cardiac followed. So as I mentioned, more than 95% of the immunosuppressant that is used in a solid organ transplantation is tacrolimus. And cyclosporine is particularly popular in the hematopoietic stem cell transplant. You might question the thing that when we know that tacrolimus is more sort of efficacious, why are we using cyclosporine in the first place? But nevertheless, this is kind of this concept needs some sort of clarification. Cyclosporine and tacrolimus both have their inherent limitations. Tacrolimus gets absorbed very fast, but it's very efficacious as well as it's very toxic also. So at the same time, you might have a better regulation of cyclosporine levels. Cyclosporine levels generally do not fluctuate much. The pharmacogenomic effects on cyclosporine A is limited, and the clinicians who have been using both the drugs, they feel that it's way easier to control and manage a patient on cyclosporin than tacrolimus. However, we know that the evidence for the efficacy of tacrolimus is better. You can see that the better graft survival is seen with tacrolimus. And as well as I told you, it comes at a higher cost of diabetes, tremor, and all these adverse events, gingival hyperplasia, dyslipidemia, etc. So both the drugs have their advantages and disadvantages, and both are in use in different contexts, in the sense that the predominant use of cyclosporin is in hematopoietic stem cell transplant and tacrolimus in solid organ transplants. Now, if I'm going back to the TDM of cyclosporin A, it's C0 versus C2. So why C0 versus C2? As C0, Dr. Sandhya explained, it's the drug concentration, but C2 also came up for cyclosporin. So C2 actually came up for the neural formulation or the microemulsion formulation, which has a delayed absorption. And some of the conventional preparation of cyclosporin also studied the C2. However, the TDM community is yet not at a consensus which one is the better biomarker. For all practical purposes, C0 is being used. I remember somebody in the last TDM education class asked this question. I went back and looked up, and I really stay on my answer that I'm kind of close to the truth, that there is no consensus about C0 and C2. For all we know is C0 is the time-tested marker, though some of the studies really say that C0 may not be an indicator of efficacy or long-term outcome in these patients. But we all do C0s for cyclosporin. So some of the clinicians in my setting, my institute believe that C2 was a Novartis floated concept for microemulsion of with all due respect to the industry. So C2 was a Novartis invention, but at present everybody does C0. Now TDM of tacrolimus, we know that the sorry, I missed a little bit here. So the when you are doing C0, the C0 is 200 to 300 in first 1 to 3 months of transplantation, 50 to 150 in the later months. So one thing to take away from here is the levels or the therapeutic window varies from with the time since transplantation. So for C2, it is 800 to 1000 and 400 to 600. So just mind you the ranges. So it's pretty wide for cyclosporin in comparison to tacrolimus, where it is like 7 to 10 in the early months of transplantation and 3 to 7 in the subsequent months. So in the West, people practice it as with ATG or without ATG for a solid organ transplant. And so I'll just quickly move forward. So this is the personalized therapy consensus report, where these are the takeaways from here. So the pre-dose C0 is still the best. They do recommend the exposure for patients who are having high risk, who are in the high risk category. And a group in France is working on this. University of Limoges has proposed that AUC by C0 probably stays constant for a particular patient, and for high risk patient, you would probably like to do an AUC, as C0 may not be the best indicator. Now, here they emphasize in this document the importance of consistency, calibration, proficiency testing, and requirement of standardization, and the reference material that is being used. So these are all part of the quality parameters, and Dr. Sandhya already elaborated this. So the most important part is to maintain that quality, and even though we are not accredited, we should be knowing that what we are doing is the right thing. And we are as much close to the truth as possible with the limited setting in which we are working. So the CYP3 genotype, this document also mentions, and then it also mentioned the residual nuclear factor activated uses. This is for tacrolimus. So this is the target, the pharmacodynamic target. Since I am sitting in the, I am in the company of the pharmacologist, I'm trying to go a little bit to the lab. Okay. Now, how do we test these immunosuppressants? We started in our center in about, I think 2016 we started. 2015 or 16 we started with the LCMS-MS. Pediatric biochemistry actually procured the LCMS-MS. We were closely involved because that was the first LCMS-MS we got in our institute. And now for last 1.5 years, we were running into trouble with the LCMS-MS with the high turnaround time, and because the one instrument was being utilized for the newborn screening as well as you know, it's a very versatile equipment. So multiple users, and therefore the turnaround time for drug reporting was high. So we procured another autoanalyzer, and our reporting time is within 2 hours or 2 to 4 hours of receiving the sample. Now, you see when we fight between, I mean, there are great discussions whether this assay is better or the mass spectrometry is the better one. So I will just take you through some of the things, like we have the pros and cons of each method. So here, please pay attention to the upper panel, which is the, like we were discussing, this is for the residents. Like we were discussing the ELISA methods, whether it's a direct ELISA, indirect ELISA, or sandwich ELISA or anything. You have all types of method existing for the drugs. For a biologic, you might go for a sandwich ELISA kind of a method. This is depending on how the kit is being developed by the vendor and what is coming out as a more error-free and very validated thing for a specific test. So this is a very kind of, it's very easy to use. The acceptance quality controls are good if you keep all your checks and balances in place. The cost of equipment is less compared to the LCMS-MS. The throughput is fast. Like our equipment can process around 450 samples per 1 hour. Now, we don't get as much samples, but this is what is the processing speed of this equipment. And then the sensitivity. So sensitivity means how low you can detect the compound or the drug or whatever your analyte of interest is. So typically sensitivity in this instrument, the autoanalyzers are up to the tune of 2 nanograms. So we don't consider them a very sensitive equipment because we have the LCMS-MS, which is the gold standard. Okay. Now, the disadvantage of this immunoassay is it has a problem of selectivity. You see, this is antigen-antibody reactions. And if you have a mimicker, which could be anything, which could be a metabolite of the drug, which could even be an endogenous molecule, which could even be another antibody which is having a similar structure. So selectivity or non-specificity is the problem in these assays, and therefore the general understanding is that you always get a little higher value than the accurate value or the exact value, right? And we cannot go away from the non-specificity here. And the sample volume that is required for this assay, immunoassay, is generally higher. I'm just telling from experience that 200 microliter we require for an immunoassay method, whereas an LCMS-MS method can do it in 50 microliter. So it's a 1/4. Then cost per sample is high in an immunoassay method. So if you are, I mean, end up using we call it as a closed system or an open system. So closed system is when you have to buy the kit from the vendor who has supplied you the instrument. And most of the times it goes like that because the vendor otherwise does not take the responsibility when the quality of the test is not maintained. So you most of the time end up having, because if you're using an open-ended system, when you buy a kit from a third party, then the onus of accuracy is actually on you. All right. So we all end up using the closed systems. So therefore, the cost per sample is high. So even if the equipment cost is low, the cost of cost of analysis of each sample is high. Therefore, people have made elaborate calculations and they have seen that when you have a high sample load, I mean, your hospital is having, let's say, 300 samples per day, then LCMS-MS turns out to be economical compared to an amino acid. Provided we are not here talking about the turnaround time. Time is money, everybody knows, but we are not talking about the turnaround time here. Okay. Now, the next point I would like to highlight is the reproducibility. Now, reproducibility in these assays are generally considered inferior to the LCMS-MS because you might have variations in the temperature of the lab. You might have a change in the way the sample had been stored, and there is clogging, or there is how do I explain? So there is, and several antibodies have stick to each other, and there's a loss in the sample that you are taking. So generally, these are considered inferior in terms of their reproducibility compared to an LCMS-MS, where you are choosing your sample, the sensitivity and the accuracy, everything is better than the amino acid. Now, multiplexing is something that I told in the beginning. We try to club all 4 immunosuppressants and then try to run one method so that you may have any type of sample, but in the one run that you can report. So that actually is very economical for the lab. The more you multiplex, the better it is. But in an immunoassay method, the scope of multiplexing is non-existent because you can't possibly put 2 types of antibodies and do 2 types of estimation in one well. So next is the mass spectrometry. So mass spectrometry is much better in terms of sensitivity, specificity, and multiplexing that I just discussed. The disadvantage in terms of the mass spectrometry is the most important is the handling, because it is very much technically demanding. You have to have an expert who would realize that there is some error somewhere. Otherwise, in that you may remain in that sense of grandeur that I am running a LCMS-MS, nothing can go wrong. When you are not technically sound or you have some error in your assay, the analysis can really go haywire and you end up concluding wrong things. Inaccurate estimations would then be a standard. So the other thing is lack of standardization. So there are great documents from several regulatory agencies for standardization of the assays and the periodic monitoring and things. So most of the times the standardization, the onus of standardization in a setting where there is no regulatory body or regulatory authority looking at a clinical lab, actually the onus is on the lab director himself or herself. So in a regulated environment or in an environment where you are doing reporting in a CLIA setting or a accredited kind of a setting, then the standardization protocols are well maintained and they kind of assure that the lack of standardization is not the case for this sample. So the other thing that I would like to highlight is the matrix effect that we see in these cases in the LCMS-MS. So different types of biological matrix may have interferences, and you have to rule out matrix effect when you are standardizing in assay. So the question, we come back to the question, which is the best? This is the take, that is the general consensus. The no single method immunoassay or mass spectrometry is the preferred method in every situation. Lack of assay standardization is currently not specific to one assay type. So you might have lack of assay standardization also in the immunoassay. And the implication of this should be carefully considered for each specific assay. Then I would like to really read, because each word is important. When deciding between immunoassay and a mass spectrometry for your lab, the best option will depend on your lab's needs, goals, and the patient population. So next drug is mycophenolate. I will quickly browse through this because we are we don't want Dr. Sumit to be waiting for a longer period. Now, this is the basic thing about the drug. I just made this slide to give an overview of the drug, because it might seem to an unrelated audience who is not working in this area very alien. So mycophenolate is IMPDH2 inhibitor. It gets metabolized to MPAG, mycophenolate, and the active moiety that we measure is mycophenolic acid. It is available in two formulations, MMF and the ECMPS. Again, second formulation came up because of some criticism of the MMF for gastric toxicity or gastric adverse events intolerability. Now, enterohepatic circulation is something every pharmacologist should know. So all the students, please pay attention. This is the keyword for mycophenolate. That's one thing that I would like you to take home. Mycophenolate has significant enterohepatic circulation. Thereby, I mean that there is going to be a second peak in this. Therefore, the current consensus is that C0 is not an indicator of it's not a good PK biomarker for TDM. So what do we do here? We do a AUC. So for doing an AUC, you can see in this picture how many samples have been taken? 3 to 5, 8. 8 samples have been taken. So for each patient, you have to take 8 samples. Is that feasible? And is the patient going to get it done for you? I would not get it done. I don't want my mycophenolate to be done. You choose an alternative drug for me, even if mycophenolate is the best kind of antiproliferative. Because azathioprine, we see patients coming back to us with leukopenias. You would not see, mostly mycophenolate is generally well tolerated. So for GI side effects, they would just reduce the dose. I would not go for an 8 sample test. So what do we do? In this document, we sort of propose that this is the overview of the document that say from the IIT City says that AUC is definitely the biomarker, but you have to work around that. You may have limited sampling strategies. But the flip side is you have to do it in your own population, and you can also go for Bayesian dose adjustment, which is like a statistical way of extrapolating from 1 or 2 samples the 12-hour AUC of mycophenolate, and the fixed dose prescription, because this is always titrated, and because the TDM is not frequently done or in many parts of the country. So the fixed doses are prescribed, which has been really questioned. And the range here, the therapeutic range we are looking at for the AUC is 30 to 60. And one point the practical point I would like to highlight here is HPLC turns out to be as good a method, as good and accurate method, I would say, for doing the mycophenolate, because you measure them in micrograms per ml. So it turns out to be really good, as accurate as the LCMSMS method. So that's where I would like to stop, because Dr. Sumit will take on the next. If anyone has any questions. Yes, please. Yeah, overall it is not low. Overall cost of equipment is low. Let's say the cost of equipment is 15 to 17 or 19 lakhs. But the kit that we get for the kit will have the diluents, the extraction reagent, the buffers, and the QCs and the standards. They would be somewhere around 20 to 50,000, in which you would be able to analyze some randomly around 300 samples. So we provide the test at a cost of 500 rupees to the patient, but again, that's a highly subsidized one. So in outside labs would charge somewhere around 3,500. Anyway, all patients, most of the patients who come to us are having either the Ayushman Bharat beneficiary or poor free. We make them poor free when they are generally the BPL, the below poverty line kind of patient. So don't look at that 500 rupees as a cost. You end up spending somewhere around 1,000, 1,200 if in a non-profit, non-loss kind of a thing. And the interesting thing is some of the equipment vendors, I would like you to know this fact as a lab director. The equipment vendors are always eager to give you the equipment free of cost. Why? That's because you will buy the kits and that's how they will make up the cost. So in PGI, we do not have a policy to take like that, but if you can really afford one, why not? It's ultimately for the patient. Yes, please, Dr. Sunny.
One of the big learnings that I had during this kind of only of using real world data as well as pharmacoeconomic data. Pharmacoeconomic data in order to associate the returns to that project, right? And I think near the time the institute director and the government body actually always ask us, why do you want to have TDM? Why do you want to have a thing? Can we use this thing for something like that? And that's always the question. So what has been your experience?
Wonderful. So that's a real difficult question, actually. So we did some of the pharmacoeconomic things, but as of now, it's always the patient welfare that dominated so far. We can't make a general assumption that this system would ever be profitable. And because if I go back and look at the statistics, as I mentioned, almost about 60% of our patients are poor free.
Yeah, I think I'm asking the wrong institute.
Yes, yeah. I mean, I'm sure it's your tax money, it's my tax money, it's everybody else's tax money where it is going. But we certainly need an assessment there that how much the institute is investing for one test, which we actually haven't done a formal calculation, which would include all the investment, establishment, manpower, everything else.
And more important, what is the benefit that the patient gets, right? Maybe it's not just the test because you want to, but for the community, what is the value that they get?
Excellent point, but excellent question, but with no easy answers, I must say, because these kind of studies are completely lacking. We recently just kind of published a article in BJCP where we have said that there should be a continuous assessment of a system, in the sense that you are establishing a service. At the end of the day, the outcome studies are completely lacking. A group where TDM was not done, a group where TDM was done. These kind of studies are unfortunately lacking from most of the parts of the world, even in the developed countries. And making an RCT work in a TDM setting is almost impossible. So when, let me know, when there is evolving evidence which suggests that TDM is beneficial. How will you not do it? Even for an immunosuppressant drug. It would be disastrous not to offer a TDM, not assessing tacrolimus level in an organ transplantation. So I mean, I'm really looking forward to an answer. How will you conduct those kind of studies where you would say that you would not do TDM versus you have done TDM and what is the result? No, we all need to find an answer for this. I mean, how will you design such a study? You're very right that you should have observational data, but we would either would like to have an historical data set where when TDM was not practiced. And if you have an historical data set, the clinical practice has changed so much. The surgical technique has changed so much. Even for, let's say, even for the hematopoietic stem cell transplant, things have evolved over a long period. I mean, decades. So, I mean, we really need to find a design of a study which would assess this. We can have a lot of retrospective data where because most of the evidence comes like, okay, the patient had higher concentration and he landed up in adverse event, or lower concentration, he ended up having GVHD or anything, or a graft rejection. I am not sure whether I have an answer for your question. Thank you for that question, though. Hello, Dr. Sumit?
Hi, ma'am. Yeah. tell me,
Yeah,
ma'am.
yeah. Anything you would like to add? Dhaneria sir, would you like to add anything? Okay, so
I will address this issue regarding the study in my talk. Yeah. So
if you permit
anything
5
else?
minutes, can we quickly, my student actually dealt with this case. And if you permit, can we quickly do this case presentation of a patient where we used TDM plus pharmacogenomics to quickly 5 minutes. Kumarvel, can you please come up and present this? How do I make it full screen? Where is the cursor gone? The cursor is not visible. Stop it.
না ঠিক আছে আমি বলছি আমি ওদের লোককে বললাম যে থাকতো this one, no?
We have to.
I will do that. Now you have to share.
Okay.
Thank you, ma'am, for giving this opportunity. So as a part of routine clinical services like TDM services, so we come across this case. This is not moving. Yeah. So here I will be presenting a case like a 16-year-old female, KR, who was diagnosed as chronic kidney disease, stage 5. So with the primary cause of congenital anomaly of urinary tract and kidney. So undergone living related renal transplant, that is allograft. The donor was father. The induction regimen we are used is ATG 50 and also tacrolimus for starters 50 like 6 milligram per day. So here you can see the post-operative days and tacrolimus dose and whole blood tacrolimus concentration. Even though we are giving adequate dose like 6 milligram BD, but we are not achieving the therapeutic range. So this, what is the clinical issue is initial post-operative period, the tacrolimus therapeutic window was not achieved despite giving high dose. So we planned a pharmacogenetic and pharmacokinetic analysis. The pharmacokinetic analysis is dose exposure response. So we have analyzed. So for this, we have taken a written informed consent from the patient. So we did some special investigations like genotyping. For genotyping, initially we did like genomic extraction, that is DNA extraction by using the kit. And then genotype came as CYP3A5 star1 mutation. That is homozygous pattern. So here you can see that is SNP CYP3 star1. So see here you can see this we did like to explore the dose exposure response or analysis. So Z0, C1.5 and C6. So the dose which was given here, it is 7.5 milligram BD in the POD of 65 days. Coming to below panel, here it is, we have given 4.25 milligram, like almost same dose, but it given us TDS, that is thrice a day. Why we have did like this? So in C1.5, we have high therapeutic range, like this 37.88. But in C, whenever we are giving 4.25 thrice a day, we have 25. So the thing is, these results suggest that the peak concentration achieved here, it is toxic range, and also the concentration at 6 is also high. So the suggested, we have planned for a scale dosing reduction, that is from 7.5 milligram BD to 4.25 milligram TD. The lessons learned we have from these cases, individualized dosing by using by doing the genotyping, and also the based upon the PK profile. So we have given TAD dosing. So this will possibly reduce the long-term CNA toxicity and also will improve the better clinical outcome and the graft out. Thank you.
Thank you, Kumar. Actually, Kumar actually did a lot of work in this patient's dose optimization. So I would just he just missed a little bit. So look at the peak there. That is when we were prescribing 8 mg BD, 37.88. It's 37.88, which is way high of the when we know that beyond 20 it is going to be nephrotoxic. So we could by TDS dosing we could bring it down to 25, and that actually increases the pill burden on the patient, but somehow increased pill with a better long-term outcome. So all I wanted to highlight is regimen optimization, keeping in view your long-term goals. Thank you. Yeah, Dr. Sumit, yeah, please.
Thanks a lot, Dr. Smita, and your placing committee. I will thank you at the end, all of you. Maybe I will start my presentation soon. Thanks a lot anyway for inviting me, and all the previous speakers, Dr. Sandhya and Dr. Smita, has actually gave a good overview about TDM, so that I don't have to spend time talking about that TDM, how it is important for the patients. Here, my major area of work in the department is antimicrobial agents, TDM of antimicrobial agents. I can give you evidences on how it helped patients What are the possible study mechanisms where you can actually prove that TDM works, especially etc. So to start with, sepsis. Sepsis is a threat to life, especially for critically ill patients. And it's common in ICU patients. Around 40% of them develop sepsis. And this 30-day mortality rates are as high as 37%. And with this outset, I would like to ask this question: why TDM of antimicrobial agents? Why is it important? Recently, an article is published in 2022 in Clinical Infectious Diseases. This is a meta-analysis done by Rekha Pai Mangalore and team. So only the important things I'm highlighting here. TDM guided dosing was associated with improved clinical cure, improved microbiological cure, less treatment failure, and improved target attainment. So there are loads and loads of evidence supporting TDM of antimicrobial agents in critically ill patients. There are many. This is the recent one. So why this TDM should be integrated into hospital antibiotic policies? One important reason is the concentration effect relationship is well established for most of the antibiotics, especially all beta-lactams, aminoglycosides, vancomycin glycopeptides, and even to a certain extent, polymyxin antibiotics. And you also know that some of these antibiotics are extremely toxic. Okay. And the duration of action of these antibiotics are relatively short. And the patients are presenting in acute conditions. And a lot of disease factors can modify the antibiotic dose required. For example, sepsis. It can cause capillary leak syndrome. So therefore, the antibiotic concentration, antibiotic can go from the central compartment to the peripheral compartment. So the central compartment concentration will fall. Or there can be third space fluid volume loss, for example, ascites, and we are treating a patient with lung infection. So when you remove the ascitic fluid, you're losing antibiotic. Then patients with renal failure, you need dose adjustment. Then treatment interventions can modify the antibiotic exposure. For example, dialysis in between, or the way you give an antibiotic, that can change the exposure of antibiotic. Then also there is good evidence available for relating the bacterial kill with the antibiotic exposure in the blood, or even in the CSF or other fluids. So there is a need for loading dose of antibiotics, at least for some of them, which have long half-life. So the Surviving Sepsis Campaign guideline recommends administration of effective IV antimicrobials within the first hour of recognition of septic shock and severe sepsis without septic shock. So this is very crucial. Effective antibiotics within the first hour of recognition of septic shock. So time is very crucial when you treat a patient with sepsis. And simulation studies, however, shows that the target concentration will not be reached at first dose for majority of critically ill patients, even if you use the most commonly recommended dose. Can you close the door? Even if you use the most commonly recommended doses. So what are the factors affecting clinical outcome? Infection, where the infection is. Lung infection. Is the dose of antibiotic you need to treat lung infection same as dose required to treat osteomyelitis, or is the dose required to treat CNS infection? That is a question. Then second is the virulence of pathogen. Can you give the same dose of antibiotic for treating Klebsiella versus E. coli? Adequate source of control of infection. That is very important, especially when the patient is having pus in different body parts. You have to drain the pus. Without draining pus, even if you actually give a proper dose optimized antibiotic treatment, it is going to not help the patient much. Then pharmacological properties of antimicrobial agent. what antibiotic you use. So you may have the sensitivity report, culture sensitivity report with you. And now the patient is having a skin infection. So this is skin infection. You need an antibiotic which is highly lipophilic. So even though you have the culture sensitivity report, you have to choose an antibiotic which is more penetrating to tissues if you have options to treat skin infection. So you have that choice and dosing of antimicrobial agents may be very important for deciding the treatment outcome. And also the patient characteristics, something like critically ill patient, they are very different from a normal patient admitted in ward, or whether there are significant comorbidities, extremes of body size, extremes of age. All these are factors which can contribute to change in drug exposure in patient's body. In 2021, okay, that's the latest, Surviving Sepsis Campaign Guidelines. They recommend the dose optimization of antimicrobials based on PK/PD principles. So there are a lot of factors which can affect the plasma concentration of drug. So you can't treat a patient with one dose of drug. You have to use guidelines, and when possible, you have to use TDM in your routine practice. So, for example, I will give one example on colistin. We are doing this study, it's still going on. At the point when we recruited 61 patients for this exposure to determine the exposure to colistin in critically ill patients. Remember, all these patients received same dose of loading dose, 9 million international units of cholesterol sodium, all these patients received. And they were on 3 million international units of colistin as TID as a maintenance dose. So their doses are same, especially because this study was done sometime back 2019. People were not aware of how to adjust the dose of colistin, etc. So all the patients received almost similar dose of colistin. Okay, but see the difference in, so I will explain, this is one patient exposure in one interdose interval. This is another patient exposure in another interdose interval. You see the y-axis, how much it is spread, and the red line is the concentration that patient should have for optimal response. That means minimal toxicity. You know, colistin is toxic. It is nephrotoxic. It is neurotoxic. It can cause muscle paralysis. So to have optimal response, you have to have a concentration of colistin around this 2 milligram per liter steady state concentration. But see all these patients received same dose, and see the spread of exposure between patients. So some patients are going to have so high levels, some patients are going to have so low levels. And this is the time when we were not doing TDM. We are actually doing the study, seeing the exposure. And we actually looked at the GFR relation. So normally colistin, the only guideline is dose it based on the creatinine clearance. Okay. Now, when you look at the GFR and the 24-hour AUC exposure of colistin, the higher the GFR, lower is the exposure, but the correlation is very, very poor. R square is only 0.14. What you need an R square is like more than 0.8 to say that, okay, that you use for dose adjustment guideline. Now, GFR, you cannot use as a dose adjustment guideline because there is no correlation between GFR and exposure to colistin. So we have done some study. So we were doing colistin exposure monitoring before actually TDM was implemented, and after TDM, when we started implementing, we did a study on AKI. You see, before TDM was implemented, AKI was 32, acute kidney injury. Acute kidney injury while the patient is on colistin. By day 7, 32% of patient developed AKI. While with introduction of TDM and with dose adjustment, it reduced to 7%. Now, next is, we couldn't do, once clinicians get to know that, okay, this is so important in patient outcome, they will not be willing to do a randomized control trial. But it will be very difficult to do a randomized control trial. One is you cannot blind the patients, blind the study investigators or the patient. It's very difficult if you're doing TDM. So we have done this way. In those, we looked at patients who achieved the target concentration of cholesterol and those who did not achieve target concentration of cholesterol. And we followed them up for a period of 7 days. And we saw that the clinical improvement happened in only 44% of patients when the target was not achieved, while clinical improvement happened in 92% of patients when the targets were achieved. This is the same case for meropenem also, where for those patients who achieved the target, the clinical improvement was 93% compared to only 25% when the targets were not achieved. So this is unpublished. We are in the process of publishing this data. Now, another case of voriconazole. A 62-year-old diabetic diagnosed with left renal abscess underwent simple nephrectomy. And voriconazole was started on 3rd December. Okay, so on 3rd December, voriconazole was started. On 10th December, the dose of voriconazole was 200 milligram morning and evening, and the concentration was adequate, 5.95. But that is on the higher side. 5.95 is crossing 5.5. So therefore, the doctors have reduced the doses a little bit to 200 and 100. But over this period of time, the patient had improvement in the CRP. The inflammatory condition or the inflammatory process in the body generally improved. So inflammation subsided. So with this 200 and 100, the levels dropped to like 0.28, very, very low. So the doctors again increased the dose to 200 BD, and the level still is, which was less than 1. Okay. And then they had to increase the dose to 300 and 200 to reach a level of 1.46. Why this happened? Because inflammation, in the presence of inflammation, CYP enzymes are inhibited. Voriconazole is metabolized by CYP enzymes. So when there is an inhibition of metabolism because of inflammation, voriconazole levels will be higher. So the initial stages of infection, the voriconazole levels will be high, but as the inflammation subsides, the voriconazole levels drop because CYP enzymes take over and metabolize the voriconazole. So even there was a study which published, which proved the same thing. So you can't start a patient on a particular dose, especially with anti-infectives. You can't start on a particular dose and just leave the patient with that. You have to do follow-up and you have to do measurements. But there are some practical issues with TDM. One is there is a delay in achieving steady state. So normally we say for anti-epileptic drugs or for immunosuppressants, we wait for steady state in some cases. But many of these antibiotics have long half-life, and monitoring waiting for monitoring to reach steady state is very detrimental, because Surviving Sepsis campaign, they actually said, if you don't monitor early, it is equivalent to not monitoring at all. Okay, you have to hit the target concentrations as early as possible. So especially in patients with renal failure, the half-life of drugs increase. So that is kind of difficult to understand when to monitor, etc., etc. And there is fluctuation in clearance and volume of distribution of drug over a period of time during patient's admission in hospital. So even though on day 3 the antibiotic levels were okay, on day 5 the antibiotic levels may not be okay. So the issue is here, you need to do monitoring very frequently as possible. Okay. So first of all, there is a delay in achieving steady state. We can't wait till the steady state is achieved to do monitoring for dose adjustment. And another example I would like to talk about is vancomycin. Here, a 55-year-old diabetic diagnosed with left parasinusitis and normal renal function. Functional endoscopic sinus surgery was performed on 23rd May and trained pus, and CRP was only 10.4 on 24th May. And pus culture grown MRSA, and the patient did not respond to linezolid. So therefore, they changed the antibiotic to vancomycin 1 gram BD. That is a normal dose to start with. It was started on 29th May. And on 1st of June, we measured the antibiotic level. The trough is only 5.72. That is very low. What we expect is something above 10 to be adequate exposure. So on 4th June, the doctors increased the dose, and by 4th June, we measured it again, but still it was only 6.85. On 7th June, we changed the dose to 1.5 gram BD. And on 13th June, we measured again, it was 14.1, which is adequate exposure. So this patient improved with a change in antibiotic dose. So normal dose given for vancomycin is 1 gram BD, but see this patient, and it's very common now, we regularly monitor vancomycin for most of our patients, even ward patients. And we see this pattern for many patients, they need a higher dose. And after some time, as patient improves, maybe after 1 week or 2 weeks, if the patient is still on vancomycin, then they may need a dose reduction. So TDM really helps in patient improvement, especially if you do at the earliest. So now there are studies saying you don't look at trough, you have to look at AUCs. So, and there are even meta-analysis supporting vancomycin AUC guided dose adjustment to reduce nephrotoxicity. So there are plenty of studies to support TDM and especially AUC guided dose adjustments. So vancomycin AUC, especially in critically ill setting, we can't do because we are talking about 8 to 10 samples, and that too for ICU patients. It's impossible. So how can we overcome this situation? So what we do here is we use PKPD models. So the typical way we actually do is we get the treatment history of vancomycin. We note the exact date and time, when was antibiotic started, what are the times at which this vancomycin was given, what was the dose that we were given. Next, all this detailed drug history we will take. We actually do not go to ICU for this purpose. We have people in the ICU who gives us this information to us. So to reduce the manpower going inside the ICU, we did that. So yeah, so information come to us, and we advise on at what time we have to take samples, and it doesn't have to be trough. So we advise maybe 1 sample or maybe 2 samples or maybe 3 samples to take. And we use this information, we put all this information in a software called BestDose. There are other softwares which are available, but this is the cheapest that we have. We plan the treatment, and then the software will come up with the dose suggestion. Okay, so you can see that the points in red, these are the time points at which we have actually measured. We have taken the sample and measured vancomycin concentration, but the software is able to give the full past history, how the exposure was, vancomycin exposure was over the past many days. So it's not just one AUC that we're talking about. We are seeing the entire AUC of the past few days and how the AUC will be in the future, provided the serum creatinine continues like this, or provided the body weight of the patient continues like this, what is going to be the exposure and what is the actual dose that we have to give. All that the dosing software can tell us, but we have to use our sense, and based on that, we have to suggest the dose to the physician, because physician at times won't be able to take a decision on dose. So normally what we do is we pharmacologists do dose suggestion. Okay. So we look at the model quality. If the model quality is good, we also report the predicted 24-hour AUC and we recommend the dose. So patient's creatinine is going up. Patient creatinine going up may be because of sepsis. It may not be because of the antibiotic levels being high. So then I'm just giving you an example. So then we actually, when we tell the, okay, doctor, you increase the dose of vancomycin, they will be actually, okay, kind of, oh, should we really? Yes, we have to give them confidence. You please go ahead and increase the dose of antibiotic. And actually, by doing so, the creatinine falls down. Okay, so yeah, so what is the way forward? I told you antibiotics, the best way to monitor TDM is to monitor as frequently as possible. Now for ICU patients, things like microsampling devices or biosensors can actually continuously monitor the antibiotic concentration, especially in the initial few days when the patient is not really doing well. So those points you can use biosensors. Now biosensor is not available in India. There are places where biosensors are in research. So, but what we can do is we can at least do the TDM and we can use the concentration estimations in the Bayesian models, PKPD models. PKPD models we have to develop in our institution, or we can use the ones which are available outside, but we have to validate those models in our patient population. So what are the advantages of Bayesian models? We don't have to wait for steady state. Vancomycin, once we start giving to a patient, we don't have to wait for 96 hours, especially if the patient is having renal failure. We don't have to wait for 1 week to see, okay, whether their levels are adequate or not. Use the Bayesian models. You can do measurement even in the first day and suggest the dose in the first day itself. You can sample at any point in time. So that makes your life more comfortable. You need AUC with few, you can find out the AUC with very few time points. And the most important question is when to do TDM of anti-infective agents. So this is a publication which I have done in Journal of Clinical Pharmacology. So I have published a model for colistin based on the study. So this is a very simple model. Normally, colistin is given as colistin-mediated sodium. So all the models currently available are, you have to measure for both colistin-mediated sodium and colistin to use their models. But in my case, in this particular model, this is a simplified model where you can just use colistin concentrations to predict the colistin exposure. You don't need to measure colistin-mediated sodium. Actually, measuring colistin-mediated sodium is a very tedious procedure. Okay, so in this study, I found that there was a subpopulation of 22 patients whom we had actually followed up for 7 days. And in that, if you look at, you see the how the even though, so remember colistin-mediated sodium, we give a loading dose, 9 million units loading dose that we give actually, but still it took 96 hours. The concentration slowly raised up. Okay. It took 96 hours for the colistin concentration to reach steady state. So should we just wait for 96 hours? No, we should not. So as early as possible, monitor. So this is another journal which, another article which was published in Antimicrobial Agents and Chemotherapy, which states that delay in measuring beta-lactam concentration was associated with clinical failure, longer ICU stay, and higher mortality. Okay, so time is very crucial. You have to monitor as early as possible. So now we have established precision dosing for our ICU patient. We have started only in one ICU, SICU. We have over 200 beds, ICU beds, but it's impossible to start with all the 200 beds. Now we have started only for 20 patients. We need manpower to do this. So how we are doing this, I will let you know. Precision dosing for antibiotics. So how we initiate TDM? So an ICU technical assistant from the ICU, he will give continuously he will give information on which all patients are on which all antibiotics. We see that with the TDM consultant, we look at it and they identify the patients who need TDM. For example, some patient may be just in the ICU, just on an antibiotic, completely empirically treated, no fever, nothing else, then we don't have to do TDM, something like that. So identify the patients who need TDM and they inform to the antibiotic TDM lead. Currently, in our hospital, I am the antibiotic TDM lead. And then we contact the ICU registrar. Okay, so we have decided this patient needs TDM. And the advantage of doing this is there is no delay. So as soon as the antibiotic is started, at least within 24 to 48 hours, this information will be given to the antibiotic TDM lead and the TDM things will start. So the ICU registrar, we will inform the ICU registrar. He will manage the appropriate timed blood collection. And that usually happens within 48 hours of starting the antibiotic in the ICU. And then he will take part in dose optimization discussions with the anti-infective TDM lead and TDM consultants. So finally, the ICU consultant will decide on the dose optimization. So we will give the dose suggestions. Okay, so this patient needs 10 lakh units of polymyxin BD or 15 lakh units of polymyxin BD. We suggest. And the ICU consultant take the final decision on that, maybe in association with consultation with ID physician, maybe. So now, once you change the dose, it is the responsibility of the TDM team to continue following up that patient till the patient is stopped on antibiotic. That particular antibiotic should be, we have to monitor continuously till the antibiotic is stopped. Because now you might have suggested a very high dose or a very low dose than the physician normally give. So you have to take the responsibility to continuously follow up that patient. So that is run by the TDM consultant till the patient leaves the ICU. Faster than culture. Okay, so so for example, if the physician decided to start a patient on meropenem, we do meropenem, we give the reports within 48 hours, but by the time the culture reports come, it will be like 48 or even 72 hours. And plus another 2 or 3 days, 2 days for getting the MIC reports. But by then, the clinician will know whether the antibiotic concentrations is sufficient to kill and all the meropenem susceptible organism, because you are doing TDM within 48 hours. And if the patient is not responding to meropenem, they can just go up on to a higher antibiotic, or they can go to a adding another antibiotic. So you can actually save a precious time. So you don't have to wait for all this culture and MIC and all that stuff. But you can facilitate when in the precision dosing, a clinical microbiologist can be involved so that they can do the MIC as soon as possible. And we repeat measurements, we look at the clinical status of the patient, and we do dose optimization. So for each of these patients, minimum we spend around 15 minutes. I mean, the pharmacologist, along with the PharmD, we spend around 15 minutes. So we need a huge workforce for doing all this. So pharmacologists are not enough. We need PharmDs to do all the groundwork also. So we do dose optimization for till the patient leaves the ICU. So in the summary, TDM of antimicrobial agents will improve target concentration achievement, clinical outcome, reduce the length of hospital stay, and reduce the risk of toxicity. And TDM gives objective goals. You have numbers. So if the numbers are not attained, if the concentrations are not attained, you are working on those. You have objective goals. Increase the dose to that. So if the levels are low, even synergism will not work. You can't just add another antibiotic and imagine that that will work. No. If the concentration of antibiotic is low, even synergism will not work. Okay, so you have objective goals for antibiotic treatment, and this guides selection of antibiotic appropriate for patient management. Use of PK models for dose optimization assist with selection of appropriate dose to achieve target concentration. For effective implementation of TDM, a team is very important. Team approach by including a pharmacologist, a microbiologist for dose optimization of depleted patients is suggested. And don't forget, early TDM improves patient clinical outcome. All measurements should be implemented to achieve sufficient, all measures should be implemented to achieve sufficient antibiotic concentration at the earliest in the course of anti-infective therapy. Thank you, the organizing team. Especially, I would like to thank the, I would like to thank all the organizing committee, Santanu sir, Dr. Smita. I am extremely happy with Dr. Smita because she is very active in spreading TDM across India. She is a member of ITDM City, and she is standing as a ITDM City, in which committee? I'm sorry.
I'm in the immunosuppressor committee and the pharmacogenomic.
Yeah, you're now standing for councillor.
Yeah,
ITDM City Councillor.
Yeah. This is the election.
Yes.
Sorry, I forgot.
Yeah, election.
I actually thought about the committees, but this is the council election. I forgot.
Council. So please, all those who are in the ITDM City, please vote for Smita ma'am. She is actually very active in promoting TDM across India. Thank you. Thank you all. Any doubts?
You, Dr. Sumit. Let me see the chat box. Yeah, Dr. Nitya has written, Dr. Sarkar started in 1989 about KEM, I think. 89.
Okay.
Any questions? Okay. So
And
that
shall I
I
stop
got from one
share?
of the internet pages. Yeah. So anyone has a question?
I have a couple of.
Sure, sir. Please go ahead. Dr.
One
Sumit.
is about beta-lactam. The need for having TDM for beta-lactam antibiotics, because as we know, it has a very wide margin. This is one. Secondly, you have shown in one slide about vancomycin TDM. Then can go to that side, because what I find that the treatment was started in I think 30th of May, and then the final if you look at this data, that 24th May and then 13th June, so it's quite a long time. That by gradual this you could optimize the dose to the PTM service. So how physicians responded to this, or whether this model is actually adding any value?
Hello, Dr. Smita. I was not able to hear at all. Something I heard partially. Can you please?
Can I repeat the question for you?
Yes.
Yeah. So Dr. Tripathi wants to know, looking at the data that is on the slide, that on 24th of May, you kind of got information about the patient. And on the 1st June, you started doing the TDM. And on 13th June, we find that the patient is possibly responding.
Sure.
So,
yes.
Yeah, so so now the patient is a big window. That's what Dr. Tripathi is pointing out to. 24th May to 13th June.
Yeah, that's the sad part about the story. So actually, they were treating the patient with linezolid for quite a long time, and then started vancomycin. As doctors pointed out, that also was continued for a long time. And initially in the wards, unfortunately, we are not able to do precision dosing in the wards because it's a huge hospital, around more than 2,500 beds. So we are right now focusing only in ICU patients. Only when the request comes from the ward, we are able to know, okay, understand that, okay, this patient is getting a vancomycin. That's a sad part, that we are not able to implement precision dosing in the wards. But ICU, yes, ICU patients are more sick, and yes. Definitely, it would have been better if we actually came to know about this patient early and dose adjust early. And at that point, we were actually not using models. We were using tough concentrations. We are talking about 2019. And we were not giving any dose suggestions. So they themselves were increasing the dose. So they were not very confident on increasing the dose. So all that matters. Now, with the use of PKPD models, we are able to give dose suggestions, and that makes everything faster. But again, the problem is wards, we are not able to cover, only ICU. And that only one ICU, we don't have enough manpower to do this.
So that also I find that first June and 4th June, the dose has been adjusted. It's more than, I think, 32 hours or more than that. And then again, 4th to 7th, again, dose has been adjusted. So how much of this was the turnaround time, and how much time they took if you need to actually readjust the dose based on your study?
Sorry, Smita ma'am, can you?
So essentially, sir is asking from 1st June, 1st June was the first vancomycin concentration done. And then the second dose adjustment was done on 4th June, then 7th and 13th. So about 3 to 4 days gap in between.
Yeah.
So
Yes.
how much is the time that was taken? I mean, to my mind, these are very good intervals. I mean, if you can really change the dose in this, but how much was the time that the lab took? How much was the time the TDM consultant took to? I mean, this is simply a self-assessment that how efficiently we can do the service, and how much was the time taken to convince the ICU physician to do the dose adjustment. So what was the most difficult part, which took, you 3 days to 4 days during each interval.
Dr. Sukanta, to add to that, meanwhile, if one physically patient, the patient condition is also changing. And by the time you decide about it, whether the vancomycin start person, even when it keeps it relevant, because in 3 days, typically the patient can also have worsening or improvement.
Yeah, so Dr. Sumit, over to you.
Okay, so the question that you asked, the time that we take. So around 24 hours we take for giving the report. That is the lab delay. That is even for precision dosing, that 24 hours delay is still there. Now, at those time points, we had to wait for trough to go up because we have changed the dose and we were not using any PKPD models. So therefore, it took around 3 days. Okay, so we said, wait for 3 days and third day you send the sample to us. So that also added that point because we were not using PKPD models. The best thing is go for biosensors. Biosensors has not reached India, but it will substantially reduce the time of hospital stay for the patient. And of course, 1 day in ICU costs nothing less than 10,000. So if whatever cost you are saying, the cost of TDM you are saying, it is nothing compared to the length. If you can reduce the hospital stay, that's the best thing that you can do for the patient economically. I hope I answered that question. I was not able to hear properly.
No, absolutely perfect, Dr. Sumit. I would like to add one thing. That is, when you are putting it into the Bayesian, the dose adjustment software, that also takes a bit of time to compute and do the model and then make a dose suggestion. If if I know best, it doesn't take time.
So as soon as we receive a sample, we get the proper history. So the sample will be going for processing. It may process within. If it's coming in the morning, we will do processing everything in 8 hours time. But meanwhile, we get all the full dose history for the patient, and that is the time-consuming part. So sample has gone for analysis. You may take around 10 to 15 minutes for entering all the details from the ICU into the BestDose software. And then we just have to wait for the sample concentration to be ready. We enter the concentration immediately. We have to, pharmacologists have to see, we have to use our wisdom before suggesting any dose. It's not like a computer will tell you some dose and you just have to tell that. No, we have to look at the patient's condition, and there will be multiple. So for example, one example I will tell you, CNS meningitis, patient is having MRSA meningitis. We just don't suggest like, okay, if the levels are only 5, trough is 5, something like that. We just don't suggest, okay, just increase the dose to 1.5 grams. That may be the thing that the computer may be telling, but then we have to use the literature also. So therefore, literature says CNS meningitis, give the dose as continuous infusion. So then we have to go say that, okay, you may have to give vancomycin as 2 gram, a higher dose as a continuous infusion. This will prevent the toxicity, nephrotoxicity, because you don't have Cmaxes. And it will also improve the penetration of antibiotic into the brain. So that's the importance of a pharmacologist here. We have to use our MBBS knowledge and also pharmacology knowledge to actually dose optimize. They help the physician decide the appropriate dose. Okay, so yeah, that's a big role that we play. We have to have confidence for that. Yeah, yes, it's a big role. Yeah.
Yeah, thank you so much.
But that part will take some time. Okay, deciding on the dose may take around 10 to 15 minutes. That's it.
Right, and we all who work in labs, we understand that in fact, in the lab, manpower is always at stake, and people doing multitasking in institutes and turnaround time is really an issue. And if you could do it in 24 hours, I would really appreciate your team. That's a good job.
Yeah, but that is not enough for antibiotics. Yeah, but that is something.
Yeah,
something
I
for the
understand.
patient.
I understand. Everybody would be happy with a point of care kind of a thing.
Yes.
And yeah, we have to reach there someday. So Dr. Manjunath from ACTREC has a question for you, Dr. Sumit.
Yes, yes. I'm not able to hear. Can you give the mic to? I'm not able to hear.
Yeah, we'll try to use the other one. Are you able to hear him now?
Sorry. Okay, you can.
Right. So it's a great work by you and this contribution for the video. So a couple of questions from me. So like for the position as of now, majority of the research shows like the free concentration of AUC by MIC ratio has to be a specific range, like 24.5 to 49 something. So now many people are like are employing different ranges or the AUC ratio or the Tmax ratio or the drug concentration. Some are saying that the steady state concentration, right? So you have taken a steady state concentration of 2 milligrams per liter. So we also have undertaken a similar study where we have tested a cutoff of 2 milligrams per liter. We have undertaken the study in the bone marrow transplantation. So is there any validated result or information about using the steady state concentration of 2 milligrams per liter?
Okay, so Dr. Sumit,
What drug?
should I re-articulate or
Yeah,
you
yeah.
would be able to
What
start?
drug? Yeah, yeah.
So Dr. Manjunath's question is for colistin in a critically ill patient, we have two biomarkers, C0 versus C0 at steady state versus AUC upon C0. That's what some other group is investigating. And AUC upon C0, that ratio people have seen from 20 AUC by MIC ratio is up to 49 point something is some group is suggesting and working on. Dr. Manjunath has also started working in that area in bone marrow transplantation. His question specifically is AUC is C0 steady state 2 milligram per deciliter is a recommended standard. Where does this number come from?
Oh, okay, okay. All right. Thank you. Thanks for the question. Now, colistin is an antibiotic which has very poor penetration to deep tissues. Especially if the patient is having a lung infection, you may have to add some other antibiotic along with it. So because of this exact reason, colistin penetration is very poor. Normally, we talk about colistin when we talk about colistin when the patient is having bacteremia or the patient is having urinary tract infection. So the number more than 2 actually, more than 2, around 2 to 2.5 steady state concentration. So which means AUC divided by the interdose interval will give you steady state concentration. It's not just C0, the entire AUC divided by the interdose interval that will give you the steady state concentration. So it should be between 2 to 2.5. And the normal cutoff for MIC to say that the organism is resistant for colistin is 2. So if the organism having an MIC of, if you want to cover an organism with an MIC of 2, we have to have antibiotic concentration at least 2. Okay, that is a concept. That's why the concept of 2. And it was proved in many in vitro studies that if, for example, mice thigh infection model and all, if you achieve an average concentration of 2 to 2.5 over a period of time, that is able to cover an organism with an MIC up to 2. So anything less than 2, you can treat. The problem is you should not treat an organism which has an MIC of more than 2 because beyond that concentrations, colistin will cause toxicity. So you can change this average steady state concentration to AUC. AUC is a better way always to work with. Now with the model that we have made, the AUC, we can actually see AUC with 1 or 2 concentrations. So 24 AUC for colistin, we should target something like 50, not AUC by MIC, AUC I'm telling. If the AUC is more than 50, or if it is something like 100, it will cause nephrotoxicity and neurotoxicity. And also we have to take into consideration the duration of therapy. For example, if the colistin is given for 20 days, you can't say that, okay, the AUC of 75 is okay. 24-hour AUC of 75 is not okay in that case. It can cause toxicity. So you have to also consider the cumulative accumulation of colistin on the patient's body. So if we target an AUC of 50, that means if you convert it into steady state concentration between 2 to 2.3. If we are able to achieve this anytime in the 7-day period, that will be adequate to treat a patient with a MIC, with an organism with an MIC less than 2. And for bacteremia, UTI, and intra-abdominal infections. But if it is a lung infection, you have to add some other antibiotic along with colistin, because colistin cannot penetrate into lungs. Am I clear? So the therapeutic ranges are like that for colistin. Am I clear? And we don't look at MIC. The problem is because colistin penetration into tissues are very poor. So what we are aiming for is at the earliest reach the highest possible, which will not cause toxicity. So the highest you can go for is 50 AUC or 50 milligram hour per liter. So hit that concentration and continue hitting that concentration till the patient recovers. So we don't no point actually looking at MIC also, because then you decrease the dose, the antibiotic may not be penetrating into the tissue. All that can cause issues.
So
Even
when
though even though people normally say AUC by MIC of 50 is good, but it's not. I will not suggest that for an ICU patient. ICU is hit the maximum, which is less toxic.
Right. We also did a similar study in the bone marrow transplant patient study. So wherein we try to identify which regimen is again suitable for the patient.
Bone marrow transplant patient, I heard.
So we did a similar study in the bone marrow transplant patient. Okay. So wherein we try to identify which is the regimen that is suitable for the patient. Okay. So, like the colistin label says, like to give the drug at 25,000 international units per kg body weight. Okay. Isn't it 3 times doses? So if you look at that one, the 3 million units will not touch it. 9 million units. So we did a pop PK. We did the PK initially for the first dose as well as the steady state. And we have simulated, we did the PK/PD modeling, and we came out with the result that you have to give a loading dose as you are suggesting with the 9 million units, followed by the 4.5 BD or 3 times thrice in a day. And wherein we found like both these regimens are achieving a good concentration of 2 milligram per liter, the steady state one. But the 4 million units BD1 is crossing the trough concentration of 3.3 milligram per liter, which is toxic. So what we have suggested to the clinicians is to start with the 9 and followed by 3 million units 3 times a day. So this is what like our study has resulted in.
What I understood is we have done simulation to reach a particular concentration, right? To reach a particular AUC. Is that correct?
So his point is to aim to attain 2 milligram per deciliter steady state concentration.
Okay.
You have 2 options. Your loading is 9 million. First, your loading is 9 million units per. That's the loading. Then you have 2 options: either to adopt a BD dose of 4.5 million each, vis-a-vis a model where or 3 thrice daily dosing, which is 3 million units. So their point is when we dosed the patient 3 times a day, our attainment of the steady state drug concentration was better, whereas with the BD doses, they attain a concentration somewhere around 3.2, which was toxic.
Okay, okay, yeah,
Yeah.
sure. Okay, so for cholesterol, there is no evidence available to say that if you reduce the frequency, total dose giving the same, but reduce the frequency will cause toxicity. There is no evidence available for that.
Yeah.
As far as I know, there is no evidence available for that.
So this is their new study. I mean, this is their study where they have found this.
Okay.
So there's one more question from Momita who's asked about the TDM of voriconazole. So there are ample guidances, Momita. I am ignoring your question. I would send you the reference and with Dr. Sumit in the loop.
Okay.
Okay.
Yeah.
We'll proceed for Dr. Tripathi's talk and then we will conclude the session. Okay. Thank you, Dr.
Thanks a lot.
Sumit. Thank you.
Thanks a lot. Thanks a lot for having me. Thank you. Thank you.
Thank you for sparing your time. Dr. Sumit? Hello? I think he left. He left.
Dr. Smita, I think after the discussion since the morning, the topic that you have given, that TDM in resource poor setting, okay, that seems a little not carrying too much of relevance. In fact, we have already discussed. One thing is clear that in India also there are not too many centers where TDM services are available. There are two things. One, we can have some discussion. That's why I was requesting if Dr. Sumit would still be there. And you can also request, I think Dr. Sandhya is still there. So it could be a kind of panel discussion, or it could be a kind of discussion with the other faculty on this theme, that TDM services in resource poor setting. If we consider that ours is actually a resource poor setting, given the fact that if it has been started in 1988 or 89, so 11 years that side and 23 years, 22 years this side, 33 years we are in this. But then how many centers are actually having, how many institutions are having access to TDM services in the country? So given this fact, it is no wonder that there is no denial that there are a lot of barriers. There are huge limitations. And although we may be hopeful that in the next, say, 5 years or 10 years, things will improve substantially, but then we can only hope that. Given this, what could be the possible solution? Or if we say that one possible solution is try to have more and more centers inducted into this. This is one. Of course, as Dr. Sandhya had her comment during her presentation, that to popularize it more, to have more discussion, deliberation, CMEs, conferences, discussions, etc., to motivate younger people to come up in these areas. But then it's not a person's wish it is also the support that is needed at the institution level. So that becomes also very important, how you are going to convince your institution head. If you are in a government job, then it is not just, most of the government institutions, they do not have enough autonomy, okay, to take this kind of a decision to start a TDM lab. And even if somebody is over enthusiastic and starts it, but then in order to continue with this, the kind of recurring support that you require, and also the kind of teamwork that will be required in a government setting, it's a huge challenge. When I say government setting, maybe the central government institutes are a little better off. But if you think of the state government institutions, okay, it is too much to expect that you would be really very fortunate to start it, and also not just starting, continue with it, really implementing it in the most desired manner to really supplement or optimize the patient care services with the help of these TDM services. So given this, the other strategy could be the centers which are already have established and achieved some degree of success. There are a few success stories in the country, of course, whether it is in PGI Chandigarh or in KEM or in Jipmar or in Vellore. These are the few centers what I can remember. There might be a couple more, but then these are the centers to start with. Whether these centers can also keep over and above trying to cater to the need of their own institutions, whether they can also come up with some kind of support, although it may be a little utopian, but then whether as some kind of hand-holding support, these few centers, okay, 4 or 5 centers or 5 or 6 centers, whether they can offer some kind of hand-holding support to some other areas, other institutions which intend to start this. If we can say as a strategy, if at least beyond these 4 centers, there might be another 5 or 7 centers where there is clinical pharmacology training, curricular training program is going on. But even there, we find that they have not yet started for very many reasons. Whether the centers which already have some degree of success, they can extend or lend some support to motivate these centers where they could not start it yet. How can we do that? Number one, to develop the center. When we say developing the center, again, it will take time, because we know it requires the infrastructure facility to create the laboratory, to provide manpower support, to have the instrumentation installed. But then again, to continue service, you need the diverse kind of technical manpower. In a government facility, it's very, very challenging, because to convince your minister or to convince your director of medical education that this is a really essential, etc. I'm leaving aside the other part, that where from the clinicians, where from they will be sending samples, or they will be convinced that it is needed and they're actually going to add value to their patient care services. This is one part. But whether the clinical pharmacology departments or pharmacology departments, whether they would be able to develop this facility at their center, for that, what are the constraints and how we can try to obviate these such constraints in our own setting, in Indian setting. So if keeping that in mind, if we could have some meaningful discussion in the next, say, 15-20 minutes, that would be great, I suppose. My question was that whether the 4 or 5 centers which have started experiencing this and attained some degree of success, how and to what extent they would be willing to offer some kind of lending hand of support. Dr. Smita.
Dr. Smita, are you there? Hello? Okay. So I thought he was going to answer this, but unfortunately, I have to address.
Right. Fortunately.
question. So I'm a born optimist.
Of course.
So we have started a program called TDM Education in India. How many of you are aware of it? Only 4 in the hall.
No, but
You
then
were also there, 5 in the hall.
the 5 out of how many? So then you will be, that is optimist.
Maybe 10.
It's not bad. If you think of the total pharmacology community, it will not come to 10%.
Everything into it. So, with the International Association of Therapeutic Drug Monitoring and Toxicology, we have started this program where we are running into the 2nd year now. And unfortunately, let me be very honest, Shambo, you are the leader in this region. I don't see any participation from West Bengal. We have people attending more than 200, 300 from all over India. I am going to, in the Oslo conference, I'm going to give them the statistics. We are running a educational webinar series where anybody can join. We disseminate the link on LinkedIn, etc., whatever platform we can. Okay, so one from the West Bengal.
So there is another at the back.
Why I want that one to go into 100. So everything starts with, practical aspects are there. We don't go away from those realities which was just pointed out. We have to first make our theory sound, That only will happen when I see participation. And holding all 4, 5 institutions, whoever is doing, everybody is eager to let them. Apart from the logistic bottlenecks, I think there's somewhere our own intrinsic motivation has to come forward.
For starting for in fact, anything that come from the interest there. We started doing interest course there from 1 year, and they have 2 persons came from him. That's in the game, and they are insisting us to start this. But as Sarah said, that we have several bottlenecks in the grassroots actually. So we have not reached up to the stage to go to this queue, because we are now rising to accumulate all these instruments and these things.
Everybody has to give their best. And we have several central institutes that have come up. Those central institutes they are doing the central procurement. They are way ahead of us in terms of procurement of equipment. But I can't see any of them using those equipment to deliver. They're everywhere. Some of them who have got the auto analyzers, they are doing video. I know ACPI is doing that. They are giving patient service. I'm sorry, I'm not aware of the other aids whether they are doing delivering the patient service or not. We all are doing patient service at a very in a very compromised setting. I understand. Most of it I understand is the lack of information. Apart from the logistic problem.
No, can I comment here?
Sure.
Yes, there one can easily say there is lack of motivation, but then again, this motivation level also drops down when you find it is both way. Just wait. I was telling something. Let me complete. Yeah. We have to think of there are both ways. One is lack of motivation. There is a general lack of motivation. But then again, if somebody is motivated today, and then he finds that it is becoming, despite his best effort, it is not being possible at his own institution level to initiate it, to start it, then it goes down. He gets frustrated. So we have to strategize actually. One is, of course, you have to keep on trying to get your facility developed at your own institution level. But if you do not get it easily done, not to get frustrated, and until that is done, whether when I put this across, whether the centers which are optimally successful or primarily successful, whether they can lend support. Lending support could be in raising motivation level, in making people aware, etc., sensitizing them. So one is the educational part. Okay. The other is that in the interim period, when a center X is able to develop these patient care services at their own level, until then, whether some kind of services can be provided by these 5 centers which are right now in the business. I was actually trying to propose that is it possible some kind of samples to be sent? It could be in a very rudimentary level, okay? Some kind of dried blood samples, etc. If I try to dispatch you to your center. So whether you are ready to provide some kind of service, it may not be very easily, immediately helping the patient, but at least to gain, to gain interest further, okay? We have to identify some of the areas where even if I get it maybe after say 7 days, it will help in some kind of long-term care situations where TDM has a place to identify them. And in those cases where this turnaround time is not that too much relevant actually. So we can possibly afford to wait for 3-4 days or 5 or 7 days. Even then, whether there is a need for, there are some situations where you can do that. You just think of the tuberculosis, where we can wait for 7 days. Okay. So think about if we could think of some of those situations where these 5 centers, they are ready to extend this kind of support. It's not easy to say yes, it will be, because they have their own workload there in their own centers. In order to flourish further, they need to also satisfy their own need. Okay, it may not be so easy, but could we think of doing some kind of like that? That was my question.
Can I give a suggestion, sir?
Yes.
Basically, yes. What you asked is little difficult, but doable for some drugs. For some drugs, for example, TB drugs, it is not stable at all. But you may have to do some minimum extraction before you're sending it across. But for some drugs, even after extraction or even after you add stabilizing agent, it may not be stable at all. So yes, but there are many drugs which you can send across and we can analyze and give back the reports. That is one thing. But for when we talk about your department, for the department motivation to continue or to prosper or to actually evolve into something bigger, I will have a suggestion. I have a suggestion. This is the suggestion. There are usually in all hospitals, there are automated analyzers. So usually it will be in the biochemistry department. So we don't have to set up a lab right now. You already have a lab in the biochemistry lab. So use the automated analyzers in those labs and get the kits like phenytoin, carbamazepine. There are many drugs which you can analyze using those existing automated analyzers. And it's you are not adding any burden on the hospital or on the authorities. So this is just buying kits. So if you start a service, the thing that you need to focus on is not the lab, because you don't have the expertise to manage a lab. What you need to focus is, as a pharmacologist, establish a TDM patient service area. So for example, that's a place where patient come. It's not unlike a biochemistry test, where the patient goes to a common place and give the blood and go or a pathology place. It's not like that. Pharmacology, you need to get a proper history. So you find a space in your department itself, or if it is close to the clinical area, that will be the best. OP is the best if you get a TDM services board on it. And
got your point. This
start
the auto analyzer services, I think 4-5 years back, I also heard, if I am not wrong, AIIMS Bhubaneswar, were they trying that in 3-4 years back, and was it a success story in your case, using auto analyzer and trying to get some trough levels of some anti-epileptics? And so so this could be a success story, and you can also share that with in this forum. Okay, try to exchange that how people have started with the little resources, and whatever are the available infrastructure and logistic resources available with us. With that, how we can initiate these kind of activities, and then by this you gain some kind of confidence, and then try to build on that, and gradually try to own a lab which is dedicated for these purposes, patient care service purposes.
Yes. So the sample comes to you, the database belongs to you, you have the full data, and then you actually start service. That's the way you actually progress.
Great.
So you have some money in your hand to buy equipments of your own.
Right.
So now the focus here, because it's not lab, you can give your entire energy for your use the existing pharmacology knowledge itself. So that way it will be easier and faster for you to convince the hospital management.
Sir, can I add a point on this? Sir, like when it comes to government institutes, like any government institute for that matter. So the first thing, like if we have to help others, probably that institute should get into an MOU that is at administrative level. So they should get the administrative support, and then even if they send the sample also, like if without the MOU, the administration will be again asking like how will you spending money on consumables? So that will become an issue. One possible thing is like maybe capacity building can be done. With permission, they can come and learn how to do, what are the simple methods. That is one possibility. And with respect to this auto analyzer, if it is a tabletop, a small portable analyzer, it's okay. Like for example, in our biochemistry, they have a clinical chemistry analyzer which is huge with high throughput. So like if you want to do some drug analysis using that auto analyzer where the throughput is very high, for few samples, if you do, it will be like wastage of money and resources. So once we had tried, but then they said for the amount of patient sample, using that auto analyzer may not be a good thing. You have to go for a portable one. So that also we have to keep in mind.
Right. We have our friend from AIIMS Bhubaneswar. KM Mumbai, I'm sorry. Yes.
I'm Dr. Bhaskar. I'm working in KM Mumbai. So just like Dr. Sunil suggested, we in KM Mumbai already run a TDM OP that is run on Fridays and Saturdays twice a week, and we get reference from the business department who can take it to get the TDM done. So with our clinical pharmacology and pharmacology residents, so we only take the history, we fill up the TDM form, select the samples, and give you a bill. So this is one very good way to find a benefit of the liquidity and provide the TDM service. And with regards to capacity building, we also have a training program. We have a structured training program of 2 to 3 weeks, wherein people can come to KM and get trained in how to provide the TDM services, how to set up the lab and everything. Very recently, there was a team from AIIMS right here. Dr. Yogendra Nethi and 2 lab technicians. And from AIIMS, Bilapur also we have received a request. Dr. Meenakshi is the assistant professor there. So she also wants to get training. So yes, we do provide training, and so we can avail of that training services. Of course, we won't be paying for the accommodation, and and it will come at a monetary charge. So that thing will have to go. And secondly, regarding the additional provision of services. So, of course, so far we have received very less number of samples, I mean, 250 samples from other institutes, where they don't have TDM facility available to continue sending us samples and we have to send them. So yes, it is practically doable. And how much that, of course, we will have to work on but yes, it is practically doable. We can accept samples from other institutes and
Okay, good. So, Dhanadya.
Sir, you have correctly raised the point because the peripheral institutes are facing the problem of technical expertise for TDM. Like you correctly said, hence I think was facing the problem of getting the technician for HPLC. When we got it, then we asked the members or I think faculty are coming for a week and technicians for 2 to 3 weeks. The expenditure is to go back. So this technical personnel, it is really a problem that is in the study. We are not getting that. But the KM, there is a very good help they have provided to the end side. Sir, I think you remember that Dr. S.K. Garg at our time was not allowing except Naresh to test the HPLC because he was of opinion that if multiple persons are handling HPLC, it will not work beyond 1 year. But his HPLC, I think it worked for more than 10 years.
The kind of problem that we mostly face, let us be very frank with it, the center which doesn't have the facility yet and intends to start that, what are the bottlenecks, what are the hurdles? Number one, instrument. So purchasing an instrument. And there are in government setting, again, it has its own procedures for purchase of instrument. If we assume that you have been able to convince the policymakers or your local administrator or whosoever, and you got the funds, even for that, ultimately getting an instrument installed is a challenge, number one. Second is the recurring cost. Who is going to vouch for that recurring cost? Okay, even for the reagents, specimens, etc., everything. Third, technician. Most of the government centers, old persons, they are being as they are retiring, there is no okay filling the vacancy. Okay, people are now used to put people on contractual service, and getting people on contractual service. So getting people in contractual service and getting them again trained, that is again another challenge. If you have a technician, then the question of training him comes. You don't have a technician at all. So I'm talking of the real ground scenario in most of the government institutions. After that, it is the question of convincing your clinicians that they should also be believing that this is going to add value, and for that again capacity building and sensitization, etc., that will be required. So I think in order to really find a solution to these kind of problems that we are facing for decades, in fact, and if we really feel that in the coming, we are interested in getting a better picture in the coming 5 years or 10 years, that we have to flag these problem areas and how to obviate them. And then only we can expect that more and more. Otherwise, hopefully, there are many new aims are coming. You can say after 5 years, there will be 5 or 7 more TDM centers, which will be done in the aims only. But if you think of having peripheral centers coming up with TDM facility, if we really want to see that, we have to put our effort and we have to think differently. The PGIs and KEMs are not the representative of most of the hospitals and institutions in the country. That we must admit. I'm sorry if I am putting a very pessimistic view of this whole scenario, but then that is reality. Let us accept that. If we wish that we need to change things, we have to think differently also. Okay, please, Dr. Smita.
Yes, sir. I really don't want to end on that, so therefore I have to speak.
Yes, of course.
So, even if I acknowledge that we went through a 2-decade slump after starting. So I sincerely believe again this intrinsic motivation will come. The way we have progressed in last 1 decade only indicates that intrinsic motivation is important. That's the starting point. So that's what is important. And of course, CMC Relevance has been one of the institutes where I look forward to for inspiration, for technical knowledge, for any kind of analytical trouble that I am facing. So people are out there very talented, very knowledgeable, very skilled to help. And all we need is a thought and a strong motivation to go forward. And as we know that a lot of central institutes have been started in several parts of India. So we have to capitalize on this kind of centers to make them as medium centers and possibly making that whole group as single group is important. And that was the vision with which we started the TDM Education in India program, where everybody comes to the same platform. You can ask what are the reagents being used in so and so drug analysis, whether it is useful to do the continue doing the older anti-epileptic drugs, things like that, where we are trying to look for answers to those questions in our setting. So it was a continuous discussion and brainstorming that is needed, and also the channel of communication should always be open. Whether you are facing logistics, maybe the person who is already some way ahead of you in that line will provide you some sort of, okay, you can contact so and so person, you can write so and so grant, or maybe do so and so thing to get an instrument, or so and so company provides the kit.
I think we have to go beyond this here.
Right.
To identify sources of sources which can provide resource or can provide the kind of support that is required for developing or initiating your center. But looking at the past, what we find that the institution which have some degree of autonomy in decision making, there it has succeeded, which I find that most of the state government institutes do not have that kind of autonomy. So they have to depend on their local administration or departmental head, etc. I mean the Ministry of Health, state government. There, I think it can succeed provided we can give kind of a model where you can generate revenue. So those centers which are already succeeded, if you can give us a model, we can try to convince our health secretary that this is a model which is otherwise not only would optimize patient care in certain areas, but it also would generate revenue, whereby it can self-sustaining kind of model. If you can give that kind of a working report from your group, from this group, forerunner group, so that might help in developing this kind of center in some state government institutes. Doctor, please, Tanis.
Try to keep it short. And I'm going to shift the discussion from TDM in these institutions into something which might also be useful in a bigger way. So many of these departments have now developed capabilities in pharmacology analysis. One thing which probably the pharmaceutical industry needs the ability of people who are trained in pharmacometry, right? And that will also enable a lot of academic research that is happening in the current time, where you need people who have understanding of clinical pharmacology as well as you can say clinical pharmacokinetic. And I'm thinking of clinical pharmacokinetic from clinical pharmacology because you need to have analytical hands-on skill to actually do it, right? And this is a big area which nobody has kind of like gone into in many institutions. But I think the starting points are there for many of the institutions. So maybe there are some students, bright students who say that I don't want to go into TDM and because I feel that I'm not going to be here or I'm not going to be the institution. But these can be centers of excellence for pharmacometrics and all.
I think it's cut the conference.
Yeah.
So I would like to leave now. I hope you're a good ma'am, Sandhya ma'am.
Yeah, yes, sir. Yes, sir.
Yeah.
Thank you, sir. How are you, sir?
Okay.
You're nice, sir. Your talk was nice. It gave lots
Yeah,
of
I heard
information.
partially your talk also. Yeah, thanks. Thanks.
Thank you, sir. You're doing really a good job.
Oh,
CMC is really doing a very good job with respect to
Yeah.
TDM.
yeah.
Nice. Whenever we have some doubts, we'll always approach you, sir.
Sure, sure. Okay, ma'am. Yes.
Okay. Okay. Yeah. Thank you, sir. Moumita, can we leave? Or will you be connecting? Moumita, can we?
Yes, yes, ma'am.
Yeah. Okay.
Definitely in the academic institution. That's it. It's coming up.
So I think we can now.
Yeah, with this, we will like to thank everybody for the active participation and there have been a lot of discussion. Please send your feedback if you have any on this forum, on the ACPI WhatsApp forum, wherever you feel like. And it is definitely interesting to see that lots of people have lots of thoughts to share. And I actually overtook the time. Thank you. Thank you.
I would like to thank all the Dr. Sandhya and Dr. Singh. I would like to thank all the resource persons for the workshop, especially so I would like to extend a warm gratitude to all the resource persons for this workshop, especially Sandhya ma'am, Sumit and Smita madam over here and all the other people who have contributed immensely to the discussion. So we will next move forward to the workshop on drug allergy and desensitization. So for this, I would like to request Professor Sushant Bandhavadhyay sir to come up here as he will be acting as the chairperson for this session. And the course directors for this workshop are Dr. Shoibal Moitra sir, and who will also be the moderator for the entire session. I would like to request her to please come up onto the stage. And I would also request Dr. Taha Ashraf Qurashi, who has come a long way to visit us and participate in this workshop. So he will also be acting as the course director. I would like to extend a warm welcome to both of them to conduct the session. Thank you.
So good afternoon, everybody. It's my pleasure that I am amongst all of you. I don't think I need much introduction of myself at this stage. So better continue with the topic for discussion because every time I experience that whenever in any conference, it's very difficult to maintain the time, and that is the most important part. So I'm sure that we are running late. Yes, I can visualize that time was sheet was 12:30, and now it is 1:30. So just 1 hour, nothing much. Anyhow, so today's workshop is on drug allergy and desensitization. And so without wasting time, I will request our resource person first, Dr. Taha Ashraf Qurashi. Please deliver your deliberation.
So first,
sorry?
First will be Dr. Saibal.
Acha, Dr. Saibal. Dr. Shoibal Moitra. So you will tell. But I will request other speakers to maintain it within 15 minutes because just to maintain the time.
Yes,
Please.
definitely,
Thank you.
yes.
Thank you. Please, Dr. Moitra.
Yeah, thank you. First of all, am I audible? I think. Yeah, first of all, I would like to thank the organizers for inviting me in this. It's not, no, it's not. Yeah, I think it's better now, right? Okay, I would like.
Can you hear us? Planet? Planet, can you hear us? Hello, Movita, can you hear us?
Yes, sir.
Okay, so am I audible?
Yes, sir, you are audible.
Thank you. So I would like to thank the organizers for inviting me in this ACPICon 2023. So which not much ado, I'll just go directly into the topic. So I will just set the stage so that we can have a discussion on this topic of drug allergy. And we'll just would like to have an interactive session, take up the questions, put up some cases and have a discussion and try to wind up the entire thing in an hour with definitely touching on the important tenets. If we talk about the drug allergy, which is better to be called a drug hypersensitivity reactions, like how many of you have a drug allergy evaluation set up in your hospital? So is there like, just like before, if we can have a poll, if someone raise hand who has a drug allergy evaluation or treatment set up in your hospital? Well, there is, yeah, there are 2. Okay. So that shows the thing that is we need to have the awareness of this entity. By and large, having an allergy medicine set up in the hospital, it's still in its infancy. Okay. So we recently had a published article and another article, I think Shambo is also a part of that, where we had submitted it in one of the journal, that what is the status of the allergy practice in India? And that we have pointed out that where are the bottlenecks, where are we standing right now, what do we need to do in the future regarding the training and to have a specific allergy medicine subspecialty for the training of the medical students. So we are still a long way to go. But notwithstanding those issues, we definitely need to address the issue of the drug allergy. Better that we said it's a drug hypersensitivity reactions. We get the patients who come up to our emergency departments with the features of maybe the anaphylaxis, following intake of some drugs, or the patient may come up to any of the doctors saying that he or she has allergy to one of the other drugs. Now this allergy, when we say, or when the patient says, it's very important to understand what the patient is actually mean by this term allergy, which is a very overused and abused terminology. So from the medical parlance, if it's an allergy, it is basically a type 1 immediate hypersensitivity reactions, which we all know. But when we look into the spectrum of the drug allergies, which is better called a drug hypersensitivity reactions, it could be a type 1, it could be type 2, type 3, type 4. It could be immediate, it could be delayed, it could be an IgE mediated, it could be a non-IgE mediated immediate,
or it could be using the other antibodies or maybe the other immune cells. So basically the broad term is the drug hypersensitivity reactions. Now it's very, very important for all of us to understand that when a patient comes with a history of a drug hypersensitivity reactions, whether immediate or delayed, we need to find out the culprit drug, because that is the answer which everybody wants. That is number one. Number two is that usually the patient and the physicians alike, they want to know that what drug can be given to this particular patient in the future when the patient needs, for say patient going for any operations, or the patient is going for any other treatment. So whether the patient is likely to react to any of the drugs. That is number two. And number three, what is the likelihood of the patient landing up into a severe or hypersensitivity reactions and to some drugs in the future? So these are the three main questions, which is very pertinent as far as the patient's treatment is concerned. So what usually a drug allergy clinic or a drug allergy evaluation OPD needs to do is that they needs to answer these questions. And for this, usually the allergy department will get a maximum number of the referrals from entire hospitals and also from the other physicians. So keeping this in mind, we'll just have a short talk by Dr. Taha Qurashi from Sher Kashmir Institute of Medical Sciences, Srinagar, where he would be talking about in next 20-25 minutes, the basics and some of the important tenets in the drug allergy evaluation. Then we'll just discuss that what is the role of the drug allergy testing, how we can test it, and where we should not test it. We'll just briefly discuss about the recent 2022 QuadAI updates regarding the drug allergy. And then we'll talk about the desensitization, in which drugs we should actually go for the desensitization, in which drugs we should not go for the drug desensitization, and what is desensitization and how long it is going to help the individual patient. Then we'll have the Shambo Samajdar, who would be talking about some of the cases. He would be showing the cases. And in that cases, we'll just have a group discussions and we'll try to find the answers to how to evaluate and treat those patients. And meanwhile, we can take any questions if you have encountered any of the patients in your practice, in your hospital, in your clinic, and we can discuss those and take up any of the questions which you have. So with this, I'll just request Dr. Taha to come up and just walk us through to his presentations in the next 20-25 minutes. Thank you.
Hello, everybody. I'm Dr. Taha. I work at Srinagar with the Sher Kashmir Institute of Medical Sciences with the Allergy Division of the Department of Immunology, and recently I've joined the JLM Hospital as the allergy consultant. And I will try to be very precise. Shoibal sir has made my job very, very easy. So I think I would start from the middle of my presentation. This is not working. Okay, thank you. So I hope I'm audible to the audience online. Am I?
Yes, sir, you're audible.
Thank you. So straight away, starting with this, my second slide, how do most patients present? And, most of the patients who present as drug allergy are already labeled as drug allergy by different people, sometimes on their own, sometimes different people. So again, my slides are not moving. Can you please help me? My slides are not moving. I'm doing it. Yeah. Okay. So mostly, as Saibal sir said, there are referral cases. There is no proper documentation, unfortunately. Again, my slides are not moving. Excuse me. Can you please help me? So some are labeled by local chemists, some by the nurses, and sometimes children come labeled by their parents, where somebody in the family has been allergic, and the parents assume that the child too will be allergic and deprive them of some very important treatment. And the most unfortunate part is that our fellow colleagues keep on sending patients to us without a proper workup regarding this allergy. They want us to give clearance. They don't want to touch the patient because the patient's already labeled as being supposedly allergic to something or the other, and we need to give clearance to those patients. Now, I am giving a few prescriptions as a model. You can see vague prescriptions saying drug allergy to multiple drugs. They need clearance for allergy in this patient for different injectable drugs like ceftriaxone, diclofenac, propofol, because this patient was going for cholecystectomy, and asking us to give clearance for these drugs as if they are available on a plate, just like a microbiology culture for the drugs, sensitivity testing. Little knowing that every drug allergy testing costs us at least 1 day and a lot of headache otherwise as well. So then this is another look at this. This cardiologist has sent a prescription to us. He wants us to give some antibiotic sensitivity testing, not mentioning the antibiotic the patient has to be implanted with a pacemaker. And then for local anesthesia, for radio contrast dyes, vague things, not specifying what all he needs to do. I mean, specifically which drug. So then another look at this. This patient on the right, allergic to all drugs. If somebody is allergic to all drugs, something very kind of impossible. So these kinds of prescription, whenever they come to you, it gets a little difficult. Drug allergy seems to be, a hard task to do. It becomes that actually is typical. But then if we try to manage it scientifically, it will become helpful strength if you are an allergist. So this patient, 22-year-old male, the new recruit in police department came to us. He had a grade 3 varicose veins, planned for surgery. He developed anaphylaxis twice. He was sent to us from the department of CVTS. He had anaphylaxis twice with the preoperative drug test dose, Augmentin and then ceftriaxone. Augmentin is amoxicillin clavulinate, as you must be knowing. Then previous drug history was suggestive of some urticaria rashes following intake of some antibiotic for gastroenteritis. So we don't know what the drug was, but it seemed to be something like a multi-drug allergy situation. This patient's surgery was a must because his life was at stake and his job was at stake as well because he was working in the police department. So we needed to come to some kind of solution in this kind of a patient. And this brings up to the allergist approach to a patient labeled as drug allergy. Before going ahead with that, just a few reassurances that in children, allergies can be outgrown 50% by 5 years and 80% by 10 years. That's a little assuring. Then drug allergies, as I said, they are overreported. Labels are often wrong, 90% of time. Then patients with history of previous documents, of allergy are usually previous docs are unreliable because there is no proper documentation as I showed you of. So skin testing, sometimes people have been skin tested and they have been labeled as positive, especially by non-experts. Well, that's something what's very common in our setup, maybe in the rest of the country as well. They are also usually wrong. Again, a little reassuring. And eventually only 10% of people who have been labeled as drug allergy worldwide, they prove out to be false. And what is the outcome of these wrong labels? It's so unfortunate. This deprives the patients from taking simple treatments, important medications. Like imagine the condition of a patient who is labeled as allergic to local anesthesia drug. And I have seen many patients who, because of this wrong label, which ultimately it turns out to be, they undergo even tooth extraction and root canal treatment under a general anesthesia procedure. Imagine the plight, imagine the risk and inconvenience and the cost on the exchequer as well as the patient. Then, unneeded and expensive drugs are given to the patient, especially when it comes to antibiotics. It leads to resistance as well. Cost on the exchequer and cost on the patient's pocket. And the patients develop a fear psychosis. They even, try to avoid treatment sometimes. They become drug phobics, drug cripples. You remember this movie, Diwar, 1972 movie, I think. A hit movie of those times. This movie was based on a wrong label. Mera Baap Chor Hai was written on the hand of this small child, Vijay, Amitabh Bachchan. In fact, Amitabh Bachchan is the great man today because of this movie only. And this wrong label, makes this movie turn into a tragic end where Amitabh Bachchan, because of this long label, becomes a gangster, not a gangster, in fact, an underworld don, and finally gets killed by the bullet of his own brother, who is an honest policeman. Unfortunately, even very unfortunately, in the lap of his mother, something like this. Had this label removed in time or not been wrongly labeled at all, the situation would have been definitely different. So there's a dire need for removing false label in case of this movie and in case of other drugs as well. So what is the allergist expected to do? So rule out this false allergy. And if, we confirm the true allergy after testing the patient properly, scientifically, then obviously, saying that this is the true allergy and give solutions to it, viable solutions. Maybe a substitute drug or maybe some other way, which we'll be discussing. So there are three cardinal elements in this evaluation of the patient for drug allergy. What is that cardinal element? Number one, history. Number two, history. And number three is history. History is the most important part of the allergist evaluation of a patient where he wants to evaluate a drug allergy patient. There's a questionnaire which is adapted. Many questions need to be asked, and this gives you a huge clue about what kind of allergy was it. The phenotype, sometimes, patient can have immediate reaction. You can accordingly judge the patient. Sometimes you can have a delayed reaction, and then, rest. You can evaluate the medical notes, which usually are vague, as I said earlier. And then physical examination can help us at targeted laboratory workup. And finally, a skin testing is also done to confirm immediate reactions, IgE mediated more so. And apart from this, finally, the drug is to be used on the patient. And therefore, we challenge the patient with that drug with a definite regimen, and that's called gated drug challenge. We challenge the patient with smaller doses, gradually increasing doses, and that's what it turns out to be finally. That gives an idea that is the patient really allergic to the drug, or is the patient not allergic to the drug? And as far as examination goes, there are many ways patient presents. Patient to present as examination gives you these ideas. If patient presents like this, though patient, to an allergist, patient presents in a chronic form only. By the time lesions are settled down, we need to evaluate only. This is the urticaria. Then you can have angioedema. You can have fixed drug eruptions. You can have AGEP, the generalized erythematous pustulosis. Then SGST, and these are very difficult conditions to treat. And as far as the laboratory workup goes, there are some parameters which are done and which can give us a clue as to what is the kind of reaction. Serum tryptase is very important among them. It has assumed quite a lot of importance, but unfortunately, because of being costly and because of being less available, this is not employed much. And another, disadvantage with serum tryptase is that it is to be done in the first hour of the reaction, and usually we miss that. By the time patient reaches us, those first 1 to 4 hours, some say, they are already gone. So serum tryptase, it has a magic figure 11.4. If it is more than that, it confirms an immediate IgE mediated reaction or an anaphylactoid reaction. If it is less than that, then you can repeat the baseline after 4 to 6 hours, and then see if there is a raise of greater than 30%, some say 20%, then it happens to be an anaphylactic reaction or anaphylactoid reaction. So another method of ruling out an IgE mediated reaction is the fluorescent enzyme immunoassay, or the FARDIA as you call it. But this is available for only some drugs, a few drugs only this is available. And in India, you hardly get a place where this is done for drugs. There's drugs like penicillin, drugs like papain, and then opioids were done on this, but not much. Then basophil activation test. This offers quite a lot of promise, but it still is in the research area, not commercially available. Same as probably lymphocyte transformation test. This is used for delayed reaction, but BAT and LTT, they are going to be the future of drug allergy, non-invasive drug allergy testing. Another 5 years or so, this offers quite a lot of promise. Then coming to in vivo tests, skin testing is actually employed. It's very common. Skin prick test. This is also called the percutaneous test. Then the intradermal test. Again, the test done on the skin. You inject this drug into the dermis part of the skin, and You can see in the diagrams, then we measure the size of the wheel, then you have obviously, you have to validate this test with a negative and positive control, and then there are different guidelines by which we measure the wheel size, and then accordingly decide whether it's a positive or a negative test. In skin tests, this is being commonly done many centers, but before coming to that mistake, there's another way of doing skin test, is doing patch test for the type 4 allergic reaction for contact dermatitis most often. Sometimes for the fixed drug eruptions as well, this can be utilized. We put up a patch, and then after 48 to 72 hours, we read this patch and then find out the reaction and then judge accordingly whether this was positive or this was negative. But this is for type 4 reactions. Coming back to skin testing, this skin prick test or the intradermal testing, the right concentration of the drug used for testing, that's very important, because it so often happens that we use the wrong concentration and then derive a wrong conclusion out of it, usually false positivity out of it. So the right concentration is to be used. These are a few authorities. This is the ENDA, the European Network Drug Allergy Network, and European Academy of Allergy and Clinical Immunology. They have given these correct drug concentration for the skin prick test and the intradermal testing. And these concentrations also be used. Otherwise, if we use the full concentration, that might, give us wrong results. This is one authority. There are other American authorities as well. These are the American Academy authorities which have given the concentration of the drug. If we do not use the right concentration, this becomes irritating concentration. We have to use a non-irritating concentration. If we use irritating concentration on the skin, that will obviously irritate the skin, and we'll have a huge wheal, we'll have a huge erythema, and this false positivity can come up. So correcting the mistakes is the key. For example, this ceftriaxone injection, we often test the patient using full concentration for testing. So lots of false positives, and obviously wrong labeling of the patient. Then the technique has to be correct. You can see on the left, a wrong needle is used, and the wrong technique is the injection is going too deep. It's going subcutaneous. On the right is the right technique. Intradermal technique, the bleb should be raised. The quantity of drug too is very important. The quantity of drug should be 0.02 to 0.05 ml, and not more than that. If we inject more than that, it will again give a false positive result. So pricking too deep, injecting excess volume of drug, these are another mistake which can happen in drug testing. So we need to correct them. And you see the result of wrong testing on the left side, and then right testing on the right side. Even the marking, you can see on the left, they have marked this, the huge circumference around, and the marking has to be just outside the bleb, and then wait for 15 to 20 minutes in case of intradermal test, and then check out the reading. If that has extended more than 5 mm or more than 4 mm, then only we say that this testing is positive. And obviously, after using the correct concentration of the drug, that's where we need to correct ourselves. So that was all true about the IgE-mediated allergy. Skin testing would give us a clue about the IgE-mediated allergy. What about the rest of the allergy? There are many ways patient can have allergies too, or adverse drug reaction to a different, whatever drug we test with. So the ultimate belief of whether patient is positive or negative to the drug as regards the adverse drug reaction is the drug challenge, as we have said. It's also known as the graded drug provocation test. We start with a very small dose and keep on increasing at the most for 3 to 4 steps. And if the patient tolerates them well, obviously we keep intervals in between. We'll come to this procedure later on. But to undergo a graded drug challenge, the patient needs to be fit for this particular test, because it's an invasive test. So these patients should not have any decompensated cardiac illness. Patients should asthma should be under control. If patient is asthmatic, then a baseline blood workup should be normal. Patient should be off antihistamine. Patient should not be on beta blockers, ACE inhibitors, which can prove out to be fatal if there is adrenaline drug, if required, may not work, and for anaphylaxis if at all that happens. And yes, a 4 to 6 week interval from the previous drug reaction is very important, because from the day of reaction up to 4 to 6 weeks, it takes histamine stool to get replenished inside the mast cells. to allow mast cells to have their stores replenished of histamine, then only do this graded drug challenge test. Now, all this is to be done. These drug challenges are to be done under a controlled setup where any untoward reaction can be handled very well. So when we know when to do this drug challenge, we should know when not to do it. Obviously, wherever in whatever reaction there is an organ involvement, single organ involvement, then not to do it. Or there are severe reactions like severe cutaneous drug reactions like T and SJS and AGEP, etc., etc. And the organ involvement, I told you, nephritis, hepatitis, or hemolytic anemia, or if the previous reaction was a severe reaction with the drug, it was around, it was 2 to 3 grade anaphylaxis with that drug, never ever do graded challenge with that particular drug. So the procedure, as earlier we discussed, incremental doses are to be given after interval of 15 to 20 minutes each, some say 30 minutes as well. And the number of steps should not be more than 4, a maximum 4. If the number of steps are more than 4, then that gives a false reassurance to us, because that ends up in desensitizing the patient rather than telling us that the patient is negative to that particular drug. We'll come to that maybe a little later. This is one of the examples of a protocol. You give 10% of the dose first, then wait for 20 minutes. If everything is fine, give 20% of the dose, then wait for 20 minutes, give 30% of the dose, and finally, if everything is hunky-dory, then give 40% of the dose. Dose means the therapeutic dose. For example, amoxicillin is there. 500 is the therapeutic dose. Start with 10%, 50. Then give 20%, give 100, okay? Then give 30%, give 150 accordingly till you reach 500 milligram dose. And the final observation period has to be 1 hour. And if everything is normal by that time, so we interpret the test to be negative. So if there's a negative reaction, patient can consume the drug safely, and we can assume with a great bit of surety that the patient is not allergic to that particular drug. The patient, if labeled allergic to that drug, stands delabeled, and that's a great service. And if the challenge is unsuccessful, if the reaction is positive during any of these steps, we tell the patient not to use this drug, and we provide the patient with an alternative class of the drug. And of course, we educate the patient with the EpiPen training, the adrenaline training. We tell the patient to keep adrenaline, with him or around him quite often, because sometimes, because of the accidental exposure or because of some other reaction by some other related drug, patient might end up having a reaction, and they should have this EpiPen nearby. EpiPen is not available in country, but there is a local jugaad. You can give this, we can discuss that if that comes in the discussion, how to teach patients how to use adrenaline at home or anywhere else if he gets or she gets a reaction. Now, this coming back to our case where this young boy, this needed surgery. What we did in this case, since patient surgery was a must, we selected a preoperative drug from a different class of drugs, levofloxacin. Patient had a reaction with augmentin and ceftriaxone. We thought, let us hope this quinolone would work, because this was idea. I mean, the drug we took this drug, decision of this drug, in consultation with the CVTS department, the operating department, because they had to decide ultimately which antibiotic is to be given or not to be given. So we challenged the patient for this drug. We did the graded challenge for this drug. It was carried out successfully. Patient tolerated the full dose of this. This was the way it was done. This was the concentration for SPT, then intradermal test, and then this oral challenge was done. It all was negative. Patient was operated under discover uneventually. So in this case, this in fact we got published as well that time, as it was 2017 as a case report. Then there's another situation, a desperate situation, where patient needs the same drug which the patient has a documented allergy to. Either there has been anaphylaxis in the past, or in your graded drug challenge, you have proven that this patient is allergic to this drug. What to do then? There are many situations, where the patient needs that drug, what a patient is already known to be allergic to, like, iron salts needed in patients where there is, severe iron deficiency anemia, and the patient is proven allergic to iron. Then rituximab in the refractory lymphoma patients. There are patients who have anaphylaxis with rituximab, but they don't have a choice but for that drug. Syphilis in pregnancy or syphilis otherwise also. So, this somebody allergic to penicillin, needing syphilis so badly. So in that case, this answer lies in something called drug desensitization. What is desensitization? A temporary induction of drug tolerance. This also is called as you tune up the patient with the same drug which patient is allergic to. Start with it with very small dose, keep on giving it in short intervals till patient tolerates the maximum dose of the drug. This is called drug desensitization. It has different regimens. This procedure, rapid administration of incremental doses of an allergenic drug, just like drug challenge it is, but starting with a very small dose. Even if there's a reaction in between, you treat the reaction, but do it. There are around 12 steps to 16 steps, sometimes 14 steps or something. Actually, it's for different drugs, there are different regimens which we have been adopting from time to time. So how does this drug desensitization work? Actually, nobody knows. These are a few mechanisms which are postulated. Regardless of the mechanism of the drug reaction, whether it's Ig mediated, non-Ig mediated, desensitization often works. How does it work? There are a few mechanisms which have been postulated, like alteration of expression of receptors, blocking antibodies, then internalization of the receptor on the mast cell, then sometimes activation of the inhibitory receptors. These are postulated mechanisms, but nothing much has been proven as yet. But what is most important is the results, because patient tolerates this drug by virtue of this desensitization. But these all procedures are to be carried out obviously under a very well-controlled setup. And after desensitizing the patient to a particular drug, if you want that patient should remain free from allergy from that drug has to be continued for long. You cannot take a break. If you take a break of 48 hours from the last dose, then you want to give that drug again, then you have to desensitize from the beginning all over again. So this often happens in case of patients where you give chemotherapy, you have to give chemotherapy, you desensitize for some chemotherapeutic agent which the patient was previously allergic to. And then after 21 days, after 4 weeks, patient needs that drug again. And in that case, you need to desensitize from the very beginning. I mean, start the procedure all over again. But otherwise, for example, somebody is desensitized with aspirin, needing aspirin for a long time. You can carry that on for every day. Don't give a break of more than 48 hours, and the patient tolerates that drug very well. So one of the these are different regimens. I am here showing clarithromycin. You can see it's a 14-step protocol for this clarithromycin desensitization, starting with a very small dose, 0.03 milligram, then doubling the dose every 15 minutes. Then patient keeps on tolerating until patient reaches the maximum dose needs to be given, 503 milligram in this particular regimen. There are different regimens, different protocols given by different authorities, but the primary principle is the same, almost doubling the dose every 15 minutes, starting with very small dose, 1 by 10,000 of the dose, maximum dose, or sometimes 1 by 1 lakh, sometimes 1 by 1,000 of the dose, depending on the various things like route of the drug, previous reaction, and many other things. So this is the serial dilution which actually have been adopted for the clarithromycin drug. You take from the stock solution, you take 1 ml, dilute that with 9 ml of the water, it becomes 1:10. Then take out from that second vial 2, take out 1 ml from that, dilute it with another 9 ml of the water, and keep on doing these serial dilutions till you reach the dilution which you want to start with, and then give the dose accordingly. So I would like to share this case of iron allergy with you. This recently, in this year only, we had this 38-year-old female. She was a referral from clinical hematology to us, a severe iron deficiency anemia of hemoglobin 5.6. And she was highly symptomatic. In fact, she had landed into this congestive cardiac failure. Because of this severe anemia, and the underlying cause was obviously menorrhagia, and was planned for hysterectomy, but nobody was ready to touch her till her hemoglobin would be restored. She would be built up. So that's how she landed with us. And this patient did not have history of allergy to any other drug. So 2019, she had an urticaria with iron carboxy polymaldose infusion, though this is supposed to be less allergenic, but she had had an urticaria with angioedema with it. 2020, she had urticaria with throat tightening after 1 hour of iron sucrose infusion. Then 2021, she had been given oral iron. She had a doubtful angioedema to that also. Then 2022, she had a grade 3 anaphylaxis with blood transfusion. So the picture was kind of very horrible. And all these occasions, she needed hospital admission, which is which makes us feel that all the time the reaction she developed was quite severe. So our line of management, we give a trial of oral iron, gastro-friendly iron preparation, but the patient had gastritis, and then she developed some objective symptoms, subjective symptoms as well. So we managed her symptomatically. So the answer, would lie wide, because oral iron's the trial failed. She is allergic to every preparation of iron. So does the solution lie? Can anybody on the audience tell me? Patients allergic to every form of iron. No iron is patient tolerate. Every iron is allergic in this patient. So what do? You need to build hemoglobin in this patient. Patient does not tolerate blood transfusion even. So obviously the answer lies in iron desensitization. So we took up her, it was 14 February this year only, 12-step protocol was carried out. We took up FCM iron, the iron carboxy polymaldose, supposedly less allergenic, though patient had reaction to this as well. In 14 steps, we desensitized this patient, 12-step protocol. I'm presenting this case because, once we did this case, I tried to serve the literature, and this was, to my knowledge, to our knowledge, best knowledge, the first iron desensitization case from our country. So this is, this ICU picture. This dilution, how did we do the dilution? This was, the dilution was 500 milligram per 10 ml. This means 50 milligram per ml, this concentration was there. And actually, yeah, this is how we did it. This is the 12-step protocol. We started with a very low concentration. You can see the concentration over here. We started with 0.02 milligram per ml. The dosage which was available as stock was 10 milligram per ml. Then, that 10 milligram per ml we had to dilute, do serial dilution. We, 2 milligram per ml, make it 2 milligram per ml because this, the concentration was 50 milligram per ml. This was 500 milligram per 10 ml. That means 50 milligram per ml. Then we had to dilute it up to 2 milligram per ml. 2 milligram per ml, this much quantity we needed for all these. It turned out to be around 250 ml of the dialone, and then make 2 serial dilutions of it. One 0.2 milligram of it, then 0.02 milligram of it. And once we did these dilutions, we started giving it in 12 steps, and fortunately, this whole procedure was uneventful. There's a formula of making these dilutions. I hope all of you are pharmacologists, and you might be knowing this better than me. C1N1, C1V1 is equal to C2V2. C1 is the initial concentration. In this case, it was 50 milligram per ml. Then V1 is the volume. The volume out of that initial concentration you need to take. This is what you need to derive. The rest of the 3 parameters given. C1 is given, C2 is given, V2 is given. What is C2? C2 is the concentration, next concentration needed. The next concentration needed was 2 milligram per ml out of the stock. Then V2 is the volume. Volume of the next concentration we needed was 250 milligram, 250 ml. So we can easily derive this V1 out of this, knowing C1, C2, and V2. C is the concentration, V is the volume. Initial concentration, final concentration, initial volume, final volume. This formula is very easy, and it tells you how to make these concentrations of different agents whenever you need to do this desensitization and make dilutions. So this patient, a 12-step protocol was carried out. The procedure was uneventful. In fact, it took us a whole day. In fact, my resident on that particular day, it was a Valentine's Day, 14 February. I can share you with his status. He was there for the whole day. So his could not meet his Valentine. He wrote my allergic Valentine as a status on WhatsApp. And do I have some time? Better than one more case? Okay, shall I or shall I stop? Just one case. This case is very close to my heart because this case, in this case, there was a mysterious drug which was responsible for causing drug allergy in this patient. My topic was detection and desensitization. Detection is done by detective, and that's how a drug allergist has to be. 22-year-old female, she was admitted with surgery department of our hospital from 3 days as a case of rectal prolapse. She was planned for surgery after 2 days. Her baseline investigations were normal. But where do we come from? Day one, she was had generalized rash after receiving IV levofloxacin, and she had no systemic symptoms that time. Day two of admission, she had anaphylaxis twice. Within 5 minutes after receiving IV dextrose normal saline, the second episode occurred 10 minutes after starting IV ringer lactate. So the past history, she had features of allergic rhinitis, she had intermittent asthma, both of them were ignored. There was no history of drug allergy in the past. The patient would tolerate most of the commonly used drugs like antibiotics, NSAIDs, and PPIs, and even local anesthetics. So the culprit drug was to be found. We were called for this only. We were called to be this Sherlock Holmes for this procedure. So was this IV levofloxacin which was causing the problem? Was it IV DNS? Because within 5 minutes of DNS, she got a reaction. Or was it IV ringer lactate what caused problem in this patient? She had a terrible anaphylaxis, remember. Why would it be IV levofloxacin? She has been tolerating most antibiotics in the past. Why would she, this be IV DNS for ringer lactate? Because these are fluids which are very compatible with our body. Is it something else? So we had to think a little out of the box, keep our mind open on this. So we reviewed the history. At admission, just one point out of it, at admission in emergency room, she gave one more episode of generalized rash, shortness of breath, and vomiting just after her physical examination was carried out, which included the per-rectal examination as well. So was this the punchline we were looking for? We had a consensus, and surgery on her was deferred by 4 weeks to make her, histamine results replenished and then challenge her. So we planned the unusual this time, not the usual thing. We, at 4 weeks, we tested her with levofloxacin and metronidazole. They were negative. These drugs, because this is what surgery people told us they would be using them at surgery time, then they were negative. Then we did an SPT for latex. This was something very unusual. It was positive. Well, SPT is not be all and end all of everything. It could be false positive. We did a specific IG for latex. That again was positive. And finally, to make things very, very clear, we did a puddle test with SPT, with latex, and that again was positive. Puddle test, we prepared a antigen on our own using glove, cuttings from the glove, and that again was positive. So the cat was out of the bag. I mean, the problem was very, before us. We were looking here and there. Mirza Ghalib says that dhool chehre pe thi, hum aina saaf karte rahe. The dust was on my face, but I was cleaning the mirror. How fool of me. The latex was the culprit. So the recommendations we gave were latex-free operating facilities to be used for her, even post-operative facilities as well. So a pre-operative medication regimen as well was, this was suggested, though some authorities don't agree with it, maybe you as well. And the triumph was that the surgical procedure was uneventful, messy with the cup, and we were with this patient's surgery, successful surgery. And later on, the patient's do's and don'ts were counseled for this avoidance in future, and workup for allergy immunotherapy was also taken up. Unfortunately, patient did not turn up later on. He went to Bangalore for study, and that's how it was. And this paper too got published, as a case report after we did this procedure. And I will not take much time. I have another case, but let it be. So coming to the our experience at SCIM, this is till May 2023. 2017, we started this procedure as a regular feature. We had done more than 350 procedures. Now we have crossed 400. So, all challenges for all these drugs we have done, and 34 patients tested positive out of the 351 we had tested till May 2017. 34 out of 351. It's not even 10%. So the false labels were again more than 90%. Yeah, 90.3% by false labels. And we have done a number of desensitizations as well, around 40. We have crossed 50 now of late. And this is the world data. You can see Singapore data says 75% labels are wrong. UK says 90 to 95%, and USA data says 90% of labels are wrong. Ours were almost at par with it. I think the story is universal. No blame to our country. So the take-home message is that drug allergies are largely overdiagnosed, mislabeled, and delabeling is badly needed. And what can it do? Reduce cost, antibiotic resistance, and optimize patient outcome. True drug allergies have definitely workable solutions. And for all this, we need an interspecialty coordination. That's the most important part of it. As they say, if you want to go fast, go alone. But if you want to walk far, walk together. Thank you.
So thank you, Dr. Qurashi, for your excellent presentation.
Yeah, I think Dr. Taha had made excellent presentation as on the drug allergy and desensitization. Now we'll take some cases by Dr. Shambo from our side. Okay, so then we can have some house discussion.
So we will discuss one case, and specifically the topic is like that, the role of us clinical pharmacologists in detecting, in managing drug allergies. So let's start. Presentation. So we will discuss one case here. This was a case from our clinical pharmacology OPD at School of Tropical Medicine. So she is a doctor of 33 years. Just before taking her COVID-19 vaccination, she visited us. So for 6 months, she was eligible for COVID-19 vaccination, but due to fear of this allergy, drug allergy, she was not taking that. Background, multiple drug allergy, of drug allergy with multiple agents in last 9 years. And what we had done, a detailed history taking and clinical examination. So we'll discuss the episodes, starting from the first episode, where it was into 2012, January, diagnosed with temporal lobe epilepsy and initiated with carbamazepine. So after 2 days, developed macular lesions all over her body with severe itching. So carbamazepine was deprescribed. The rash was subsided with levocetrizine, little bit short course of oral corticosteroids and calamine lotion. But the thing is that we all know now the HLA phenotype is mandatory before initiating carbamazepine, whether the 1502 allele is there or not, according to current level. But it was in 2012, I think that was not there in the label, and 1502 allele was not done there that time. Again, the second episode, which was on 2012 July, another episode of absent seizure happened. Now initiated with lamotrigine and levetiracetam. After 6 weeks, developed rash with fever. Workup done for different etiologies of fever. And ultimately, after 15 days of fever onset, admitted in some acute care setting. Foul smelling discharges from different follicular areas of skin, including scalp and axilla. Leukocyte count was quite high. You can see 40,000 with eosinophil 34%. So she was diagnosed with DRESS. The treatment started with IV depot methylprednisolone. Lamotrigine was withdrawn and levetiracetam was continued. Finally, discharged with oral prednisolone, which was continued for 6 months. Now, third episode. She had a cut injury in 2017, started with amoxicillin clavulanic acid, developed high-grade fever with macular rashes and itching from day 3 of initiating that amoxicillin clavulanic acid. So on day 5, it was deprescribed. Again, treatment with oral prednisolone for 7 days and cetirizine. Finally, fever and rash subsided by day 7 and day 9. Finally, the 4th and 5th episodes. 4th episodes was like that, presented with acute onset urticaria and hypotension. Only clue was that she has some exposure to certain chemicals doing some work in her microbiology lab, and ultimately admitted in hospital emergency, resuscitated with adrenaline. So this was the 2017 episode. Finally, the 2020, there was a road traffic accident. She was prescribed with cefodoxime. Again, after 5 days, rashes with fever. So immediately, now she was feared because of that previous episodes of DRESS. She stopped herself immediately and treated with prednisolone and levocetirizine. It was subsided by 10th day. So there are 5 episodes. Now she is asking whether she will take the vaccine, yes or no. So what is your opinion? Whether she can take and which vaccine? Any comment?
One is heart only, and risk of the allergy. At the same time, the other risk of getting unprotected. Okay. On the other hand, if there is an event like this, say for instance, if this happens, if you take vaccine and there is a serious crisis, that would change a negative message.
Absolutely, it is good isolated case. Definitely as an isolated case.
Yes, sir.
Her profession is this lady's profession is she's doctor now. Something where she is more prone to get COVID and other things. So protection was even more equally important. So it was a tightrope, walk on a tightrope. But at the same time, going by the ICMR guidelines of that times, not to be given at all. But going by the American guidelines or the guidelines, we can do a graded start with the very small dose and then go ahead with that.
One thing, that practicality of giving a vaccine at the time is really has been denoted by Sir and Dr. Taha and all. So, but there is one concept which we need to bear in mind for the future such things. Drug allergy per se is not a risk factor for vaccine allergy. It has been documented well. So we should keep in mind that drug allergy is not for the time of the pandemic, but otherwise, drug allergies are not a risk factor for any vaccine-related allergies because they have different mechanisms, it has been said. So this is a point which has to be bear in mind. Now let's see that what is thing happening in Shambo's case.
So first of all, I want to respond to my sir's comment, that is Tripathi sir's comment. Sir, want to go back to that time, and that time he want to stop ask the patient not to take the vaccine. But I think, sir, you are now sitting in this time, and now you are so confident, and then you are going back to that time. You are this time you were sitting, so that confidence give you more favor in not taking the vaccine. But at that time, the scenario was like that. We are losing so many friends daily. It is very hard to tell one of our people not to take vaccine. So it is again, as you always teach us, to balance between risk versus benefit. So risk of drug allergy here versus risk of getting COVID. So we need to balance that. So there are certain clues. Yes. Yeah, that is also well taken, sir. But we need to analyze each episodes very critically. So even if we go back to the first episode, so first episode was with carbamazepine, and what type of reaction it is, what type of hypersensitivity reaction it is. So we need to assess that. Second episode was with, again, the lamotrigine. This time it was a drug fever, or even it develops DRESS. So what type of hypersensitivity reaction it is, again, we need to understand. Third, there was again amoxicillin clavulanic acid induced some macular rashes. The duration, the temporality is almost 3 days. We need to understand the mechanism. One important issue when we are dealing with, when we are asked about the COVID-19 vaccine, this gives us a lot of help. The IV depot methyl prednisolone was used. And we know that in the IV depot methyl prednisolone, there is one excipient used, that is the polysorbate. And we know that in the COVID vaccines, specifically the Covishield, I think, there is an important component, the excipient is polysorbate. So it was well taken. Again, there is a very, so we can nullify that risk of excipient allergy here, because already the patient got methyl prednisolone without any event. Fourth and fifth episodes. Fourth episode is typical a type 1 hypersensitivity reaction. The anaphylaxis is there due to some exposure to certain chemicals. And fifth episodes, again, that is a delayed type of hypersensitivity reaction with some specific antibiotic, that is cefodoxime. So ultimately what we had done, we had evaluated him thoroughly. Yes, sir. Yeah. So when we had a detailed evaluation, the most important history was the previous vaccination history. That is important. We took in details. Specifically, again, we need to take the history of hepatitis B and influenza vaccination, because they carry some similar type of excipients like the COVID-19 vaccines. So there were no events. This doctor took both those vaccination very recently. So ultimately we had advised to take vaccine, and she took vaccine without any event. So why this is important? Because as an drug allergy specialist, or even we can call as clinical pharmacologist, we need to understand the basic mechanism first. If we know about the mechanism of drug allergy, starting from the type 1 hypersensitivity reaction, how this happens, I am not going in details, but we know the muscle explosion, how it happens when the ID is going to attach with the Fc epsilon receptor, and again the antigen will enter. There will be some reactions, and they will release those mediators. Most importantly, it is also important to note that sometimes the patient will tell, I do not have any, I took paracetamol previously, I don't have that reaction. This time I took paracetamol and I have reaction. Why? So for allergy or type 1 hypersensitivity, there is a requirement of sensitization sometimes. Again, not always the sensitization is a must thing, but mostly sensitization should be there. So here we can understand how the patient can be sensitized. And after certain times, again, re-exposure of that particular allergen can give the allergic reactions, the mast cell degranulation. So type 2 hypersensitivity is a different ball game. So that is a locally reaction. The targeted locally means that this is very cell-specific reactions when some antigen is sitting on top of the cell and some antibody is coming to touch on that particular antigen and then invites all those natural killer cells or complement systems that can cause the lysis of the cell. Yes, there are other parts like in case of myasthenia gravis or in case of even the hyperthyroidism, Graves' disease, they are also the example of type 2 hypersensitivity reaction, but today's discussion is not on that. And type 3 reaction is the immune complex deposition. Mostly the drug allergy, what we had discussed, they are either type 1 or type 4 hypersensitivity reaction. So this is again important to understand the mechanism of the type 4 hypersensitivity reaction. So depending on the type of cytokines released by the interaction between antigen presenting cell and the T-naive cell, that will govern what type of proliferations, what type of differentiation happen in the T cell line. And depending on that, the TH1 or TH2 or even TH17 type of cells will come, producing different types of manifestations. And type 4 hypersensitivity reactions, they also have four subtypes. So what is important, if we go through the history, we can understand the type of hypersensitivity reactions the patient is facing. Now, if this particular doctor wants to do the skin prick test for drug allergy evaluation, what will be your opinion? So first of all, if she want to do the skin prick test for all those drugs she was exposed, to check whether it is right. Again, if we go back to the history, if we analyze the type of hypersensitivity reaction, then what we will find, the first episode was type 4 hypersensitivity. Even that third and fifth episodes was type 4 hypersensitivity. Only the fourth episode, which was type 1 hypersensitivity, which was to some unknown chemicals. So as Professor Tripathi sir was mentioning, we need to explore more on that part only, why the patient had developed type 1 hypersensitivity reaction. For that purpose only, we need to do the skin prick test specific to the specific history given by the patient, not for all those drugs. So this is very important, and that is why the mechanistic understanding we need to know. And as there is a terminology of drug-induced disorder, and here we are talking about drug hypersensitivity. We need to acknowledge that drug as an etiology here. So for that, as already Dr. Qurashi has mentioned, the importance of history taking. So we need to have a detailed history taking, detailed medication history taking, followed by some clinical methods. Here also we need to little bit expertise. We need to become expertise on some specific skin manifestations. We know what is DRES, when it is SGS, when it is exanthematous pustulosis. So these things we need to know about, because we need to exclude other things too. And finally, some lab tests are important, as some routine blood tests, skin prick test
to understand the type 1 hypersensitivity only. Again and again, we need to emphasize on that. The lymphocyte transformation test is the future because they can tell us about the T lymphocytes. They can guide us about the link between T lymphocytes and different types of hypersensitivity reactions, different patterns of type 4 hypersensitivity reactions. Patch tests are important to understand the type 4 hypersensitivity reactions. Tryptase level, again, only for the emergency purpose. Here, the HLA phenotyping is important in some subset, but again and again, we need to give emphasis on that. History taking is the investigation. It helps in the diagnosis and treatment in evaluating drug-induced disorders. So as we are talking about this HLA concept, we need to know this pharmacological, immunological receptor interactions. And sometimes the previous concept of hapten is replaced by this PI concept, where there are certain HLA phenotype that had been shown by some antigen presenting cell that can be responsible for some specific serious type of adverse drug reactions. Already these HLA phenotypes had been identified. If we can test this, we can also predict this type of unpredictable episodes. We know this drug allergy or this type of severe adverse drug reactions, often we called as type B or Bijare type of hypersensitivity reactions, which cannot be predictable. But if we can do this type of test, we can predict those things. So finally, this is taken from our current updated NMC DM clinical pharmacology curriculum, where they're mentioning that clinical pharmacology is the study of drugs in humans. Clinical pharmacologists are expected to have in-depth knowledge of pharmacological principles as well as clinical medicines, enabling them to provide a wide range of service to society in variety of settings. As Dr. Qurashi has mentioned, the importance of de-leveling, importance of identifying the correct drug allergy cases. If we apply these two things, our pharmacological principles with proper clinical medicine knowledge, then we can address this very neglected issue. Drug allergy is a neglected issue well, and we can serve our society. So we need to understand the basic mechanism of drug allergy, how to confirm the diagnosis, and finally, the treatment should be a multidisciplinary one. Thank you very much.
Thank you, Shambo. So just to put it in a very nutshell, what probably is, the drug allergy is still a phenotypic classification. We classify drug allergy in the form of phenotype. So in the phenotype classification of drug allergy is immediate or delayed. Immediate means when the symptom started from when the patient took the drug for the first time. It's not that the patient took the drug for the first time. That's the first rule of the patient took the drug and when the symptoms start. Symptoms are mostly cutaneous, but it could be mucocutaneous related to diabetes. And that decides whether the disease is start more than to start. Say immediate and delayed. There is a first step in working out of the drug allergy. And then in the delayed, we have various phenotypes. Just we have to be addressed, it could be in it could be a tent or it could be some organ specific symptoms, which may be not having any significant manifestation. So important to understand the concept is that the delayed symptoms can be even up to 8 weeks or more from the date of taking the first dose of the drug. It's very important to have that concept in mind. Because even within the 8 weeks, 2 months period before the symptoms start, the patient can see the drug taken 2 months. It is prior to the onset of the symptoms. So on this, we actually formulate about 2 to 3 the substitution drug, and then the formulation test, the test for immediate test and test for delay. One other thing also is important to define is that immediate reaction could be an ICP test, that is taken by initiated like test on the or it could be non-ICP initiated direct active challenge. As we find the new market mechanism, we find the alone, so there actually is activation of the emergency RSP. So this is one another important agency because this drug is not be taken up for the testing, so it is an individual cause master for the testing. So the now the recent update is a de-emphasis on the skin testing and more emphasis on the graded drug study or the drug study. Why? Because there are many other mechanisms which are so unknown to all of us. Number one. Number two is that activities encompasses all scientific reactions in type 1, type 2, type 4, type 6. The third thing is that activities it helps in understanding the entire spectrum of the part. It is important when important caveat is that so the spiritual challenge should not be done for any or when there has been any organ fix, it is what the otherwise, we will go about in evaluating and as Taha says, the other hidden agents which have to be in the consideration. One is the method, another important agent in the phase of it. Also going to anything about the for the phase of the so these are some of the important areas which is really mind by the and then we ourselves for what how to do about. And if the drug cannot be used the drug so the desensitization. Can we desensitize any drug? It's difficult to say. It may not be all drugs that don't desensitize. But definitely those drugs have a type 1 hypertension. But we have to follow this process. Nowadays, the drug challenge has come down to one step or two steps. We need to have a fourth step, to then one step of drug challenge. But you can take it into the tolerance that it has to be done and started on the drug as long as the drug is in the body, in it is being tolerated once it's 48 hours, but almost the drug is done. Temporary tolerance, the multiple mechanisms but now not nothing has been really indicated as we have wanted. Can you take any questions now? Any questions that we
for reactions other than anaphylaxis? Is there any specific time period where the person has been taking for a drug for so long, beyond which we can rule out or we can say it is unlikely to be allergy? This anaphylaxis can occur after any dose of the drug. For the other reactions, it will be time period where beyond that we can say it is unlikely to be the drug for the reaction.
Okay. Somebody take it.
So, yeah, first of all, apart from anaphylaxis, I am telling you one example. Just yesterday, I had faced. I will show you the pictures also. There is one bullous pemphigoid for 7 days, 7 or 10 days like that. The patient was consuming sitagliptin for last 4 months. Okay, and now she is presenting with this bullous pemphigoid. So we had withdrawn that drug, and most probably the patient is having the sitagliptin induced bullous pemphigoid. So there is a 4-month time duration. There are many evidences that suggest there is this temporal relationship may in sometimes can up to 1 year also in some specific drug rash, some specific type 4 hypersensitivity reaction. When we are talking about bullous pemphigoid, it is important to note because bullous pemphigoid is a overlap between both type 3 hypersensitivity reaction and type 4 hypersensitivity reaction. So we know the immune complex deposition, the type 3 hypersensitivity reaction. This will take a long time to. Sir, your take.
One example of negative disease, have also come across it. It's a very good question. Type 4 hepatitis, contact with type. Making sure who tolerate local immunization, who will probably planning to use. All of a sudden, as we are 40, 45, you start getting contact with cells because of immunization. Because of other cases, one that has quite common finding. I often come across. I was already immunizing till this time, either 40, 45, 50, something. So, I mean, dogmatic medicine, the 89 over, anything can happen in the country. There is a positive insight in every mind that why are we differentiating different things? Why this cutoff of system? What is that is happening? What is so possible? So what we usually find out is that if it is a type 1 hypersensitive reaction, it requires the inhalation of the it has to go and bind itself to the high frequency receptors and the masses, and when the allergy in the form of the drug, it will come to persistence, bind to the high frequency receptor, found the IC for this possibility, then the downward depending signal for this. That means there has to be the presence of the IC. That is for the sensitization. And when you see the muscle, you will get something. We may be sensitized to do more of the thing. The mere presence of the IgG or the mere presence of the IgG bound to mast cells, it does not entail that we will have an allergy. There is a universal phenomenon having an allergy to the phenomenon. So why is this started? Because this is the time when actually the blood is going to the system, then it will bind to the high frequency down to the muscle, which will consider the important element in our body, and then degenerate. It actually there is a preformed IgG already in the system. Preformed IgG is a type 1 hypersensitivity. Type 1 hypersensitivity actually there is a window of opportunity to protect, a window of opportunity to see in the form of successful desensitization, as we can have. So we can have but from the IgE also, but now has developed the reaction because now again when the medicine has gone into the blood, it gets reacted with the IgE, it causes physical behavior, it causes symptoms and causes. It is rather interesting concept. The concept is that the patient gets de novo sensitized. That means the patient has not taken the medicine before, has taken the medicine from day one, is sensitized. It happens in certain when actually genotypes, that's what pharmacology is very important. And this is a de novo sensitized, so there is a course of the medicine. It is de novo sensitized in the first day, and the reaction and the system similar to the actually the cycle has a system, but on day 7 or day 8 in the medicine. This happens in few of the drugs, but this concept is also there. Otherwise, majority is in the preformed IgE, and all the other, apart from the more than 6 stars, is the non-IgE family. So, actually, yeah, after this long discussion, one point is absolutely clear that if we are to control this drug allergy or sensitization, whatever we want to do, we should have a very clear knowledge of pharmacology as well as clinical. We shall have to combine these two at a time. And Shambo was very correctly saying that this part, be it in medicine or in pharmacology, that is perhaps much neglected. And I don't know how many works have been done on this issue.
And at the same time, microbiology has got a very specific good to do at the same time. Because we are not discussing about what majority of the reactors are type 1 and type 2. We don't know how many cases are there. We are using out and out of type 2, type 3, or type 1. So I think out of your conversations, I have to remember one recent incident. 3 months back, I was testing a patient for tuberculosis. This patient had come to us as a case of allergy with lidocaine for a local anesthesia dental procedure. Had allergy to lidocaine. This indication came to us. We gave the next drug we trust to test the patient for tuberculosis. It's a substitute is considered to be less cross-reactive to lidocaine. Young boy he was, we tested him. While testing him, he again had reaction. He tested positive on same testing due to the cane as well. But when I was doing his testing, they won't come to what Sir just said, neglect. I was asking him, engaging in conversation. I asked him what his family is like. He said he recently had a terrible tragic death of his younger brother. A sudden death which happened during the night when he was at his friend's home. Then the boy said that we suspected. I told him, was there any reason? He said, no, absolutely healthy. But he said that my brother died at friend's home and we filed a case in the family. We did an autopsy of this boy. We thought that friend's family did some foul play and we did autopsy of the body which was inconclusive. Therefore, for doing the autopsy. Then I asked him, did you your brother consume any drug there? He said, no, nothing much. Just he had some this headache, he had a migraine, he had taken some tablets for that. I told him what happened to him. He said he developed heart attack. I told him what are the symptoms. He said he had a choking in the throat. And then immediately got on. Probably he had died out of delirium edema because of some anesthesia, which likely he must have taken. I don't know. It was just what I presumed. The amount of neglect. It had gone after autopsy, which was inconclusive. The case was filed against the family, but nobody ever had thought of this patient. One important cause, likely cause to be like many people around after getting here and there, and we are missing it out. I think I want to know. What is the time? Follow the applying of the class after another thing is what is the scenario of I have come across some they have asked me what the same. Children develop suspected as per the protocol, don't follow the hypertensive for administering an antibiotic. Before the answer is given, that is fast. I would like to tell you one thing. This question is applicable not only for infants and children. This question is applicable to experts of ages, old age people, and also in pregnant. So there are different issues of anyhow, but the questions may come. Definitely it could come. I will try to be as succinct as possible because of that. And first of all, a patient admitted taking a drug developed from rash, and it is suspicion that the drug being injected or given orally is causing the reaction. So whether we can do a drug differentiation at that stage and then we can start it. The answer is a resounding no. Why? Because this is drug desensitization. The mechanism is very complex. The drug has to be washed out from the body completely. The immune system has to come back in the homeostatic state,
And then it has to be challenged in a very minuscule process and process. So there is a deviation. It's not whether it's a direct innertion of the regulatory cells or innertion of the regulatory cells or the blocking antibodies and that cell. So there we stop the drug with the modulator. It's not to be sensation effect. That is number one. Number two is regarding the children. It's equally important or the more important for children, but the thing is that in children, the medicines are given by the parents. The history is from the parents, but desensitization or drug testing is a more or it's a daunting task in children rather than in adults. So obviously, where the secret is, though this is very much reproducible and it can be done above 5 years of it can be done. But definitely the drug challenge testing it becomes very difficult because we need to monitor all the vital signs and symptoms, and usually most of the guidelines is that don't should approach body because about the drugs in the context. That is what we have right now. The last thing I just have to take home message, the practice of doing a drug testing before giving a drug is now no more in vogue. That gives a false sense of maybe the drug can be given and also the false sense that the drug cannot be given. Because we do not use a non-written constitution of the drug while doing the test. And as Dr. Taha was showing that in the monosegmentation, we do not, the practice is no longer validated. It is not right. So do not embark on doing a skin testing with the drug and inject it. The practice is no more good. So I think there was an excellent brainstorming discussion. After 1 hour, 1.5 hours. I think there is a hypothesizing of I am ready. So anyhow, excellent presentation and nice discussion. Thank you very much.
So we will take a lunch now, and then we come back to the panel discussion. I think the next is panel discussion after lunch. So we'll be back by 3:30.
এটা কি খোলা নেই? কি করছি? হ্যালো, হ্যালো, হ্যালো। হ্যালো, 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 হ্যালো।
You are on mute, sir.
The sound system has been checking, ma'am.
Okay, okay.
Hello, Sandhya madam join.
Yeah, Dr. Shambo, I'm
Okay. Madam. Panel discussion. कल तो ये था मैडम, आज तो नहीं panel discussion. कल दूसरे दिन था. ना. Okay. I just shared the link. हाँ. ना ठीक है मैडम, और एक बार लिंक भेज रहे. ठीक है. So good afternoon. Welcome you all in the post-lunch session. So we'll have a very thought-provoking panel discussion now on clinical pharmacology in India, the way forward. And we are really privileged to have with us Dr. Shoibal Mukherjee, sir, who needs no introduction. He's a consultant clinical pharmacologist. And as panelist, may I invite Professor Prabhakar Reddy, sir, in the dais. Sir is currently the additional professor at the Department of Clinical Pharmacology at Nizam Institute. Also, we have with us online Dr. Sandhya Selvarajan, madam. Welcome, madam. So again, madam needs no introduction. Madam is currently additional professor and head at the Department of Clinical Pharmacology, JIPMAR, Pondicherry. Welcome, madam. We have with us Professor Sukanta Sen. Professor Sukanta Sen is currently professor and head at the Department of Pharmacology at Haldia Institute of Medical Science. So welcome, sir. And we have with us Professor Ratindar Jhaj. Madam will join shortly. Madam, again, she is now the professor at the Department of Pharmacology at AIIMS Bhopal. And Dr. Sougata Sarkar was there, but he is very ill now. He is suffering from fever. So he had some message with Dr. Shreyoshi Dasgupta. She can share later when our moderator will give the permission. So now may I invite our moderator, sir, to the dais and take the charge of the podium. Yes, we introduced sir already.
He needs no introduction.
He needs no introduction already. Sir. এটা দেখা যাচ্ছে তো সবাইকে? আর সাউন্ডও শোনা যাচ্ছে সবার?
Then why don't you come here? We'll have one more question as we go through. That time you speak over this. And you can give your comments, separately also. So good afternoon, ladies and gentlemen. It's a pleasure to be here and once again moderating this panel discussion. The topic of this panel is clinical pharmacology in India, the way forward. It might sound pretty familiar to some people in the audience today, but it still is a very pertinent question, I think. And we have at least 1 hour for this. The original time was 1.5 hours. I think we are running a bit late, so we try to complete this in 1 hour. Let me just give you a few starting comments before we go to the panelists. Dr. Ratindar has joined. You can see her on her name on the screen. Ratindar, can I request you to unmute yourself so that we can hear you when you come? Okay, we go ahead. I think she may not be in front of her. Yeah, there it is.
Yeah, hello. Yeah, good afternoon. Sorry to join late.
Great, good to hear you. And you're not late. We just started.
Okay, thank you.
So,
I think I'll keep my video off. Sorry, only when I'm talking, I'll just put it on. Is that okay?
That's fine. That's fine.
Okay.
So let me start with a few comments. Now, the topic being clinical pharmacology in India, the way forward. So before we can look at what the way forward might be, we need to look back on where we've come from. So just a few words on that. And it is not as if clinical pharmacology is something new to this country. In fact, if you really look back, the clinical pharmacology probably started in this country very close to where we are sitting today at Bengal Chemicals, and which is just a few meters away, I think, with Dr. Karthik Bose and Dr. Vijana Sen, and we have the papers on the clinical effects of probability of serpentina, propaganda of that time in the 1930s. So it is really very interesting that we are having this conversation here today at this point, very close to where it all started. But clinical pharmacology has not been recognized as a distinct discipline, distinct from pharmacology or distinct from any other discipline. Still, Dr. Ranjit Rai Chaudhary introduced the DM course at PGI Chandigarh, and you had clinical pharmacologists, labeled clinical pharmacologists, coming out with a degree from that. So that was in 1978. So we have the 1930s, and then the next episode comes on in 1978 and thereafter. Even
Dr. Ari took over as the chair of students and time for pharmacology. But he was the man from the
right.
He was given the responsibility to chair pharmacology as a topic in the professor that started in 1921. And he started at the same time, from first day, he started OPD under the Department of Pharmacology. So 2 OPDs are run every week, hypertension clinic and critical center, run by pharmacology department.
I think we should also have a mic somewhere there because it will be required, I think, as you go ahead. Obviously, Dr. Tripathi knows this much better than I do. He's been there at the Tropical School of Medicine here in Kolkata. And so that's a great input to have. So we have these long years in between, and then we have the DM in clinical pharmacology coming up in 1978. Thereafter, there was a slow period, even after that, about a decade or so, when there were qualified clinical pharmacologists coming out from Chandigarh, but they remained in academia and by and large taught other DM clinical pharmacologists. Not too many of them, because when I joined in 1988, there were 4 seats, 2 of them were still vacant. And I was just one of 2 candidates who was there in that batch with 2 vacancies. So it was going slow at that point of time, and it continued to go slow, I think, for a few years after that. But then suddenly it caught up. And so the whole area of clinical pharmacology opened up, and there weren't obviously enough clinical pharmacologists. So a lot of other people took up that gap that was there between the need for clinical pharmacologists and formally qualified clinical pharmacologists. And how did that need arise? That need arose because in 1995, the good clinical practice guidelines got harmonized across the world, and major regulatory agencies in Europe and the US started recognizing studies done anywhere in the world. So here it was, 55% of the world market for pharmaceuticals at that point of time was the United States, another 25% was Europe, and another 10-15% was Japan. There was hardly anything left for the rest of the world. And these 3 organizations signed up to the ICH guidelines, which said that if clinical trials and drug development activities are carried out according to these standards, then we don't care where those studies are done, we will accept it. That brought a flurry of clinical work, clinical development work to India initially. And it was thought that India is such a huge country, so the patient population is large, and it would be easy to do clinical trials much faster. That initiated the requirement for clinical pharmacologists, but of course there weren't enough clinical pharmacologists, so pharmacologists, MD pharmacologists, who also are good in, quite good at being able to handle that, were able to come in and join, and there were a lot of other specialties which joined the pharmaceutical industry at that point of time and thereafter, and contributed to the development of clinical development of new drugs coming from the West. The Indian pharmaceutical industry also had to catch up at that point of time, because the writing was on the wall. Patents had just been recognized in India. Before that, there were only product patents. Patents were de-recognized in 1970, and they were re-recognized in 1995, saying that by 2005 they would be implemented. Since the writing was on the wall, the Indian pharmaceutical companies then started setting up their own research and development. Things went slow with the Indian pharmaceutical industry for quite a while. Quite a while, meaning all up to this time, it hasn't really caught up to the expectations that were there. But companies like Android, companies like Cadillac, set up 2 research centers, Dr. Reddy said. And they've come up with some new molecules, but realized that it was not easy to do. So that was a scenario in which now we started requiring clinical pharmacologists not only to undertake clinical trials, but also to look at drug development as well. It's not just the specific activity of clinical trials, but the entire gamut of drug development from preclinical into the clinics and even into the market, and strategizing the development pathway. And it was not only because India used to be and still is a small market for pharmaceuticals when you look at it in monetary terms. It's probably about 5%, 6% of it, less than that of the world market, while our population is about 17%. So even when Indian companies develop new drugs, they do it for the world. They want to market it worldwide. And so the regulations that have to be followed have to be international regulations. And to follow those regulations, we require a great knowledge of international regulatory affairs, as well as, of course, drug development. That is where we are now progressing towards. A lot of Indian companies now have new molecules in their pipeline. However, because of a lack of drug development expertise in India, a lot of these companies have actually set up offices in Europe and the US. They are manned by people of Indian origin, or even people who have have spent their careers in India, but now have moved to those countries because the rest of the talent and the infrastructure is available for drug development in those countries. This can't go on for too long. As we go ahead, I think we require that expertise to come back to India, because the cost of development is much, much lower in India than abroad. So we are doing our industry, and anyone else who is interested in developing new medicine to be able to do it in this country and take the advantage of the low cost that we have here and be able to do that for a global market. Now, a word about on the other side. This is drug development, generally industry centric. But then I see a revival of clinical pharmacology in our hospitals and in patient care, also in India at this point of time. I see major hospital chains wanting to do much more research, and I see that they need the expertise that clinical pharmacology brings to the table. Very often they do not know that this expertise does exist in clinical pharmacology, and they are not actually specifically looking for clinical pharmacology. But I do honestly believe that if anybody can really handle this, it is clinical pharmacology. So that is where we are today. I think there's a revival in clinical pharmacology related to patient care, and there is also a great demand for clinical pharmacology in product development. The question is, what next? And that is what we are going to discuss today in the next 45 minutes to an hour. So as we do that, I want to just say here that, when you talk to clinical pharmacologists, you get the sense that there is a sense of crisis. Some people have told me, actually, clinical pharmacologists have said that there is crisis in clinical pharmacology, even though the number of clinical pharmacologists we have in this country today is at its highest. We have more DM clinical pharmacology seats in the country than ever before. While I was in 1990, the 11th DM clinical pharmacology candidate to pass out and get a DM degree that year in 1990. Today there are over 120, I believe. Give or take a few. So the specialty has come a long way. What next? And is there a crisis? So that is my first question to our panelists. Do you think that there is a crisis? If you do think there is a crisis in clinical pharmacology, what is that crisis? And what are its contours? If I can start with Dr. Prabhakar there and ask him what his perspective on this question.
My personal feeling is that I think we are coming out of it. We are slowly emerging out. Because now people are seeing the numbers. The crisis is there. So why the crisis is there? Is that
we have the knowledge, we have the ability to solve some problems which clinicians or other people in various departments are not able. But until now, we were per se were not okay. So now, with more emergency numbers, people are walking out. Let's say before 10 years, when I was assistant professor, I just sit in my room and spend my time, meet with my friends. So it was just a personal issue. Now people are going out. We are forcing the students, we are forcing the staff to. Recently, we are lacking from that. We had a hypertensive clinic. Not
Go out, what does that mean?
what?
Go to the ward.
They did not sit in the room thinking they are a clinical person. So now what happened is that we had a OP long time back in 2005 where we had a that was just closed because we didn't have any OP at it. Now we started the hypertension and also we restarted the drugging. So now we have a consultation in the hospital itself for drugging. So we just had a payment for that. So what we do here is any complication, most commonly now we are getting out of state. So this AMR I think is going, we can really catch hold of AMR. As people go against antimicrobial. So AMR is most important.
So Dr. Kumar, is this the clinic that you are running in collaboration or is this
Separate, clinical component.
Is this running?
Totally different.
And patients come from other departments?
Other departments, mostly other departments.
Correct.
One of drug interaction.
And how do you go about advertising your presence? Because other departments might not, even know sometimes in a big hospital that them when they know it, it might not come to their mind when they actually require it.
So what happened was that pharmacovigilance started. Media before started. So during this time we started sending our to what? To find out. So once they came to know there is a department, people are active, they started asking doubts regarding the impact, what to do in this case. So with this information, they are well known.
So the football disease is that
We just started.
Just
Just we are getting. But basically from inpatients of the hospital, we are now getting around 5 to 8 drug information, mostly regarding the antimicrobial. Drug interaction with various.
So the message I'm getting from you, Dr. Prabhakar, is that while a crisis existed, we seem to be going out of that crisis. And the reason why we are going out of the crisis is because we have taken. We have taken initiative. Dr. Do you agree with that? Are you seeing the same thing in your institute? In Sandhya, Dr. comes from a private hospital in Sandhya. So do you see the same or is the scenario different? And your scenario might well be different because this is a private institution here. It is not in the center of a big city like Hyderabad. We are talking of Sandhya, which is several, maybe a couple of 100 kilometers from major center. First of all, thank you to organizers for putting all of us in a single room. We think we are basically looking for something. So this is the second opportunity and this is the first thing way forward. Now coming back to my experience, till yesterday we are having 704 medical colleges. Only 11% medical institutes, they are of national importance. So almost 50%, if it includes the private and the government colleges, they are below average. So my experience during that period, I almost visited 15 to 20 private medical institutes. I am very close to their management. When you introduce yourself, sir, I am a clinical pharmacologist. So first reaction, ये क्या होता है? ये medical pharmacology नहीं है. So this is the reaction of the owner of the institute. So now
First, we introduced no sir, this is something different. We are DM clinical. This is what just when you introduce yourself into the academic institute, the doctor, so DM clinical pharmacology. अच्छा कहाँ होता है? So these way, even our colleagues, doctors, they ask for इसमें क्या होता है? So that means we are having identity crisis. Now coming back to the development in India, if you go through the starting of courses, right now there are 15 colleges in India offering clinical pharmacy. So almost 48 seats right now. And if you go through the admission process, I think 60% is admitted and 40, some cases, maybe 50% left back. And that vacancy is because of different state government policies. If you go through our state of West Bengal, if you do a DM for 3 years, and if you have to do another 3 years, so and it is not a promising thing for them. Suppose if you are from Kolkata, it is okay. But somebody from other state, he owns point is 6 years to Kolkata. So that is the limitation with our discipline. In my setup, sir, but in last 8 years, what I feel, I've had advantage of having DMT. Okay, everybody, all the clinicians, students, and the faculty members, they accepted me whole. This is the biggest advantage of doing DMT. So everybody is positive about it. Yes, this is something different. So only thing how you transform your experience with your colleagues, sir, आपको ये चीज करना, to start this new thing. Sir, मैं आपको एक example बताता हूँ. Suppose we are doing PG journal class, and thankful to Professor Tripathi sir, the way he taught us how to analyze the scientific. In our 50-seated medical postgraduate institute, nobody of the medical side, they don't review the articles properly. So this scheme we are having, and we have started those activities in our, and that I am getting a personal recognition from my postgraduate. I am 50 students, and everybody is attached. So this is the advantage of doing clinical pharmacology. And now we are requesting our faculty members to incorporate our society party in their medical outcome service or whatever service. So these are the things. Great, thank you so much for that insight. I think what Sukanta pointed out is that there is a crisis. Clearly, there is a crisis because people don't even know that a specialty called clinical pharmacology at all exists, and that you can get qualified in that field. But also he talked about what he is doing, and that is similar to what Dr. Prabhakar told us earlier, that initiative by qualified clinical pharmacologists and demonstration of their skill is what probably will get us through the way forward. I want to go to Dr. Sandhya and ask her what in a tertiary care government setup like Pondicherry, what the scenario looks like.
Yeah, even in a setup like JIPMER also, there's a crisis. Now it's almost 10 years since we started the DM clinical pharmacology course. And initially, when it was started, like the previous speaker said, the same query used to come. What's the difference between MD pharmacology and DM clinical pharmacology? Why are you doing DM clinical pharmacology? What is the difference? Where will you be placed? Where are you going to work? So these kind of queries used to be asked for a long time. Probably for the last 1 or 2 years, we are not getting those kind of queries. But a few years back also, we used to get those kind of queries. And even now, when the administration changes, when a new director comes, the first query will be like, what is the difference? Why there is a separate clinical pharmacology? What is the difference between pharmacology and clinical pharmacology? So there is no clear distinction between these two disciplines, which is known to others. So that itself is a crisis. And even in most of the colleges, it's still like the Department of Pharmacology
And after finishing DM clinical pharmacology, if you have to join as a faculty, you have to join the Department of Pharmacology. And again, when you join there, like the other people ask, like, what is the difference? Even after doing DM clinical pharmacology, you are joining a pharmacology department and you are doing UG teaching. So, like, what is the use of doing this super specialty course? So, as of now, due to this lack of job opportunities, especially in academics, as the clinical pharmacology departments are very less. What I mean is separate clinical pharmacology department, and most of our candidates have to join pharmacology department if they want to be in the academic setup, and that itself creates a illusion that there is no much difference between the course. At the end of the day, you will go and join pharmacology and you'll end up doing UG teaching. So not having a separate clinical pharmacology department and no job opportunities in the academic setup itself is a crisis, and that is a major limitation. To overcome that, we have to have separate departments where we teach DM candidates and do things which are related to clinical pharmacology apart from UG teaching and other things. That's the way forward, I think.
Thank you so much, Dr. Sandhya. So what you're saying is that the crisis, according to you, is the fact that the distinction between a clinical pharmacologist and for a better word, a non-clinical pharmacologist, that differentiation doesn't stand out. And perhaps then what you're suggesting is that we need to have probably a different pathway there, a separate department. I'm not sure whether, just that would be sufficient, because people will always also keep asking us, why do you have this separate department? So we have to be able to answer that question. Why? What do you do different? What do you know different? And how is your curriculum different? And all of those things. Last year, when we had the same conference, I think I did have the opportunity to make a presentation. And that's the point that I wanted to make. And possibly through the next 2 days in this conference, we will talk a little more about it. Tomorrow I have a presentation. And I want to specifically talk out those areas where that distinction can stand out sharply. But I do agree with Dr. Sandhya that it's not easy to make that distinction. And it is up to us to make that distinction as wide and as broad as possible, as distinct from each other as possible. And we'll have to brainstorm on this. And as a discipline, we have to work on this and do certain things. And I have some suggestions which we speak about when I get some time tomorrow to speak on this. But I want to go to Dr. Ratindar and ask her. She is at AIMS Bhopal. It is a relatively new institute. AIMS is recognized as, all these are recognized as leading institutions in the country. And she studied from PGH and she has a legacy of also to carry with her. Ratindar, what are your views on this topic?
I'm sorry, except you, Dr. Saibal and Dr. Sandhya, I could not hear, it was not clear what others said. So I might be repeating myself. But of course, now there will not be any repetition in the fact that, as you said, we are a new institute. And in fact, we do not even have DM clinical pharm. It has just been approved and we are hoping to get our first candidate in January. So that anyway, we do not have that crisis as of now of being recognized separately. We do have 3 clinical pharmacologists in the department, and we do plan to request for put up in the staff council for, as I agree with Dr. Sandhya this is a question not only, we are anticipating right now also when students, decide to do clinical pharmacology. In fact, some of our students, prospective students have already asked, why should we do clinical pharmacology, as Dr. Sandhya has said. And this is something that we have been listening to right from the beginning since we have done our clinical pharmacology from PGI Chandigarh. So I agree with Dr. Sandhya that a separate department of clinical pharmacology is something to aspire for. But at the same time, I don't think pharmacology and clinical pharmacology can be watertight, compartments. So we cannot say an MD pharmacology should not be learning what clinical pharmacology, is all about. So I think, as you said, the way ahead, let us discuss, in the future. And I'm not sure, are we what we do? So we don't have clinical pharmacology as such, even as a unit, but as I said, we have 3 clinical pharmacologists. And fortunately, we have a good environment, a good cooperation with our medical, faculty, even though not formally, we don't take formal rounds. But our PGs actually work, take rounds and present the cases during their, as part of the teaching. We also do regular prescription audits where it's not just doing a prescription audit and publishing it. We circulate as a 1-page PDF to our, the whole entire faculty and staff of AIIMS. And not only, and we also present, that just happens once a year during our faculty academics. But while we are, analyzing those prescriptions, we have involvement of a medicine person. So it's not that pharmacology just looks at the prescriptions and says that, yeah, this is correct or not. We have involvement of the clinicians to decide whether it is appropriate or not. So that way, I think we are doing a bit of clinical pharmacology. We are also, like, I think most of us have ADR review, ADR monitoring centers. We have recently, in fact, I've been inspired by Dr. Shambo in that aspect, and we have opened up our ADR for medication review. So we haven't got much of a response now, but we have also, offered that any patient you feel that he's been prescribed too many, drugs and things like inhalers, where you would like us as a clinical pharmacologist to explain to the patient how to take, or just do a medication review, please send to our ADR monitoring center. So like that, we are trying to play a role of a clinical pharmacologist in our hospital. We do have access to that. Being a new institute, it's easy to kind of, introduce such things, but we don't have formal clinical pharmacology as of now.
Right. So thanks, Ratindar, for giving us your perspective. I think many of us have been inspired by Dr. Shambo here, of the kind of work that is happening, and not only Dr. Shambo, but there are a few others in West Bengal particularly who are doing this kind of work. And it's great to see that at least in one part of the country, this movement has begun to happen, and many others are taking learning from that and wanting to do that in their areas. I think we should give it a fillip. We should try to formalize this service that is provided to patients and to other specialties, and we must see how we can expand that. So my thought here is that unless we provide services to patients on the one hand and other specialties on the other, to the hospital in general, the value of a clinical pharmacologist cannot be used. So thanks for those comments, Ratindar, and bringing us onto that topic. I will ask Dr. Dhaneria, a very senior clinical pharmacologist here, to give us his views.
Esteemed colleagues and listening delegates, has covered a lot of things. I would like to share a few other things. I have been undergraduate teacher throughout my career. what I see that medical science is a science of integration. Unless and until we have not understood the pathophysiology of illness, we cannot treat the patient correctly. We have to understand the pathophysiology of illness, how the drug interacts with the pathophysiology, and how the patient is benefited. Our curriculum has a shortcoming that we have given much more emphasis on diagnosis rather than therapeutic aspect. And I think here is a vital role of a clinical pharmacologist being the expert in therapeutic to play. So I think we have to involve ourselves in teaching and training of both undergraduate and postgraduate. And we have to share our expertise in clinical pharmacology and therapeutics. And also, I think we can also look for need-based research. That is one of the important areas. We can also contribute after COVID-19. You have seen that our expertise can be, we can extend it to the public health education also. So I think these are the areas I think you can express your views and our young generation can take a lead from that. Thank you.
Finally, your experience comes through whenever you speak. Dr. Nani, this wonderful distinction between diagnostic and therapeutic. And I think clinical pharmacologists have that, they should be in that therapeutic phase where we should be able to assess the work of the therapy and the intricacy of therapeutic handling of patients. While clinicians clearly are trained as well as extremely good at working on the diagnosis, and diagnosis is very important for them. It is quite true that the therapeutic part gets, kind of becomes a little secondary for a lot of clinicians. They get the kick out of being able to diagnose something well. And you will often find clinicians asking for this test and that test, and all these tests, they probably are not going to help the patient that much, but they will help the clinician diagnose, and they want to do it. I think there is a niche for us there on the therapeutic side, and clinical pharmacologists should make the best use of that. You also talked about teaching, and I think clinical pharmacologists, particularly in the teaching line, should understand what the job opportunities, what the career opportunities in clinical pharmacology are, and they are great. There are massive career opportunities in clinical pharmacology, and there's a starting level opportunity there, and ultimately then you have to compete with other specialties for the more senior positions, because it's not that only a clinical pharmacologist you do your specialty job at a particular level, but after you get senior enough, you have to be able to handle other responsibilities, and the other specialties also are able to have to do it and can do it. And so who gets selected depends on how good you were and are in your own specialty, and then how you are able to also understand the other specialties around you and provide a perspective which is holistic. So thank you so much, Dr. Sandhya, for this first round of discussion. At the end of this first round, we will open this to questions before we go to a final round. We are continuing this a little bit from what we discussed yesterday. We had a little small discussion yesterday among the panelists of how to go forward with this panel discussion. But we are going to change that a little bit. So I open this up to any questions from the audience, any thoughts, any comments. Yes. Thank you so much. I joined with course after registration from Prabhakar. I'm under the guidance by Rami, and basically now we are talking. Now basically what we are discussing the relevance of clinical pharmacology in the arena of therapeutic or arena in diagnostic or arena in patient care. We should think about the patient care side. Because clinical, whenever we are calling clinical, related to the patient. So there again, I have some doubt that if I be in clinical pharmacology, I am going to advise these people who are real in the immunology. At the same time, giving advice who is real in cardiology. At the same time, who is real in neurology, who is super specialty in psychopharmacology, neuropsychiatry, or any other specialty. So I had one suggestion from the business first day when Taha gave one consultative meeting before starting this course in School of Pharmacology. I said, if there is any possibility of making this super specialty one, by me, if I am a clinical pharmacologist, I should have super specific knowledge in particular domain of our clinical disease. Then we can have a mastery over that. But if we want to be actually a jack of all trades, we will end up being master of none. So it's my suggestion. It's not a question. It's my suggestion. If you can think over it, and so that we can clearly have super specialty for sort of thing, then I will think we do have importance in our fraternity, clinical fraternity, whenever they know that they are clinical pharmacy, but from core of my heart, I know that for application of those knowledge, they are much more advanced than us. This is the basic thing. Exactly. So I think you make an excellent point because you know this area, as you go deep into the clinical pharmacology of particular specialties, let's say diabetology or allergy or whatever it becomes very vast. Suddenly it becomes very vast. It becomes very detailed. And the advances in medicine have gone to that extent that as we go into the next 10 or 20 years, where some of and all of the audience here are still to see those years, and they will then be, into their middle career, when this will start really becoming very complex. I have been helping some consultants in the area of oncology, and it already has become so complex some drugs which will work only in combination with other drugs, all gene-based or genetic, genetically having genetic association based on either the transformation of some genes or transformation of some of those genes, some of them working in one direction, some of them working in the other. It becomes very, very complex. So I think there is an opportunity as well as a threat here. The opportunity is that the kind of detail and complexity that is arising in each of these specialties makes it almost impossible for a busy clinician to actually grapple with it. And they would probably welcome help with the theory behind and the way things work. And also the number of therapies that are coming out and will continue to come out year after year, these will continue to grow. And so it's not going to become any easier. The threat is, and for which the solution was suggested, is to have subspecialization, because it is not even possible for the clinical pharmacologist to grapple with those complexities in all those disciplines. So people would have to, I think, clinical pharmacologists would need to begin to choose sub-specialization as they go through their courses to see what they like and go into that area and get into deeply into that area and understand. So there are two people wanting to make comments. One is Shambo and the other is Dr. Qurashi.
I think there are two aspects of what Dr. Ratindar has said. First, it is well taken that what we have been. Then focus is on clinical pharmacology's role in patient care. Perhaps we have tried to do that, and whether and as a clinical pharmacologist, I am confident enough to get into the nuances of practices of different super specialties, or subspecialties. I would rather say if we emphasize more on our strength area. What is the strength area? Is the pharmacology part. Pharmacology as it is applied in clinical practice. So that is something that we should be confident about. And that doesn't mean that you have to be a moving dictionary about drugs. No. But you should have, as a clinical pharmacologist, I have better skill to interpret and understand and appreciate and give the feedback to a clinician, whether there is a failure of treatment response, whether there are possibilities of drug-drug reactions because of which there are some kind of crisis. So these are areas where possibly a clinical pharmacologist can actually add value to optimize patient care. And for that, even if you try, you cannot actually substitute the expertise of a super specialist in different domains. But then what is the common thread? Any management, patient management, 95% of it is based on the drug. And that is the common thread. And that will make a clinical pharmacologist indispensable. If we can prove our merit in patient care, irrespective of the subspecialties and super specialties. Okay. So that is one thing. But then I take your point well. Could it be from that what we can suggest that is it possible in the curriculum itself, in the curriculum planning and develop curriculum implementation? Maybe at the very first year of the clinical pharmacology course, if we try to know from that candidate that what is his interest area, whether it is cardiology, whether it is pulmonology or dermatology, and accordingly maybe an elective, let's say for 6 months of the 3-year course, could it be placed with the concerned department where he can work during his training period itself in tandem with the specialty in that area, so that he becomes ultimately a clinical pharmacologist and dermatologist. So he is clinical pharmacologist more towards dermatology or more towards pulmonology like that. That we can think of for futuristic. But given the current situation, we do not have that kind of problem. If anybody does that, it will be at their own level. So this is one I was thinking that it could be possibly done, and so that because you have a clear goal that after you graduate, after you do your postgraduate, clinical pharmacology, you will be actually would like to be identified as a clinical pharmacologist in pulmonology, related to pharmacology. And I would rather say in that area, it's not to be limited to only in patient care optimization, but also all the whole gamut of canvas in reference to clinical pharmacology as applied in practice of pulmonology. So from that angle, it's a good idea. I think we can track this point and we can have further discussion. And if our society actually makes a formal presence maybe in a couple of years, then we can make these kind of guidances and suggestions to the appropriate authority so that the appropriately the curriculum can be modified.
Yeah, definitely. Formally, but also informally, that can obviously happen.
That one I thought that.
That is very wonderful that you said that therapeutics is very vast. We have some baseline knowledge about therapeutics and applied science is all about clinical pharmacology, and we should integrate that and bring into clinical practice. Now the good question here is, what if our services are not solid? I'm not a dermatologist. I can't open up a clinic. How am I going to do this if I'm not working or in a veterinary care hospital? I can still make a judgment.
What about the rest of the members and service? Right, so this maybe is a question, not a comment. Let me try to answer that very quickly, since I do have a presentation tomorrow, so I will take up this topic. But what I want to say is we need to provide services. Now, those services, to my mind, needs to be in the area of research. Most of us, many of us, are working in teaching institutions, postgraduate teaching institutions, many of us. And even if it's undergraduate, there's always postgraduate also along with that. And more and more, it will be required that clinicians have to do research, bring out papers. And, if you go and look into any hospital, I don't see you guys having any time to do that. They require services these days. The level of sophistication you require in research has gone up tremendously. The studies need to be done under good clinical practice guidelines. You need to have the right kind of biostatistics there to be able to publish in a particular grade of journal. You need to have the analysis studies when they are clinical studies when they are done. It has moved into the digital sphere. So there is nothing that is now, while we might go on doing that on paper, but any good study these days is done in a very different way, in an electronic format, where there is electronic data capture, there is a review of the data as it comes up. So if you want to do a good study, which will be internationally recognized, you need to follow the entire gamut of things that, for want of a better word, that say a sophisticated industrial setup uses to do clinical trials, which is not within the purview of a standalone clinical department to do. They cannot set up a data management group. They cannot set up a biostatistics group. Of course, there can be a biostatistics unit or department within the hospital, but those people often don't have the data management. And if they do, then they are taking it away from what is something that the clinical pharmacologist is taught to do and should be doing. So, so I think there are certain allied.
Had actually explored this idea and we were trying to develop it. So for instance, somebody who has started here, he decides he will neither join industry nor join an academic nor a government. If he wants to practice, is it possible? We have given the immediate thought. Is it possible to do freelance practicing as a clinical pharmacology practices? What it could be? Or is it absolutely anything? What is the idea of practicing clinical pharmacology? Actually, society, first of all, who comes to the practice? Common people. Now the question is that, first of all, it should come to that place, that extent. That's what I'm trying to stimulate. But instead of doing that extent, then common people will understand the meaning of clinical pharmacology. If I am going to a clinical pharmacology, how I will be benefited out of it? When I will pay it. That is the first.
That's true, but after all, we are talking of medical clinical pharmacologists who have a basic MBBS degree and have a license to practice. So they can practice if they want. Now
I'm talking of practicing. I'm not talking of practicing themselves. I'm talking of practicing something which is different from general practice. Okay, practicing clinical pharmacology. Is there a scope? Is there a need? Is there a value?
No, I
Somebody who is doing freelance practicing as a clinical pharmacologist. Question is think about that. Think about that.
Well,
Dr. Shambo,
one comment, because after just 2 months, I will be a number of unemployed Indians. So just 2 months is left because as Sundha madam told, Ratindar madam told, and also Sukanta told that there is no separate clinical pharmacology department in our AMEM. So only 2 months is left for me to become employed, so called. So I have a plan, and that is
I am not talking about, I train myself as a dermatologist, pulmonologist, cardiologist, diabetologist, endocrinologist, etc. Whether I can claim myself as a diabetes therapeutic specialist, whether I can claim myself, because if I am doing a DM degree after doing my pharmacology MD, if I am doing myself in DM course, and if I am doing some more training in the field of diabetology, or even in the field of some other specialist. So as this course, this clinical pharmacology or this pharmacology, whatever you can say, they are more confined to the therapeutic sphere, as also our Moderator sir was mentioning about the importance of therapeutic. So if a patient comes to me who is consuming more drugs, because polypharmacy is very common nowadays, pediatric patients, they came to me for therapeutic care. And this is happening. I had also started this venture, and I had faced lots of patients are now coming, even doctors, they are referring to cases because their patient is taking multiple drugs, 10 drugs, 15 drugs, 20 drugs. So they need some opinion, expert opinion. Even some endocrinologists had referred some cases of who is suffering from diabetes.
So allow me to introduce a terminology here. The terminology, you are offering a differentiated service to your other specialty colleagues.
Also the patient.
And also the patient.
Also the patient.
And also.
And I'm claiming out your diabetology certification or diploma, whatever.
Yeah, that's what.
Assume that you have that degree.
Yeah.
Whether you could have practiced in pharmacology in terms of taking care of people. Think about that. That's a therapeutic question.
So I have an answer to that.
I just want to say, in this, usually this clinical pharmacology and therapeutic work not initially the terminology that was being used. The terminology for clinical pharmacology at least was clinical pharmacology and medical research. Now you have in Indian scenario, therapeutics is the word that is being attached to clinical pharmacology. The clinical pharmacology role comes mainly in that way. So now you have to do it. For us to survive, we can't do clinical pharmacology in drug development. So we are bound to do something for ourselves. So what we have to do in a hospital setting, we have to show we are something like, we have two hands, I have another. And we have to see, we have to involve in patient care. Once we involve in patient care, nobody is going to send you off. They call you in, beg you to see. Personally, my experience, when I finished my DM clinical pharmacology, I went to an institute where they didn't want to raise my pay. After I had DM, they said, you want to do, you do. We pay only for MD. Then when I wanted to shift a job, I literally found those openings. When MD pharmacology, same department. As madam was saying, you are joining at MD pharmacology. Even if there is no vacancy, they tell, they at least make me fit. They say, what you can do to us? As a clinical pharmacologist, literally I am saying, we have so many opportunities, but we are sitting behind in a closed room doing something, spending our time. So many opportunities now in hospital, in India. This for us to go out and do. Yeah. There's no therapeutic. If you want to practice, why DM clinical pharmacology, MD pharmacology, go and practice. You say not to practice.
Not talking that way. That you can do with everything.
Right.
Destiny is other
Right.
clinical pharmacology, whether you can do that.
So I wanted to comment on that.
So there is one, sir, with permission.
Sir.
No, let's talk.
Go ahead.
We had one very recent publication on one terminology also. That is CPRRA, Clinical Pharmacological Reconciliation, Review and Feedback. This is service what we are providing from our specialty domain. It could be some specific subspecialty, as Professor Nasser sir was telling you. It could be like in diabetes, it could be some other subspecialty like pulmonology, like that. But
on which we are doing our specialization. So that is the thing, that practice we can do after doing this clinical pharmacology as a super specialty.
So to answer what Dr. Bhaji was raising, that if you take away your training in diabetology, and here you have a person who has done an MBBS and MD in pharmacology and then a GM in clinical pharmacology, can that person go and practice clinical pharmacology with that label of clinical pharmacology? So obviously, patient, there's no disease called clinical pharmacology. So unlike a diabetologist or a neurologist, there will be no patients coming with clinical pharmacology. So the patients have to be the same. You will be either a general practitioner or a practitioner slightly more differentiated into some particular area. But you can, I think, call yourself a therapeutic specialist if you have done research in that area, if you have got good publications in that area, if you are recognized among your peers as somebody who understands this better than most of the people, then I think you can claim to do that. Now, there will be no formal, degree to that kind of practice that you are a clinical pharmacologist specializing in diabetes care or in psychiatry or whatever. But if you have got work behind you, which you can show, then I think you have some locus standi to do it.
So just continuing with that, making our presence felt. So a couple of things, of course, my experience is not that high in the academic field, but a couple of areas where I have felt there is a need where we can explore. One is in the field of pharmacoeconomics. Because pharmacoeconomics, even if there are multiple studies conducted in different parts, they cannot be directly translated in the plain field. So if we do, let's say, an economic study within our institute, considering the resources that are available, considering the facilities and everything, so that would actually be more meaningful. And I'm not talking about, say, a large scale study where you're expecting that the national government will come up with a change in recommendation or whatever. It could be something as small as for the institute. Like maybe the institute wants to introduce a service, like okay, instead of maybe they want to replace say ferric carboxymaltose with say iron sucrose or whatever. So what is the economic impact on that? So these are things where actually they will actually recognize that there is a economic study being conducted, and then that will help us to make ourselves visible in the institute. Second, which I feel is even the morning it was discussed, the field of drug allergy, which is again is a very, very unexplored area and where people don't usually have that much of expertise or anything. So just like in KM, we have recently last year started a drug allergy OPD, where we cater as a referral service, we cater to any referrals on drug allergy, we evaluate, we provide the opinion as to whether to discontinue the drug or to substitute or whatever. So like I myself, I'm getting trained in allergy. I intend to take this moving forward. So these are some small things that I feel which can help us help us be visible at the institute level, not going beyond.
Bhaskar, thank you for those comments. Thanks a lot, because those are the very lines on which we should be thinking, and you will see that reflected in my presentation tomorrow. Pharmacoeconomics, pharmacogenomics. We need to work in these areas, do research, publish, and get recognized at least within our institutions, if not anywhere else. And that is where it will start. And once that wave begins, then you can think of the next step. But right now, this is what research is, I think, a very important part, as Dr. Prabhakar also mentioned. The research, I think, is a very important part of the next step that we are supposed to do. So before we close this, there are two things. Dr. Ashraf, please.
But then again, is it exclusively a part of clinical pharmacology or pharmacology also can do?
Well, let me just mention here that almost a large part of what clinical pharmacologists can and should do can also be done by other people. It's a question of the opportunity staring you in the space and you grabbing that opportunity. If you don't, somebody else will. Right. Now, if you start publishing in health economics, and clinical pharmacologists are found to publish more than anybody else, then clinical pharmacologists will be called into that health economics group. We have to make our case for ourselves, and that comes through research and through the work that we do. It will not come just because we have the label of clinical pharmacology and people don't even recognize what it is. So, that becomes
one example. We have an Indo-US body which is on research on CKD2 unknown. So it is a body of 12 members, where 8 members are non-medical. 8 members, most of them from US are non-medical. They are environmental engineers, chemists, all those people. So for us to go, we have to open our doors just for next 5 years. After that, automatically those will be open. Another example is most of the private hospitals, they go for activity, not for activity. For that, they use designated most of the hospitals, even one hospital I was from the meeting, then the hospital said, our clinical pharmacology system, I must be going from the world of clinical pharmacology. Then a young lady came, and then I asked her from you are here. So I had to talk to him. Said inform pharmacy. Most of the corporate hospitals in India, they are holding the course of clinical pharmacy. So you are talking of the crisis. I didn't say. In industry, we found
Yes, but you can't fault them. You can't fault them because they know more clinical pharmacologists than most of us here.
When you are talking about academic side, so industry we have pharmacists being head of clinical pharmacology. That's why when you are exploring possibility, it's possible that clinical pharmacology can act as consultant. Consultancy can be in a different type, right? Any clinician may consult, any CRO, of course, they can always consult, and I believe clinical pharmacology is the first person to give consultation to carry out any kind of drug.
Absolutely.
Whether you are sitting inside or outside. If you are inside the hospital setup, that's always.
We are running a little. We are running a little short of time. We have 2 or 3 people who really want to make some comments and have not gotten opportunity so far. So, ma'am.
Good afternoon, everybody. I am not from your fraternity. Basically, I am an associate professor at Pharmacology at Calcutta National Medical College. I was just listening.
There is a journal in India which is Journal of Anesthesiology and Clinical Pharmacology. Where we cannot be the member. That also. Okay, go ahead.
So the thing is that I was just listening the discussion, but my idea as Nasa is my husband, so we have discussed many a time that patient care should be involved. If there is regular ward, then only, otherwise whatever that clinical cardiologist or what are the special name that Shambo suggested, no one will listen. Because after doing MD, then another 3 years they are doing cardiology and they will diagnose the patient, then they will ask the clinical pharmacologist, you suggest the medicine, it will never ever happen. So until and unless there is a patient care, no, until they are involved in the word, say your curriculum should be, I mean, this is a suggestion or this is how you people can incorporate as Nature is there. Every time we are thinking, if we have to hone up our skills, insecticide is completely a different chapter. But if it is a patient care service, if we have to raise ourselves as a doctor for the patient care, so we have to have clinical attachment. Otherwise, I know during the COVID period, there was a duty, even it is in our hospital, that say from pathology, say from not only clinical pharmacology, from anatomy, from physiology, because you are basic MBBS, what sir has already been mentioned. But the thing is that until and unless you are having that exposure for so many years together, so it won't happen. I want to go to a clinical pharmacologist, whosoever may be. I am not going to disrespect the subject, but being a patient, that Shambo mentioned that they are taking 15 drugs, but even after that, I think, I don't know anyone can vouch that they'll go to a clinical pharmacologist. This is the point. Please don't get hurt, but this is how.
Your point is very well taken, ma'am. I think it is happening. But we do hope that
We are getting
in certain situations.
Clinical duty should be there, that in the course curriculum 3 years, that there is 2 hours what duty in the clinical cardiology or something like that.
In the interest of time, I would like to request Sukanta to make a comment, and then we will go to Dr. Qurashi.
Thank you.
Thank you. Fortunately, we are having a structured curriculum in August 2020, which has been circulated by NMC. The problem is when they have designed curriculum for pharmacology and clinical pharmacology, which is majority part is almost in English. If you go through the European Society of Clinical Pharmacology and Therapeutic, what they have designed, they have structured in 5 components. First, this is a personalized thesis in clinical pharmacology. Second, they have designed the formulation based thesis. Third, they have this way they have basically structured and their clinical pharmacology so nicely. Whenever you come out and complete their course, you will automatically indispensable part for therapy. Nobody says it will be service. You have to take the service of clinical pharmacology. And what Professor Prabhakar has told, the accreditation process, and in clinical pharmacology, the only thing is we all are clinicians. So there is no question of the MSc, MPharm, nothing. If it is clinical pharmacology, so there must be clinicians. This is not my document. This has been mentioned in the European Society of Clinical Pharmacology. They all are clinicians. Now you develop your expertise and explore it. Yeah. And the next part is very recently Medical Education and Rating Board. They have had a memorandum with Quality Council of India. So they are going to inspect all medical colleges for accreditation process. So I'm definitely sure we individually are establishing ours. But after completion of DM clinical pharmacology, there is no doubt of job. One, if Shambo wants job, and the day one will get. So there is no doubt of job for clinical pharmacology. Can I request Dr. Qurashi to give us the message that Sougata Sarkar actually has asked her to present. Sougata was supposed to be one of our panelists. He has been taken ill this morning. He called me and said he may be able to join online if he's feeling well, but he's got high fever, and hopefully it will resolve soon. But we have Qurashi to bring it
He has
in.
just sent me a message which he just wanted to convey to all of you and also speak it out. Most of these things have already been discussed, but since we have written it all up, we just have to, in fact, basically argued in favor of clinical pharmacologists and engaging in clinical practice.
Please keep the mic very close to your mouth.
Okay. So he has argued in favor of clinical pharmacologists working directly in patient care because he is also engaged in clinical practice, and he has a quality practice. So what he says is that there are 2 separate entities. One is the science behind the disease and the medical management of the disease, and that gap is bridged using the clinical pharmacologist. So from the point of discovery of the drug development, approval, studies, development of standard treatment guidelines, essential medicine, list of medicine, pharmacoeconomic studies, pharmacovigilance. In all of these stages, clinical pharmacologists play an important role. But when it comes to the final stage, when all of this is accumulated, why is it that clinical pharmacologists are not present? And second point that he wishes to make is that prescribing medicine is a complex process and it is itself a risky behavior. And prescriptions have always had a varied magnitude of inherent vulnerability. The essence of a trained clinical pharmacologist is that they can prescribe the most effective, safe, and economical medicine by balancing anticipated benefits and foreseeable harm. So, why is it that we are not engaged in clinical practice? Our professional colleagues of other disciplines refer to us patients for various drug-related issues and recognize our credentials in managing them. So, why should we not be using this privilege to conduct clinical practice on our own? Medical ethics and rational use of medicines are core part of our clinical pharmacology training. So, we should also be engaged in rational prescribing in clinical practice. We are now going through the pandemic of multimorbidity and polypharmacy, and there is a huge need for therapeutic optimization, which can be effectively done by a clinical pharmacologist. In the last 53 years or so, the rise of clinical pharmacology discipline as such has not been to the extent that it was anticipated. So as of now, there are only 15 institutions all over the country with only 50 seats for doing clinical pharmacology. But other super specialties have a very large number of seats, like EM cardiology has 600, EM neurology has 400, etc. But in medical science, the role of clinical pharmacology is not more than the other disciplines. So it may be because our numbers are still small that we are not visible to the community and to the policymakers. And I believe that this is because we are not engaged in direct patient care. So he emphasizes three means by which clinical pharmacologists can make themselves more visible to the patient. First is as a primary physician, where the patients may come directly to the clinical pharmacologist. Second is as a secondary physician, where a patient with drug-related issues may be referred by colleagues from other disciplines to us at transitions of care in a hospital setup, where we may use our wisdom of clinical pharmacological reconciliation, review, and feedback, as Dr. Shambo was saying earlier, for therapeutic optimization. And third, he says that as a member of the team, of a multidisciplinary team, which can work in along with other disciplines in area detection and treatment, overdose or toxicity management, therapeutic optimization in organ dysfunction, patients at critical care, drug hypersensitivity and desensitization. We must increase our visibility through direct patient care along with other roles and responsibilities that we are doing. So, as for the future prospects of our discipline, we say that there should be increase in the number of seats in the different colleges, and more colleges should introduce this discipline. Clinical pharmacology is a separate department as other super specialties in the medical colleges. Our functioning clinical review or medical reconciliation clinic in most of the colleges, and clinical posting, say for example, of 3 months for super specialty departments, say for endocrinology, neurology, nephrology, or cardiology, the first year of our training. And whereby in the second year, then the trainee can select any of these disciplines according to his area of interest, and then be exposed to that during the course of the training. So that is what we have said.
Yeah, I think it's very nicely kind of summarized the whole topic, and I think the main point he also makes is that practice, as Madam mentioned, practice is very important. You have to be able to be seeing patients often, whether those are secondary to those patients are referred to you from some other specialty, or whether it's primary is a different matter. But you need to be able to practice. Actually, that's why it's called practice, because you see those patients again and again. So I think we're coming to close of our discussions today. The way forward, I just wanted to check whether Dr. Sandhya or Dr. Ratindar, they are still there, and if they are there, then do they have any closing comments? People sitting here, those of the panelists who are sitting here have already got a lot of opportunities to speak, but I think those who are joining us remotely haven't had that opportunity. So please go ahead, Dr. Sandhya. You are on mute. Your system is on mute.
So in addition to whatever points have been covered by many people there, one important aspect where clinical pharmacologists also should focus is with respect to the guidelines, both regulatory as well as ethics guidelines, because most of the times, especially when a sponsored clinical trial comes to your academic institute, the clinicians look for people to help them. Like how do we proceed with this submission? What are the guidelines to be followed? Can this study be taken up? So they need some sort of guidance while taking up sponsored clinical trials. So this is one area where we can help them because they really don't have much knowledge into this. Like when some study comes up, can we take it up? It's a phase 2 trial. What is the safety of this particular molecule in the patient? Can we take it up? Will there be any problem with respect to the safety? So those kind of suggestions can be given only by clinical pharmacologists. So this is one area where we have to focus in addition to other responsibilities, so that we become very unique in helping the clinicians. And this is one area where people will come to us rather than we going to them. They will look forward to get our opinion on how do we proceed with this. As well as like in addition to this, during the documentation process while doing the trials, various other aspects of the trial, for that also they need our help. Like how do we proceed with documentation? What are the things to be documented? How long to be archived? What are the procedures for archiving? What are the ethical guidelines to be followed with respect to particular things? So being well versed with all the regulatory guidelines and ethical guidelines will surely put us forward with respect to our relationship and collaboration with clinicians. So we also have to focus on this area.
Great, thank you, Dr. Sandhya, for those comments. I think you've brought up a very important point. So we were talking on the topic of services that we provide, and some of those services are definitely in the area of research which comes extramurally to us from other organizations who want to get studies done at our institution, and clinicians are not, there's so many things to be done to get that study going. And I am currently, associated with the Medanta hospitals, and I see their research department. It's called a research department. There aren't clinical pharmacologists there as such, but some of those people are doing things that I think can be replicated in other places to provide a research service. Thanks a lot for that. So I think this brings us to a close of our discussion today. I just wanted to summarize the points that were brought up. So while it seems that there might be a crisis in clinical pharmacology, there has been a crisis in the past, but we seem to be going out of it. The opportunities are increasing, and there are initiatives that individual clinical pharmacologists are taking, which are moving us away from that crisis. We still do not have the degree of recognition that we would want, but the degree of recognition definitely has gone up. In my time, when I was doing DM, there was no question of any clinicians, referring patients to the clinical pharmacology department. It didn't happen. Today, that is happening. I hear from so many people. So it's a great advance. I think congratulations to young clinical pharmacologists who have made that happen. There is the need for awareness, and awareness in general terms means advertising. You need to be able to provide an idea of what services you can give to people so that they know that these services are available from you, and if the opportunity arises, then they will ask for those services. We need to widen the differentiation between a pharmacologist and a clinical pharmacologist, and that difference, I think, will increase as we go into provide more of these services and do a lot of research, a lot of clinical pharmacology research, which is not happening to the extent that we. So we have over 120 clinical pharmacologists in the country. What is the clinical pharmacology research that is happening? It's minuscule really. Once in a while, in CICR, I do see a few articles that come on topics which are not so greatly clinical pharmacology. I think clinical pharmacology needs to think of what are the areas within clinical pharmacology that require to be investigated research. And in today's age, digital age, almost all information is available if you search for it. With a chat GPT or something like that, you would get a lot of the answers that you are looking for to begin that kind of research. So I don't think we have any kind of excuses to not do research in our we have already talked about provide services to patients and other specialties. Concentrate on the therapeutic aspects of things because that is the area where I think we are specially skilled and trained in, and a thought towards sub-specialization. So when you pick up a specialty for deep study, that would be a good thing to do because the areas of therapeutics are very vast. And finally, regulation. Very few people understand drug regulation and research regulation within the setup that we operate in, and we can provide that as a fountain of knowledge for. So with that, I would like to thank my panelists greatly for participating in all of this discussion. Dr. Ratindar Jhaj has said that her connection is not stable, so I did not. Big thank you for such a lively discussion to the audience here, and hopefully we will build on these topics over the next 2 days and have a very good conference. Thank you all.
Thank you.
Thank you, sir. Thank you very much. Now, may I request Professor Sandhya Dr. Shoibal Mukherjee. Dr. Sukanta Sen. Requesting Smita Pattanaik, madam. We'll felicitate Haneria sir tomorrow. And we are really thankful to Ratindar, Jhaj madam and Sandhya madam. We'll send your memento madam by post. Thank you. So now we are moving forward towards the next session. And
The next session. That is a symposium on early phase clinical drug development. We have two lectures now. So first lecture will be by Professor Smita madam. You want to do that? Okay. So may I request Dr. Mukherjee to deliver on the topic like challenges and how to address the early phase clinical drug development.
Shambo. Shambo. Good evening, everybody. Good evening, everybody. I thank the organizers for providing me this opportunity to present my topic. So, like as a clinical pharmacologist, there has been a great discussion what we can do, what we have to do, what not we can do. So one of the main thing what we have thought of is like doing a clinical research, right? So people may say like it's very easy or difficult. We don't know what to do, how to do. So just we'll see like what will be the challenges in the clinical drug development. So first thing like whether the education,
Very sorry for the who want to just apologize because for this session we have Professor S.N. Naseer sir to chair the session. I invite sir to please come in the dais. And also we have Professor Sandhya sir, S.P. Sandhya sir to chair the session.
On early phase clinical drug development,
Our first speaker is Dr. Moitra. He is from Department of Clinical Pharmacology, Tata University, Mumbai. And he will talk about challenges and how to address the early phase clinical drug development. Right. So this is very important topic. What actually we are discussing about where we can have our footprint. Talking about it regarding our role in the research, especially early stage clinical trials. I think we can have very good role. Let us see what Dr. Moitra is going to deliver.
Yes, thanks for the introduction. So the first topic is given to me is the challenges. So whether the education is a challenge or is it a response for a challenge? So we'll just think about it and evaluate at the end of my presentation. So, whoever is involved in the clinical research, whether it's an investigator, a sponsor, or the regulators, so their main role will be like to understand and meet the public concern. What is the public concern as of now, or the patient concern? And then accordingly, they have to work it out. So, what are the requirements that we require for doing a clinical research? Mainly the personnel, the sites, and the patients, right? And the regulators and the funding agencies, right? So, and we require like special or the standard operating procedures to undertake these studies, right? So, but what we feel till now is the word of challenge or a grand challenge as of now. Why we say it so? Because, there are issues with reference to the funding agencies or the funds availability or the targets which are available are which are not much validated, and the stringency of the regulations and the larger duration or the bigger clinical trials. All this will lead to the increased risk for the developments. So how can we overcome those things? Either by the novel approaches, maybe like the genomics, proteomics, okay, or the gene protein expression identification, and like the biomarkers. All this will help in provide the valuable insight for the drug development, right? So like what we require, as I said, the team members. So who will be the team members? So the people or who will be assisting in the drug development. But it's a moving world and the people want to get a good positions regularly. So hiring them and retaining them in the clinical research or the team is a major challenge. So the team members should be like very much skilled and should be able to do the multitasking, not the single one. They should be able to do multiple activities. And they should be like trained in the good clinical research practices as well as trained in the protocols. And these are the daily activities which they have to undertake them, right? So keeping a person with us in the team is a major challenge, right? So what will be the team requirements? From the morning we are hearing like a clinical pharmacologist. So a clinical medicine, you should have an expert as well as some of other information also. So which are like what we call them as the common sense as well as the knowledge or the intelligence about the topics. And they should be like very much sincere and loyal because, like this being the research, if you make a mistake early, yes, prove it that, you have to show it the mistakes early itself. Otherwise, if it fails later, it adds a lot of funding loss to the sponsors. And they should be expertise in the preclinical research also. And they should be having some information about the goods, like the good clinical practices or the laboratory practices, the manufacturing and the regulatory issues also. So the team has to be like involved in all these activities and they should be well versed about the protocol or the study which they are undertaking. And they should anticipate the regulatory expectations and they should have a reserve team support, which means like it's not a single person doing the research, it's a team. So if the one person is not available in a position, the other person should be able to complete the research. Of course, the funds also. So it's not so simple thing like we keep a table like this.
we require an expert group of people to undertake these things. So next thing is like the major challenges, the practice which clinician does and the clinical research are not similar. Okay, so there is a difference between the research and the practice. And the patients will be very much reluctant to take up a molecule which is not yet completely studied. So why is there a difference here? So there is actually like a difference in the prioritization of the clinical research questions, because the person who funds the study and the requirements of the clinical research are totally different. Okay, so the stakeholder, that is the person who is funding or the institute which is funding, which leads a divergence between the priorities of the society and industry and fears of failures. So if in a field there are more number of failures, obviously the research in that area are being less taken up. Okay, so and another thing is like if most of the industry sponsored trials will be trying to get an approval rather than going for the research, basic research. And for example, like we have seen like in diabetes itself, major research is going into the type 2 diabetes when compared to the type 1 diabetes. So there is a difference here also. Next, other major hurdles in the early phase trials are the healthy volunteers. Okay, so we know like why do we require the healthy volunteers? So they'll set as a baseline to compare with the investigation. Okay, as well as they act as a control against which the other patient groups will be compared. And once this baseline is established, the appropriate dosing, safety and tolerability can be implemented and measured. So we have to involve all the ages, races, ethnicities in the research. So which is another major hurdle. So, but healthy volunteers getting into the study, early phase study is another major challenge. That is so because, like to diagnose them or to name them as a healthy is a very costly procedure. It takes into account of all the investigations, their patient's background, any other comorbidities are there. So another requirement, the requirement for the phase 1 trials will be like and get a healthy volunteers who is free of addictions. So in the trials, one of the clause which they keep is the person should not be having the caffeine. So it is very unlikely to get a person who should not drink a caffeine during the research, right? And another thing is the consenting for the healthy volunteer for the study is another major issue. And to retain that person in the trial is another problem. I mean, it's a hurdle. So maintaining them or in the study is very costly procedure. And normally, the cost of retaining a person in the early phase trials, it can runs into thousands, around 15 to 20,000 or more. It can depends upon the duration of the study, the number of PK samples, the number of follow-ups, visits, all these things. So even if say few of the visits have been lost, obviously there will be lots of deviations also. And one more thing is like keeping the data which emerges from these healthy volunteers is also like confidentially is major difficult, because the healthy volunteers may make up stories about the occurrence of any adverse events. So they may interpret in a different way. Okay, so which can give a setback for the progress of the study. So what we have to do? So maintain a database of the healthy volunteers, which most of the CROs do, but it is difficult for the academic trials to undertake this. Next is like lack of motive, the issues and the solutions, lack of motivations, educate the volunteers. Okay, and if they're hospitalized for the complications, so it can result in the reduction of the interest of the participation in the study. So evaluate the compliance risks of the participants and the complex protocols. So we have to look into the complete protocol and give feedback to the sponsors about the studies protocols.
and inadequate understanding by the study sites due to the which can lead to the poor compliance. So the sponsor should provide the support to the trials or the trial sites, right? Another option what we can use is the telepathy, which means like the telephonic visits, which allows us to view the patient's glucose data from our own computers, home-based phlebotomy visits. The data are being collected and analyzed using the wearable devices, continuous glucose monitors, and activity trackers. So which can help us in maintaining the healthy volunteers in the studies. So if we divide the studies into academic studies as well as the industry sponsored studies, so what will be the hurdles there in these two different situations? So, I mean, in the academic studies, like the scientists will be having the molecules with them, okay, which have shown and the significant effect in the in vitro studies. And the way forward for them is they have to produce that, give the molecules to the industry, or they have to go ahead to the early phase trials. But majority of the situations, the scientists are unaware of the undertaking of the toxicity studies, what to take, what not to take, and where to take. And they are very much unaware the costs that get involved. Okay. So, and one more thing is the observed efficacy in the labs may actually not replicate into the humans when it is conducted. So, like these are the hurdles. And our questions again arise whether they have taken the sensitive animals during the preclinical studies or not. And the dose range which they are claiming is not completely or translatable to the humans in all the situations. So even if all the things go in favor of the benefit of the drug, whether the molecule will be interesting for the sponsor or not is another hurdle also. And one more thing, the dose calculation should be made on the best possible scenarios, either taking into consideration of the pharmacokinetics or the the dynamic aspect, the receptor occupancy status, and all these things should be taken into consideration. Okay, so how can be this managed if they are in a academic clinical trials? You are a scientist, so they have to choose a molecule which should be like a stable one and showing the consistent benefits. Okay, and they should make a team of collaborations with the clinicians and seek their support. And they should be having the thorough preclinical as well as the clinical knowledge how to conduct the study, right? And they should have a legal expert to take care of the legal aspects of the study, right? If that is a scientist does not have an experience, they should go for appointing a CRO or contacting with the CROs, right? So they will play a major role in the document submission, making the dossiers and all the things for the trials, submission to the regulators, right? If we are taking into consideration of a pharma-sponsored trials, so what will be the hurdles? So the majority of the hurdles which we have seen previously will also be like present with the pharma sponsor also, but these are like it's somewhat different. So like the preclinical research, scientists should be available with them, and they should have a team with the legal expert, okay, and they should have trained biostatisticians, right? And they should have a team which will be retaining with them for the continuously. They should have a set of SOPs, right? They should have like logs for each and every aspect of the trials. And of course, finally, the funds should be available for the trial conduct. And what will be the protocol issues during the conduct of the trials, right? So in the protocol, right, the designing is very important. So which type of design, which type of study the phase 1 clinical trials they'll be taking into consideration, as well as whether what you call the 3+3 design they will take, or the model-based designs they will want to take it up. Which type of designs they are using? They should pre-design it, have it the statistical analysis plan prior, okay, and the causality assessment of the ADRs should be properly made, right?
So during the conduct, what will be the challenges that we face? So, in the protocol itself, we will be writing what are the drugs that have to be excluded or which are like concomitant drugs which should be avoided. So because their presence can result in the causality assessment difficult, right? And whether the complementary and alternative medications are allowed or not during the conduct of the trial is the another major information that has to be kept in the protocols. Okay. So, I'm working in a field of like an oncology. So what will be the major hurdles there or the challenges there? The success rates of these drugs being approval is very less. There is a high chances of failures from the phase 1 to 2 and also to the phase 3 and the approvals, right? Next, the cancer drugs, the issues are the disease itself is an heterogeneous one. Okay, and known temporality of the disease. So this topic, or the known temporality of the disease means the patient, what he feels, the symptomly, and the clinician, what he feels about the disease are different. Okay, the patient experiences the symptoms earlier than they are visible. Okay, and the cancer is not a single disease entity because it can spread to the other areas. Metastasis is there. Okay, and the recruitment obstacles will be there, as you know, the trial availability or the site access and the PI's willingness to accept the study. Okay, and the staff commitment and the patient's concerns about the study are also very important in the conduct of these trials, right? So these can be overcome by the use of some novel agents called molecular target agents. So what these are these are the make use of the biomarkers which will help in predicting the drug's efficacy. Okay, but there are challenges too with the use of these biomarkers because their identification as well as the qualification them as a biomarker is a very difficult aspect because we need to validate any identified biomarker, right? And we should know whether this identified biomarker is really important for the patient or not, right? And one more thing, if there is a molecular heterogeneity of the biomarker, the drug which has been targeted for this may not be working there. So another issue with the molecular targeting agents is that there is no proper animal models for the molecular targets, right? And the patients may not be willing to getting enrolled into the study of these molecular targeting agents because the effect will be produced at a later stage. It's not similar to the cytotoxic agents of the anti-cancer drugs, wherein the effect will be produced immediately, but for the molecular target agents, it will be produced at a later stage. And the MTD is not reached for these molecules. And the activity may be seen at a lower dosages when compared to that of the MTD. Okay, the toxicity profile does not correlate with the dose that is administered and also the correlation between the toxicity and the activity are less linear than the conventional cytotoxic agents for the cancers. So then what we have to do, we have to employ some surrogate endpoints which help in the completion of the study, which results in the early drug approvals. Okay. So to summarize, for the drug development for the anti-cancer drugs, so we should have to choose a good or the perfect right animal model, and which there should be an enhanced predictive validity, which can be made by the use of the computational modeling or the in vitro human tissue models, as well as the humanized models and the organ and chip technologies. And there should be good ethical considerations. So if we use an in silico models, so obviously there will be less ethical issues when compared to using of the animal studies. And the managing of the data complexity
which can be done by using the data analytics as well as the machine learning and artificial intelligence, right? So finally, the regulatory issues has to be taken into consideration for the regulatory approval. Okay, and early we have to discuss early with the regulators for easy drug approvals. Thank you. So for all these things, we need to require the education. So here, the education is not a challenge, but it is a response for a challenge. Thank you.
Thank you, Dr. Manjunath. It is an excellent lecture and full of information. I think there might be some questions from the audience. You can questions, please. Question from the audience? The role of the adaptive clinical trial design in the early phase of drug development?
Yes, there'll be obviously like an early phase in the drug development. There will be a like the importance of these adaptive designs. You know, like previously we used to do like in 3+3 design is completed, and we'll be going for the phase 2. So with the novel molecular targeting agents, so once the 3+3 design has been completed, okay, so the dose which has been providing a good efficacy, that has been taken to be forward in extension phase, what we call it as an expansion phase, wherein like the dose which have shown to be like a benefit in the 3+3 initial phase 1 trial design, they will be taken up in a increasing number of patients, which has led to early approvals. So adaptations can be happening in the various aspects.
We can go to the speaker. It gives me immense pleasure to invite Dr. Nitya Gupta Madam in this symposium as a speaker, early phase clinical drug development, and Madam will be speaking when and how to start. Dr. Nitya Gupta is well known for her outstanding contribution in the field of clinical pharmacology as an academician, and she is source of information, we can say the source of inspiration for many young clinical pharmacology in the city. So I request Madam Nitya Gupta to start the presentation. Please, ma'am.
Afternoon, everybody. As Ashraf, I'd like to thank the organizers for having given me an opportunity to be here today with my history. I sincere apologies that I'm sending a recorded talk as well as not able to be there in person, but I'm not been able to control the circumstances. So my sincere apologies. Let me begin with the phase 1 unit that we have at our department. This is a 3-level phase 1 unit at the Department of Clinical Pharmacology, supported by the Central Research Institute of Lucknow, as well as the DMC, the London University Foundation. Once you enter this unit, what you will see is an emergency start here, a very defibrillator, there is a multi-parametric that needs to be maintained, and so on and so forth. The proudest moment for our phase 1 unit came on the 10th of February 2017, when the then ACPI Director General, Dr. Pharmacology, able to that. The question that I've asked myself often over the years, the following crisis, and answer is obviously no, a lot of structure to reach there. What I'm going to talk to you over the next maybe 12 or 13 minutes is early phase clinical drug development, how we start, how we go about setting up a unit, and also a SWOT analysis and some personal perspective. I'd also like to have a disclaimer on the concept of interest. The views expressed in this particular presentation are personal opinions and not intended to discourage any organization or individual. They're also not the views of the institution that I work for and my spouse works for Cipla Limited. This is going to be the outline of my presentation. I'm going to talk about the importance of vision and visionary. Why a little bit of black and destiny plays some role in all of this. What is the role of the pharmaceutical industry? What is the role of the government of India? What is the importance of people who are within and without? What is the importance of risk, failure, and some word called stories, which I'll come to towards the end of the presentation. And I'll end with a SWOT analysis, some personal perspective, and summary of the presentation. This graph sort of tells you how the Department of Clinical Pharmacology has evolved over the years. But it is in the mid-and-the-late 80s that the Central Drug Research Institute established a CDRI unit at the Department of Clinical Pharmacology. So the first thing I think is in early clinical development is we need to have a vision. And this is the vision of the government of India, once in the mid-and-the-late 80s, to set up a drug development unit for the public sector. What's even more interesting is I've seen how a document, a memorandum of understanding, signed by the chairman of Cipla, Dr. Panelists, with the same Bombay Municipal Corporation, and Cipla actually supported, along with CDI, several beds in the clinical pharmacology unit for the long term, and this clinical pharmacology unit is then under the Department of Pharmacology. The vision is always by visionary, right? So you have Dr. It shapes the part of clinical pharmacology in India. You have Dr. Nilima Shekar, who founded the department on the 1st of June 1995. And Dr. Ula Patel, who actually established the three registry fund units that I'll show you in a bit. And this is the legacy of these visionaries, the pioneers, and this is what we have left behind for the institute, and this is what we have left behind for the country. The second or the third thing here is also about being in the right place at the right time. And I'll tell you a little bit of our story of infectious diseases. This is this showing you the little side of life in level. And this is in the early 90s where we had multi-drug resistant plasmodium falciparum in the city of Bombay. And we set up a small malaria ECD wherein the predictors pneumonitis disease at that time would be reported within 15 minutes so that treatment could be initiated at the earliest and prevent morbidity and mortality. This led us to establish chloroquine levels, and we actually published a short report on virus malaria being resistant to chloroquine. What happened after these publications is that Novartis came to us with an early phase clinical trial and co-articulation, which is a proof of concept study, co-articulation versus chloroquine in the medicine of plasmodium falciparum malaria, and in this session, in the late 90s, we had the World Health Organization who entrusted us with this study in Selvarajan and Ratindar, comparing diethylcarbamazine plus diethylcarbamazine plus alpha-beta for the management of diabetes. And this is an image of from 1997 and 1998, where this is our work in the middle of the night, select peripheral here for the cerebral parasite. I think the best here, the happiest here is the It's important here, and that's the fourth thing about drug development. You need the pharmaceutical industry. So it's the pharmaceutical industry that brings these molecules to you, and they also bring in the funding support. And I am indebted to all of these people listed on this particular slide, especially the Serum Institute of India, who've been with us for the past, I think, 14 years with the drug development of a rabies monoclonal antibody. So what the pharmaceutical industry funding allowed us to do is to set up a pharmacy. You have refrigerators, you have 24-hour power backup, deep freezers, you have pharmacokinetics lab today, we have a biochemistry lab. All of which would have been very, very difficult had we relied entirely on the Bombay Municipal Corporation for funding. Right? If you look at the growth of the department subsequently from the 2000 onwards, you can see multiple times I've seen I've mentioned Indian Council of Medical Research Advanced Center. Advanced Center for PKPD, of Anti-Infectives, Advanced Center for Product Development. Then you can see the Department of Biotechnology Clinical Research Training Center, or the Pharmacovigilance Program for the Government of India. So what's the take-home from here for drug development? The pharmaceutical industry will leave you after the completion of the projects. So if you have to sustain whatever you have built, you need the help of your institute and you need the help of the government of India. And today I'd like to place on record and the ODEC of gratitude to the Indian Council of Medical Research, the Department of Biotechnology, DSC, Ayush, and many others listed here, the John Hopkins, the WHO. All of whom have helped us to sustain whatever we have built over the years. So industry funding, government funding, and of course the institute support, all of it is very, very important to take the way forward. The next thing, and I think the most logical thing, is people that you work with. I've classified this as people without and people within. When I say without, these are people who are outside my own department. So whether it's the medicine department or the pediatrics department, or more recently the hematology department with whom we have been working. These are extremely crucial in the success of your patient health. And of course, with people like from organizations like the Bombay College of Pharmacy or the IIT Bombay or the Tata Institute of Medical Research, all of whom help you to sustain your vision. We grow with you and we grow with it. And then of course, you have people from within your own staff who stay with you for several years, and you can see that I have a staff largely of women whom I trust always much more. The next thing about, I think, early clinical development is the willingness and the readiness to take risk and the readiness to fail. And this is an ECG of a patient of an early clinical trial which we did in 1999 for the pharmaceutical industry, one particular company. This was a parenteral fluoroquinolone. And we have continuous or serial ECG monitoring at that time. And one of the things that we saw early on was the ectopic beat. Now, we did not see the ectopic beat prior to initiation of the treatment. We had ectopic beat later. The pharma company eventually abandoned the trial, but the willingness to take risk and the willingness to fail is an important aspect of early stage clinical development. This is something that I learned very early on. And finally, I mentioned right in the beginning about the summer birth for touring. Last year, on my birthday, my father gifted me this book called Incarnation by Sunil Kulkarni. It's the most wonderful book, and I strongly urge all of you to buy it. This is a photograph of MS Subbulakshmi, right? Now, MS Subbulakshmi uses the word Tori in this particular chapter, which is written by Sunil Kulkarni. Tori in Tamil actually means job, work. The early stage of development is a job or work. But one of the very interesting things which was written by Sunil Kulkarni in that particular book is that MS Subbulakshmi would actually have 3 formal rehearsals with her orchestra before she actually went on to the stage. Because he asked her this question, how come your concept is so successful? And she said that I do regard my, this is what I do, it's my dharma, it's not just my duty. So I think as a nation, we also need to think about early stage drug development as not just something that we do, but something that needs to be done, something which is done. I like the use of the word story in this particular book in the context of MS Subbulakshmi's own efforts to bring music to center stage and across the rest of the world. Coming to a SWOT analysis, strengths, weaknesses, opportunities, and threats. Being a medical institute is, I think, the greatest strength that we have here in a public sector institute. It also lends you the greatest opportunity to do these studies, right? So we have, for example, a study which we are doing, a phase-1 study on rheumatoid arthritis molecules. So having a rheumatoid arthritis OPD from where you can actually take patients and the most wonderful collaborative of the Department of Medicine, in my mind, is the greatest strength that I have to be an opportunity to do this thing myself. However, being in a medical institute where patient care always takes priority over research will remain its greatest weakness. For example, if I apply for a high-performance lipid chromatography, because I'm from a free or a private clinical department, the clinical department says, no, the testing of equipment will always have greater priority than my own equipment. So I think the public sector institutes give you strengths and opportunities, but we also need to be mindful of the weaknesses and the threats that it can pose for both drug development and research. To come to the end of my presentation, do we have the vision today to do early phase drug development? Absolutely yes. And the Indian Council of Medical Research is on a step to develop centers for phase 1 clinical trials all across India. I think this is something that will be rolled out very soon. The next question that we need to answer is, do we have molecules? And the answer is yes. And this is an example of Cipla. They invested in stem cell research in 2020, formed a strategic alliance with Therapeutic research, and the molecule is now out in the market. And they also have invested in Chain Pharmaceuticals, an early stage US-based developing country for studies in Alzheimer's disease. Now, this particular, the screenshot that I put is a wonderful article freely available on the internet written by Decoring Attard. I recommend all of you go through this whenever you have to find it. It's beautifully outlined all that the Indian pharma are doing for early phase drug development in this country. And of course, we have the Department of Biotechnology funded supported CAR T cell therapy studies for which we conducted at Pattanaik in the Pattanaik Hospital. Right? So we have the molecule and we have the vision. So finally, what is it that we need to succeed in this country? I think to succeed in this country, all of us, all stakeholders, need to borrow this ACPICon acronym. A, we need the right attitude. C, we need the courage of conviction. E, we need patience. We need to persevere. I, we need intelligent effort. E, again, we must have the courage to take risk, and we must have the courage to fail. O, we need organizational might, be it infrastructure, be it in terms of molecules, be it in terms of funding. And this comes from both the government as well as the industry. And finally, N, I think we need to answer the question, what is it that this country really needs in terms of drug development? And once we put all this together in ACPICon, I think we would have done a great job for this country. Once again, I thank the organizers most sincerely for giving us this opportunity, and apologies for not being there in person. Thank you very much.
We are very sincere thanks to Dr. Mukherjee Madam for her informative, inspiring, and useful presentation in this symposium. Thank you. And so actually, on the recorded, if you is not here, so definitely we can have discussion on it. So if anybody has any questions or suggestions, okay. I have one suggestion here. That is the early phase clinical trial. But is it possible after the invitation of ICMR, the opening of phase 1 clinical trial center in the state? So is it possible in our state also? Can you think of it maybe from the government or maybe from the private organization? Is it possible to set up one phase 1 clinical trial center? Why not? Then it is a national platform. So it is possible for any state for that matter. ICMR has asked for invited the application. They have the confidence to at least make an application, and then the expert group will do the application. Otherwise, applicable, they will go and do funding support, etc. But for that also, we primarily should have the state, have the motivation at the local level, and the confidence that it will be going ahead and implementing the project properly. And why not? For that, I think the last 2 points were very important. And willingness to fail. If that is now willingness, then only we can do.
But that readiness should come from the private organization. So whenever this symposium is going on in the private organization, so I request, basically, I don't know. Yesterday we had a discussion regarding this in Patna, and they are also saying something. But as of now, there is out of nothing, if you apply, and there is 100% chance that you will actually fail. So, we have to conclude the session. Thank you very much.
No, our speech আছে। এখানে
So, may I request Professor Prabhakar to please felicitate our respected chairperson, Professor Ratindar. Request Dr. Mukherjee. Request also Professor Moderator to join to felicitate Mukherjee. Thank you.
Next, we move on to the inauguration ceremony. So for the same, I would, at the outset, I would like to invite Professor Shantanu Kumar Tripathi, sir. It is an honor to invite you, sir, onto the stage. Next, Professor Tripathi, sir, is the president of ACPI and also the organizing chairperson for this conference. Next, I would like to invite Professor Melvin George, sir, who is the Secretary of the Association of Clinical Pharmacologists of India. It is my honor to invite the distinguished physician and professors in clinical medicine, Professor Mukherjee, sir. Next, I would like to invite Professor Jyotirmoy sir. Sir, yes. So he is the Dean of the Indian College of Physicians and also the President-elect of the Association of Physicians of India 2023-24. Next, I would like to invite Dr. Arup Chattopadhyay, sir, who is the Deputy Drug Controller and Chief of CPSCO ESO. Next, it is my pleasure to invite Major Dr. Abhijit Chakraborty, who is the Group Medical Director of Medica Super Speciality Hospital, who are the academic collaborators for this conference. And next, I would like to invite Dr. Satyavrata Acharya, sir, who is the ex-professor and head, Department of Pharmacology, DHU. I would like to request somebody to escort him to the dais. It is an honor to have you among us, sir. Last but not the least, I would like to invite Dr. Shambo Samajdar, who is the organizing secretary of ACPICon2023. Take a seat in the dais. Next, I would like to invite Dr. Qurashi to please felicitate the distinguished members on the dais. I would like to we'll first begin with the felicitation of Dr. Shabana. As a token of gratitude, we will be felicitating sir with a pot plant. Please welcome Professor Mukherjee sir onto the stage. A round of applause, please. Please give us a moment while we arrange the floor. Next, I would request Dr. Tanushree to felicitate Professor Melvin George with the Victoria and a potted plant. Next, I invite Dr. Tanushree to felicitate Professor Mukherjee sir with a Victoria and a potted plant. Next, we move on to the felicitation of Professor Jyotirmoy sir. So we have Tanushree handing over a potted plant to sir. Next, I would request Tanushree to felicitate Dr. Arup Chattopadhyay sir. We now move on to the felicitation of Dr. Satyavata Acharya, sir. Felicitating, sir. I request Tanushree to felicitate Major Dr. Abhijit Chakravarti, sir. And finally, I would like her to felicitate Dr. Samajdar. To felicitate Prabhakar sir with the award. And finally, we move on to the felicitation of Dr. Felicitation of Dr. Sukanta. Thank you, Dr. Tanushree. We shall now move on to the lighting of the ceremonial lamp. So I request all our distinguished members on the dais to light the ceremonial lamp and formally inaugurate the conference. Thank you so much. I first invite the President of ACPI and the organizing chairperson, Professor Shantanu Kumar Tripathi, sir, to share his views.
Good evening, everybody. It's a privilege and a very pleasant duty to be here on this stage and to make everybody know about the purpose of this organization, that is ACPI, Association of Clinical Pharmacologists of India. The number of trained clinical pharmacologists in the country are not too many. It's a small group, but its significance is not really small. And we understand that the visibility of this super specialty discipline is not up to the mark yet as desired, but that doesn't in any way belittle the relevance of this particular discipline in terms of its potential to extend support to patient care. At the same time, development of newer drugs. We have huge areas of our work, whether or not it is very categorically proclaimed that it is members of this discipline, they are contributing up till now. But then we have decided that it is time that we also try to be recognized. And with this view, although the discipline has actually made its journey in late 70s for that matter. So 22 years on that side and 23 years this side. So almost 44 years plus that this discipline is existing. But it is only last year that we felt that we need to have an association. professional society. And we are now, this is the second year that we have met. We are very few people in this hall, but there are a few more people online with their online presence. I must thank this organization where we are standing now, Medical Super Specialty Hospital, that they have been so generous. Thank you, Mr. Ganguly and Dr. Mr. Lahiri and Dr. Chakraborty, that you have, with your indulgence and with your support, with your kindness, that we got this opportunity to assemble here. We have started our program since early this morning, and we'll be having programs tomorrow and day after. All through since morning, we are actually deliberating on how we can make our presence felt in the society, and more precisely in the area of healthcare and medical services. So thank you for giving us this opportunity. And we are fortunate in this evening, we have stalwarts. I have my direct teacher sitting there, Professor S.B. Acharya, who was my teacher in pharmacology when I was doing my MD pharmacology. I am fortunate that one of the legendary practitioner of medicine in the country now, a very, very senior practitioner, Professor Mukherjee, who is a legend in the area of medical teaching, education also, has spared his time at a very, very short notice, and he has made it, and he has come. We are really, really thankful, sir, grateful to you. I'm fortunate that Dr. Jyotirmoy Paul, my younger colleague, but very important now in the field of medicine in the country, very important person in the Association of Physicians of India. Dr. Jyotirmoy Paul also has made it. And I also thank Dr. Arup Chattopadhyay, who is heading the East Zone of CDSCO, headquartered in Kolkata, has agreed to come. And then we have our colleague, Dr. Melvin George, who is the secretary of the organization. Dr. Shambo is taking a very lead role, playing a lead role. And besides our colleagues sitting here, very senior, Dr. Dhaneria, and then Dr. Shoibal Mukherjee, and our colleagues there. So it's a great journey. We are pledging to start again, trying to have introspection about the discipline, what its fullest potential, and how we can actually contribute in the field of healthcare and medical practice, and also new drug development areas, regulatory sciences, etc. So I must thank all of you that you are showing so much of interest, and hopefully in another couple of days when we come to the valedictory session, we'll feel a little more confident and more comfortable to take this relatively less known discipline, how we can go forward together. With these few words, I leave it here, and it's a small group, very humble and modest attempt, but then our goals are very wide and very high. Our ambitions are very high. With these few words, thank you again. I stop it here. Thank you.
Thank you so much, sir, for your encouraging words. Next, I would like to invite Professor Melvin George, sir, to speak a few words.
Thank you, Dr. Swayze. Respected dignitaries on the dais, off the dais, professors, and my fellow colleagues. It's indeed a privilege to stand before you on this occasion of the second national conference of the ACPI. Firstly, I think we should congratulate the organizing team led by Dr. Shambo for this massive effort he's taken in the last 1 month to pull in so many things and to make this event happen in Calcutta. And let's give a big round of applause to Dr. Shambo and team. for pulling this off this weekend. We all know that clinical pharmacologists are doing amazing work silently in different parts of the country, be it in regulations, be it in academics, be it in research. A lot of people are working in the research domain. And there are a lot of people, particularly in the state of West Bengal, who are into improvising patient therapeutics. And that is something that is coming up of late, and I'm sure this discipline also will grow in a big way in the coming days. And it is so important that even as the subject grows and we try to understand how best we can do in our own specialty, it is also important that we as seniors should give to the upcoming generation. And that is how a society can grow. The point I'm trying to make here is that ACPI can grow only if we all join together and work together for it. It cannot stand by itself. There was a lot of discussion in the previous session about clinical pharmacology and the way forward. I just wanted to say one thing, that a discipline of clinical pharmacology is definitely a passport, an entry ticket to reach somewhere, to reach a good reputable organization. But finally, it is what we do with it that matters in the years ahead. And that comes only by our own initiative, our own hard work, our own efforts that we take to see that whichever stream of clinical pharmacology that we choose, we go in, we dwell into it and become masters of it, because no one can be a master of every discipline subset of clinical pharmacology. We have to identify what is our niche area and become a master of it, so that the world recognizes that you are a master of that particular field of clinical pharmacology. So we are sure that in the days ahead, this organization will grow in leaps and bounds, and that will happen only with the efforts that come from all of us. So I wish the all of us a big success in that. And once again, want to thank Super Specialty Hospital Medica here, the team organizing the management of this hospital for graciously giving us the space to do this event. And I would also like to thank all the members who have come from different parts of the country, as well as the state of Calcutta, West Bengal, to be a part of this event. And special thanks to all the dignitaries on the dais to come and bless us with your presence and graciously being part of this event. Thank you all.
Thank you, sir. Next, I invite Professor Mukherjee, sir, to kindly speak a few words.
Good evening, Mr. President, Professor Shantanu Tripathi, dignitaries of the dais, colleagues and friends from the discipline of clinical pharmacology and therapeutics. It gives me enormous pleasure and privilege to be here to share some of the observations as a clinician, where we are benefited by your contribution. Second annual conference is scheduled here. That is a great news. And I thank Dr. Tripathi and his associates for organizing this conference in a new building in the medical hospital. Clinical pharmacology and therapeutics has made a phenomenal progress since 1960, when I was a student of medical college. At that time, we are only taught how to make pills, how to make mixtures, and basic knowledge of pharmacology. I do not hesitate to say most of the theoretical classes were boring.
in practice, in practical laboratory, we had to go all through this as a student of medical college through this. But since that time, over 50 years, I think we have made real advancement in clinical pharmacology and therapeutics. At that time, the pharmacology is a subject which is being examined in third year class in the university examination. But now you have got the association, you have got very distinguished professors, very distinguished research workers, and whole-time workers in the field of clinical pharmacology and therapeutics. Pioneers of clinical pharmacology and therapeutics have major contribution from the science of pharmacology with a newer molecule acting on human biology, which is all the more complicated. With restorative effects, what we achieve in clinical practice without possible damage. In spite of that, we face adverse reaction. In spite of that, we cannot predict adverse reaction. And in clinical practice is a question of if and but. And in that case, that we do not know. I can quote an example. About a week back, a patient came to me with hypertension, diabetes, obesity, but in addition, they had a very large prostate. And he has been prescribed usual drug for the prostate. After using the prostate, the patient came to me and he told me, "Doctor, I have become completely dry. And all these prostatic drugs for the prostate, I looked in the literature on the spot, and I find in 17% cases, there is an ejaculation failure, which was new to me because we are having so many prescriptions over a period of years. We never faced a problem, but still it does happen. We cannot have any prediction of any side effects. Another case we have faced with NSAIDs coming out, the toxic epidermal necrolysis with a life-threatening situation. So adverse effect is one of our nightmares, and we cannot predict beforehand, for which we need pharmacogenomics. And pharmacogenomics is a subject which can help us to go for a precision in medicine, a personalized medicine. And that is what we are thinking of. All these new avenues in clinical pharmacology and therapeutics, like pharmacoepidemiology, pharmacovigilance, pharmacogenetics, are important assets in clinical practice. If we can have those things in the armory of practice of a clinician, I think the patient will be benefited. With the advance of genome sequencing, many parts of the world have got. This is one of the important steps to achieve personalized medicine. Still, I can say we don't have that facilities in the city of Calcutta. I think we have got active Professor Jyotirmoy Pal. So pharmacogenomics, one of the important ladders to achieve more perfection in our clinical practice. All the time, you have seen many a time economics of pharmacotherapy. If you look at the private hospital and newer molecules, how costly they are. and particularly in patients of cancers, in patients with a severe autoimmune disease, in patients with obscure infection, we are at a loss. Either it is not available or it is so costly beyond the reach of the people, common people. But I can say, in our practice, in autoimmune disease, it is because of your work, your discovery, your research, biosimilar has been accepted globally. And the biosimilars, we are using it. And this is accepted all over the world. And this is a money saver for the long-term disease where there is no cure, but only we can manage. So obviously there are certain issues which still left out. And in our practice, on one side, we are greatly benefited, but some patients cannot afford it. Now the question has come. Even National Medical Council has sent a gazette about the use of generics. It is a formidable task to use the generic medicine in private practice or in the hospital even. But still, it is one of the important steps. But it has got certain lacunae. How sure you are maintaining the quality? Then on one side, you are saving money at the cost of the people. A time may come if we go into this, one group of people who are privileged, they use the trade names. On the other side of the people, generic names with a doubtful quality. I do know there are some researches about the comparative study of the trade drugs and the generic drugs, and blood concentration was found to be in order. But these are very few. So we have got limitation. But if West or developed country can use the generic name, why don't you use this? Why don't you improve the quality of drugs uniformly? There should be some kind of homogeneity than heterogeneity to offer the best quality cover. All the time we talk about the accessibility. All the time we talk about affordability. And at the same time, we are having a dubious standard for the different kinds of. Who knows that what kind of generic drugs have got the high quality comparable to the trade name. So there will be in a divisive policy, I think it needs to be looked into, but at greater depth, so that you can practice. Otherwise, there may be rules and regulation. This rules and regulation came in 2014, if I remember correctly, but it is not operable. And now today, we have got the same problem, but it is a directive for all the doctors, be it a consultant or junior doctors, to write this. Even we have got a practice, clinical practice, where homeopath and alternative medicine are in vogue. So obviously, there will be very mixed picture in the prescription. And more so, EHR are coming, electronic health records. And obviously, this is again a burden. How many people in the rural setup can go for the EHR for this kind of prescription in a dignified way as it is expected by National Medical Council? So obviously there are limitations, but thought is always highly regarded, but with some exceptions. So obviously in a situation like this, we are in a dilemma, but dilemma is there, and dilemma helps us to improve ourselves. And that is the way we can get better quality drug for the betterment of the patient. Because on one side, we need a personalized medicine. At the other side, we need restoration without adverse effect. I think this cannot go together unless we have a definite step, uniformity, and both in the urban setting as well as rural setting. In that way, we can improve our quality. And lastly, I have got one small request. Clinical pharmacology and therapeutics have changed the name to CPT. Why they should not come in the practice of decision making, in clinical practice in the hospital? As for example, today's antibiotics, there is a crisis. Nothing coming in the pipeline, no new antibiotics. And we are the doctors who have created as monsters antibiotic resistance. So this antibiotic resistance regulation, not only in papers, but in action. Then my request, or if we can make a headway as a combination of network between the clinicians and clinical pharmacologists and therapeutics. We also learn from you, you also learn from us how to adjust the drugs in the clinical setting, because all human beings are all different. They are not homogeneous. And you cannot predict what kind of reaction, what kind of action, and you cannot cure. In the chamber and the clinic, patient all the time asked, Dr. Babu, is it curable? Can you cure it? But how many diseases you can cure? Hardly 20%. 80% are manageable. And that's why the idea, so in the community discussion or community teaching also there, except malaria, typhoid, pneumonia, most of the disease are not amenable to cure. But this is a bad sound. Only thing when the doctor comes to the private clinic and hears from a doctor, I cannot cure your disease, it is a baffling. He might change the doctor or change the pattern of the question. So obviously these are some of the limitations, and my own interest, I do not know whether it will happen in my lifetime, but there is a network between me and yourself. And we have a network of knowledge, interaction. You correct me, I will correct you. I may be knowing the human being, you may be knowing the chemicals, what we are administering. So I think for betterment, one day we can shine that all the clinical pharmacologists has taken some degree of responsibility for taking clinical decision and correcting ourselves so that we can avoid adverse effect as much as possible. We can avoid drug resistance, which is happening. And these are all costly complications in our lifetime. I think in your conference, there will be threadbare discussion, but it must be combined with some clinical decision making, and what are the shortcomings? Can we plug some of them so that we can make a better globe, better doctor, better patients, and better situation. Thank you all for your kind success and all your efforts to make the second annual conference in Calcutta a really glorious one. Thanks to Tripathi.
Thank you so much, sir, for sharing your deep insights on what the expectations are from our discipline from a clinician's perspective. Next, I would like to invite Professor Jyotirmoy Pal, sir, to speak a few words.
Professor Shantanu Tripathi, organizing chairman of this conference, Professor Mukherjee, our teacher, mentor, Dr. Shambo Samajdar, organizing secretary, and all the dignitaries in the dais, my friends, students. It is really a privilege to be in the inaugural dais of National Conference of Clinical Pharmacology. My presence and presence of Professor Mukherjee, we belong to the physicians community, I don't think is odd. Rather than it is quite significant. Because there is a now ongoing debate, clinical pharmacology, whether it is the more closer to pharmacology or more closer to clinical medicine. So, as Sir said very rightly, in our student days, pharmacology means class of Professor Madan Das, stand up, what is the dose, side effect, if you cannot, he will scold you. So it was like a nightmare, basically. But in the next 30 years, the scenario has changed. The domain and extent of the clinical pharmacology, now something different. That know Dr. Samajdar very closely working with me. He knows very well. In our medicine conferences, every time we keep a session on clinical pharmacology. Because I can give you why. Why for the physicians, now this subject is more important to physicians rather than traditional pharmacologists. Because I give just one statistics. Just now coming from Haldia, there is a geriatric medicine program. And there was a discussion on geriatric medicine. That one data, 30% hospital admission of a geriatric patient are due to the side effects, not due to the disease itself. So proper application of the drugs, its timing, its dosing, because now we are physicians with patients have a multiple comorbidity. So polypharmacy is not a is a very common nowadays to the physicians. And also when we are dealing with a patient with multiple comorbidity, particularly the geriatric population, which is the percentage is ever increasing, may reach to 30% in as predicted in 2050. So drug dosing and drug spacing, drugs timing, the understanding of the drug-drug interaction is very important for the physician. Otherwise, not only the patient will not get the desired effect, also will suffer from so many side effects and will be admitted in the hospital and even can lose life. So understanding of the clinical pharmacology, it should be the bread and butter in the coming days to the practicing physician. That is why I feel this clinical pharmacology, Sarah was telling, it is not growing. I think you should move more, do more conferences with the physicians, maybe physician internists, maybe with surgeons, with the gynecologists, and in that way it can only grow. And in last week we have a program, Dr. Samajdar, students that participate, we keep a session on all the different type of competition of the clinical pharmacology. He has conducted very successfully, and our PGs, they participated in a large number. So now I think clinical pharmacology is basically the in between clinical medicine and pharmacology, more closer to the clinical medicine. And there is definitely a demand from many of you that in our Association of Physicians India, the largest organization, whether clinical pharmacologists can be the life member. Till now, as per constitution, they are the associate member. But definitely, I got some application and some request. Now our constitution committee is working. In the next meeting, definitely I will put forward. Let us see what I can do. And my personal feeling, it should be included as a life member, because I feel like clinical hematology, the cardiology, nephrology, clinical pharmacology, it should be an integral part of clinical medicine. Recently, we are developing one book, Diginar, by the JP Brothers. 30th September book will be launched for the PG student. A significant portion we have kept for the clinical pharmacology. And Shambo is the section leader of this section. I think he has involved, I don't know whether many of you, this is a large section, probably for all over India. I told him to include the many clinical pharmacology. Probably he has done it. So I hope this is the way the clinical pharmacologist needs physician. I think more the physician needs clinical pharmacology. So I think clinical pharmacology and internist will proceed further, go together, will go hand by hand, and the new domain will start, and the physicians can do the best prescription, patients can get the best benefit. Thank you for inviting me. Thank you.
Thank you so much, sir, for your inspirational thoughts. Next, I would like to invite Dr. Uru Chattopadhyay, sir, to speak a few words on this speech.
Respected guests, honorable respected dignitaries on the dais and of the dais, all the respected guests and delegates on the present on the other side of the chamber. I represent CDSCO, who is the National Regulatory Authority in India. As a part of our job in the CDSCO, we are engaged in the regulation of trial, various stages of clinical trial, starting from the phase 1 to phase 3 to phase 3 and even the phase 4 clinical trial in the country. Also, in the during the approval process, we also we are engaged in the approval of various new drugs that is first introduced the first time in India. In this, during the approval processes of the drugs, there are various expert committees, subject expert committees in the various fields of the medicines, therapeutic categories. In these categories, we engage various experts from these various therapeutic categories. In these fields, there are always pharmacologists members, and it is mandatory for our meeting that there should be a pharmacologist present. At least there is a pharmacologist, the meeting should not be going on. There are also other engagement like PVPI, Pharmacovigilance Program of India, and the Signal Review Panel. From there is a important program for us where the side effects are being monitored by us, and important side effects from even from the very old molecules are being reviewed, and the side effects whenever their signals are being side effect signals are being generated, these are being alerted to the media, and in these various panels and expert committees, there are always the pharmacologists are members, and we are always reach out to the pharmacologists friends or doctors and friends or for these valuable inputs. We also have a serious adverse event or a casual death analysis committee. India is the only country in the world where there is a compensation for serious adverse event or death during the clinical trial. If there is a serious adverse event that occurs during clinical trial or death, that needs to be reported to the regulator by ethics committee and principal investigator, and that casualty is being analyzed, and if it is analyzed by a committee, and that if that death or serious adverse event is being reported to be linked to that trial or study drug, there is a formula for compensation, and by calculating that formula, a compensation is being given to the family member of that trial participant, and that trial participant is compensation is in maximum compensation is around 80 lakhs. Dr. Tripathi, Professor Tripathi is a member of our various expert committees from the ACPI committee and our PVPI committee also, I think. So in this various, also we have various GCP inspection, the clinical trial, ongoing clinical trials, we conduct inspections, on-site inspections. In these on-site inspections we need experts from the concerned fields. So we reach out to the experts, pharmacologists, experts from the therapeutic experts from the respective fields, and during the inspection of the trial site, we take their help. So as a regulator, since we do not have expertise in all the fields, we have limited expertise. We always take help of the. We are very much indebted to the help of the pharmacologist help and other therapeutic expert from the other therapeutic experts. So this is my great pleasure to be a part of this gathering, and I am honored to be here.
So I feel honored and I congratulate for this gathering. Thank you.
Thank you so much, sir, for taking time out to be among us today. Next, I invite Major Dr. Abhijit Chakraborty, sir, to speak a few words on this.
Good evening to the dignitaries on the stage and my friends sitting on the auditorium. And welcome to the new oncology block, or what we call the D block of our hospital. This has been constructed and finished just a month back, freshly inaugurated. And still we are on the job of completing this building. And if I'm not wrong, this is the first conference being organized in this auditorium. And we have no hesitation in sharing our resources with Dr. Tripathi, who is a valued member of our institutional ethics committee. He keeps on guiding our clinical research. I saw your theme, and I just make a small comment on it. Relevance you have, impact you have started making. But then the challenge that lies in front of you to give you visibility. I will take a minute to recount one incident. That I am from the armed forces background, and one small incident that it was Kargil war, where we lost a good number of our soldiers and many of them bled to death. So we decided that in future, we have to stop this undesirable death or unwanted death that happened from uncontrolled bleeding. So we looked out and we found out that the American Army had already initiated a bandage called a chitosan bandage, which immediately can stop or prevent hemorrhage, particularly of the limb. This is a bandage which is created out of a particular product called chitosan, which is found in a sea crustacean shell. And we were given the task of developing this bandage, and I was one of the project team members. We procured chitosan from the United States Army. We went into CDRI Lucknow. We tried to develop this bandage, but we couldn't go beyond the animal study model. Neither could we develop this model or this bandage, nor could you afford it, nor could you purchase it. The point I'm trying to make is that you are sitting in the oncology block, and as Professor Mukherjee just now told us, that affordable care. So that's the challenge. How do we provide safe, rational, affordable care to the patients who are coming to this block to take oncology services? That's, if you can, participate in drug trials, clinical research, rational use of medicines, safety, medication safety of care at your chemotherapy daycare centers. Possibly that's when your specialty will get the visibility that you reach deserve. Jai Hind.
Thank you, sir. Next, it is my privilege to invite Dr. Satyavrat Acharya, sir, to speak a few words. I'll be handing over the mic to you, sir.
Thank you very much for putting me here in the dais to speak few words. I am a basic pharmacologist. So as I heard down that during the last 30 years, the method of teaching of pharmacology used to be a bit different. The dose, and up sort of thing. But nowadays, the method of teaching of pharmacology has grossly changed in most of the medical colleges. And the teachers try to emphasize on the pathophysiological basis of the use of the drugs.
But in spite of all these efforts, what I feel is due to indiscriminate use of, or rather rampant use of medicines and gross occurrence of antibiotic resistance, and most important thing is unnecessarily multi-drug prescriptions. This scenario happens not in super specialty areas, but happens in the village-oriented or small town. This I faced personally when I had the opportunity to work in telemedicine. I used to go there to the village for twice in a month and found there's a lot of folks, lot of even health center doctors. They use multiple medicines. There are 3 antibiotics. And use of the drugs which are for the bronchoconstriction and produce hypertension. And used in hypertension, which is a side effect of bronchoconstriction. Patient is having bronchitis or COPD patient. This type of scenario happens in spite of this type of new method of teaching. Of course, this new method of teaching is not widely followed in all the medical colleges in India. But in this meeting and in this presence of the delegates, what I feel very important is, as a clinical pharmacologist, you have the responsibility and commitment to the society to ensure that evidence-based use of medicine, which is lacking these days. If you go to the ordinary practitioners or in the village-oriented place, they use multiple drugs. There are at least 10 drugs for a particular disease, no basis. This is the scenario. So it is, I think, primarily the responsibility of the clinical pharmacologist to ensure that the evidence-based use of medicines in different disease conditions. Thank you.
Thank you, sir. Finally, I would request Dr. Shambo Samajdar, the Organizing Secretary of ACPICon, to speak a few words.
Thank you. The respected dignitaries on the dais, Professor Melvin George, Professor in Clinical Medicine, Dr. Mukherjee sir, Professor Jyotirmoy Pal, Dr. Arup Chattopadhyay, Major Dr. Abhijit Chakraborty, Dr. Satyabroto Acharya sir, and my mentor, my guide, Professor Shantanu Kumar Tripathi sir, and the respected delegates who are off the dais. So when we start our daily prayers, offerings to God, specifically the Purushottam Narayan, so we often use one mantra, that is Om Sahasra Sirsa Purusa Sahasraksha Sahasrapat Sabhuming Vishwato Vittva Attatishta Dasangula. So this is a very important slope from Rig Veda. And what is the meaning of that? I had just translated it in Google and I get the meaning. The Supreme Being has 1,000 heads, 1,000 eyes, 1,000 feet, pervading the universe on all sides. He lay beyond it to the extent of 10 fingers. So generally in a spiritual context, this is everything. But beyond this, that means beyond everything, they are telling the uniform God is like that. I believe I am really fortunate that I belongs to one speciality which also have that Sahasraksha, Sahasrapat, the thousands of dimensions, thousands of paths one can go from this particular discipline. It could be regulatory perspective, as our respected Dr. Arup Chattopadhyay was mentioning. Our Melvin George sir was mentioning about the research possibility, and also Dr. Abhijit Chakraborty was mentioning about that. And of course, Dr. Shottobroto Acharya sir was a veteran academician, also mentioning the importance of clinical pharmacology in building doctors, in building physicians to treat crores of populations. So that is important. Again, another aspect which was touched beautifully by Professor Sukumar Mukherjee sir and Professor Jyotirmoy Pal sir, the direct patient care, what we can provide from this discipline by reconciling the therapeutics with the help, with the conjointly with the clinicians. So that is another important aspect. So there are multi-dimensional facets we have to serve community, and we are really proud to belong to this type of community. I am really thankful to all the respected faculties who are present today, who are the dignitaries who came today. As Professor Jyotirmoy Pal was mentioning, already in the API, there are multiple projects are ongoing to improve the therapeutics knowledge. And very recently, we had contributed with more than 45 OSCEs with the help of different clinical pharmacology departments, starting from Nizam, starting from KM Mumbai, also JIPMAR Pondicherry. Their clinical pharmacology department had helped us to build OSCE questions for our MD medicine postgraduates. So it is a really great effort by Professor Jyotirmoy Pal sir to integrate clinical pharmacology in clinical medicine. So really thankful to sir. At the onset, I also thankful to my department, that is Department of Clinical and Experimental Pharmacology at School of Tropical Medicine. Professor Shantanu Munshi is the current head, sir is there, and Dr. Chiranjeev Bakchi is there with all our colleagues, our DM residents who had helped us to make this event successful. And also I am thankful to Medica, specifically Mr. Lahiri, Dr. Abhijit Chakraborty for giving us this opportunity. I am really thankful to InnovoCare Health of Solution, who had helped us entirely during this preparation. And I want to mention R&R. You know, the R&R is a very famous movie now. Really, this R&R, this Rohan Tripathi and Ranodip, these two R helped me a lot in the to make this event success. Most probably it is going to be successful. There are multiple flaws. I accept that, and that flaws are due to my own. I'm taking that in my shoulder. There will be more flaws also. Please forgive us for that. Thank you. Hope you will enjoy the next 1.5 days with different types of tests in this academic phase. So thank you once again.
We shall end the inauguration ceremony with the singing of the national anthem. I would request all our participants and distinguished guests to please stand up for the national anthem.
Thank you, sir. Thank you, Shambo. जन गण मन अधिनायक जय हे भारत भाग्य विधाता
पंजाब सिंध गुजरात मराठा द्राविड़ उत्कल बंगा सिंध हिमाचल यमुना गंगा उत्कल जलधि तरंगा तब शुभ नामे जागे तब शुभ आशीष मागे गाहे तब जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे
With this, we come to the end of the inauguration ceremony. Thank you all.